especially DPP-4s, SGLT2s, are quite good and safe to use in the background of hypoglycemia. So this is what I spoke about all this while now. Age, advancing age, you look at what are the drugs can be given, metformin and DPP-4s. And BMI, whenever you think about, you look at the GLP-1s, RAs and SGLT2s, that is with metformin. And CKD, SGLT2, DPP-4, metformin up to 30 or up to 45, 44, you need not do any cutoff. CKD, advancing CKD, SUs, GLP-1 RAs, limited use, AGIs can be used, glinides can be used, that's something remember. Duration of diabetes, whenever there is increasing duration, it's difficult to treat. Insulins, GLP-1s, SGLT2s, what you should look at. And when you look at the established CVD, that is E, GLP-1 RAs, and SGLT2, CVD, CKD, you could think of GLP-1s, SGLT2. Pioglitazone definitely is not safe, especially subclinical heart failures, which most of us don't screen, so don't try to initiate. And of course, the glimepiride glycoside preferred for over conventional insulins, because the SUs, because of the cost, we may have to consider in the established CVD in patients cannot afford. As I said earlier, DAPA can be now affordable to literally all our patients. The finance, you need to look at SUs, metformin, glycemic status worsening, insulin, SU, metformin, GLP-1, in the order you can use this for GA status, and hypoglycemia, insulins, SUs, you need to be clear about the warning about hypoglycemia, you need to educate the people. So when you see a patient in your clinic, prescribe LSM, lifestyle modification first, to all the patients irrespective, pre-diabetes or diabetics. Metformin, the most patient should be there, as I said, 99% of our patients should be there. Identify 2 or 3 most important concerns for that particular patient in that ABCD, whether it's a cost, whether it's age, whether it's hypoglycemia, established CVD, you need to look at those points and identify the best choices in the outer ring, then further fine-tune whenever they come back for this. And these guidelines have been validated by this study, and you can see 780 patients data where most study findings of anti-diabetic drug prescriptions were in consistency with RSSDA therapeutic wheel. That's the validation for this study. Now, let me end with 1 or 2 cases. 48 years old male businessman, diabetic, 3 years, metformin 1 gram, A1C is increasing, patient is declining injectables, he is obese with 32, ECG is fine, that means no CVD risk factors. So this is what in a busy OPD you need to consider. His age, he is a businessman, 3 years old, not very long, 8.4%, declining injectable, BMI 32. So you apply the RSSDA wheel. So these are the factors you need to look at: the age, BMI, duration, and is only for oral therapy because the patient himself is refusing for the injections. So in the wheel you can see here the ABD, what you choose, and this is the hierarchical thing, DPP-4, AGAs, and the end also you have this, which are the common drugs relevant to this section. So this is how you use the wheel whenever such patients come up. So this is the options available for this patient. You can escalate metformin to 2 grams, add a SGLT2, because in the Indian context now, it's very cheap drug now. You can easily add on because remember the BMI is 32.5, and DPP-4s, SU, low dose PIO, these are the other options if there are some contraindications. Good patient education for better control, and on the right hand side you can see the choices based on the BMI, and of course GLP-1 is injectable, but still it's a good one. Now second case, 70-year smoker, documented ASCVD, 12 years duration, 8.6 A1C, microalbuminuria plus, so he's already got complications. So what I highlighted in the red are the factors we should look at. This all takes just 2 minutes in your history and examination wise, nothing literally, and this is how you come to conclusion with your busy OPD days also, and you consider in this man age, BMI, duration, established CVD. So you need to use ABDE, and this is what is your slide where it uses ABDE, and look at the drugs which are there, and this is how you choose based on the risk factors of this patient, and overall this is how you look at the 1, 2, 3, 4 preferences, and overall SGLT2 will stand out for this patient who's got established, and GLP-1s are, if is affordable options, injectable acceptance, all that you need to look at, and this is what you do with the, and of course the CV evidence, for the lack of time we'll skip on this, but you know all these evidences, and these are the evidences which we have taken when we are building this wheel. And the last case would be 46-year-old male, sharp serviceman, 3-year-old diabetic, A1C 9.1, EGFR is okay, and reluctant on insulin and therapy and injectable. Again, here the finance, because he's a small-time shop worker, finance and glycemic status are the 2 concern here, and you use the F and G, the finance and the glycemic status, and this is where you end up with SUs as the number 1 choice. SGLT2 in India now, as I said, affordable, you can still have this as a second line one, and this is where you end up with having this. Of course, the ADA guidelines clearly say that the cost-wise and the efficacious-wise, metformin still stands out, as I said, and SGLT2, intermediate and high, GLP-1s, intermediate and high, DPP-4s are quite good. Insulin has got the highest glycemic efficacy, and cost, of course, again in our country, many patients can afford. So early combination therapy, dual or triple, can be considered if the A1C is high. That's RSSDA recommendation. So thank you very much for patient hearing. And again, I think I'm on time.
So thank you very much for a wonderful talk. And also thank you for sticking to the time frame. Your talk was quite informative and educative, sir. So we'll have a couple of questions from the audience and one question from the sir.
Yes, sir.
I'll ask one question.
Please, sir.
Dr. L. Srinivasmurthy has given us very good, actually, therapeutic wheel of RSSD in Indian context. I'll ask one question. Actually, metformin, we can give up to 2 grams. In that way, what are the other 2 options we can combine and give it to our Indian patients? And what is your experience?
So I think metformin and SGLT2s does a great job now because of its affordability. There's no doubt on that. And SUs are the other ones which can bring down when you think about bringing down, because SGLT2s are not robust in bringing down the A1C, but the SUs definitely do that job. So metformin and SUs.
Drug combinations?
Fixed drug, FDC. I'm talking about FDC of SGLT2 and metformin, too good.
So even gliptins also, they combine.
Gliptins also are there, sir, but weight part do not require, because most of our patients are truncal obesity. So I would prefer SGLT2 until unless the A1C is not very high, like 9%, 10%.
Now almost all companies are coming with the metformin, SGL2 and gliptins combination.
Triple drug.
Triple drug.
Triple drug FDCs. Again, patient compliance adherence increases. I have done 2 of the trials for 2 of our pharma, the triple drug. They're good, efficacious, tolerability, all that is quite good. And last August, FDA has approved the EMPA triple drug combination. The first time the ADA guidelines and FDA has approved the triple drug combination.
Thank you, sir.
One more point is, nowadays, even our FDA, we are not waiting for that. In our health and family welfare, our own
Guidelines.
our own drugs and our own country will recognize the first, and then others will follow.
No, we are very good at that, sir. As I said, the metformin SUs, highest selling combination, now they are recognizing about SU. We've been using that from last 20 years.
In that way, our 3 drug combinations in India, doing research, and FDA approval later, like that?
Yes. Sir, I think you had a question.
One question from audience.
I wanted to know about your experience about hydroxychloroquine, because that is one drug which is approved in India for use.
Yes.
Particularly, I find that it is helpful in patients who are on insulin. It prevents insulin degradation, reduces the insulin requirement, and it has action as an anti-inflammatory medicine. In your practice, do you use it?
I definitely use it, sir, especially for patients who have these vague body pains. It works wonderfully well. The robustness of HbA1c is very less, but definitely it works for this vague body pains, especially females who come. It wonderfully does that pains because it's anti-inflammatory. Very good drug for that niche patients. I don't use it very regularly, but when the insulin requirement is very high, also like a sensitizer like PIO, if you use this, definitely it comes down.
I think we're done with the first session.
Thank you very much for all the faculty. We'll have a group photo. Fine, we'll move on to the next presentation. To chair this session, I will request Dr. Anil Kumar, our past president of KRSSDI, and Dr. Venkat Krishna Rao is not there. Okay, so the speaker would be Dr. Lakshmi Nagendra. Dr. Anusuya Shetty also can join us for the chairing the session. Yeah, over to the chairpersons. And the topic is very apt. I know a lot of work has been done by Dr. Anil Kumar for this, and over to the speaker and the chairperson. One point, we are already on YouTube and Facebook Live, and we'll be triggering questions at the end of each session on your WhatsApp portal. You can please answer it. There will be a leaderboard which will be flashed periodically.
Hello. Yeah. Hello. Hello. Welcome to KRSSTI. I think after 2 years we are having one more physical conference. Last 2017 in the same venue we had the conference, and this time we are having this conference in Bangalore. So I welcome Dr. Lakshmi Nagendra, who is the Assistant Professor, Department of Endocrinology, JSS Medical College. And she has won University Gold Medal for highest marks in DM Endocrinology and several research awards, the ESI AV Gandhi Award for Excellence in Endocrinology, and Best Research Paper at ISB MR 2020, and reviewer of several journals in osteoporosis and publications in several journals. Our research interest is women's health, osteoporosis, and GDM. Over to Dr. Lakshmi Nagendra.
Thank you, sir. At the outset, a big thank you to KRSSDI for this invite. It's my first time at KRSSDI, and speaking after Srinivas Murthy sir and before Arvind Jagdish sir is quite an uphill task, honestly, but I'm going to try. Anil sir is the chairperson, so many help with questions, hopefully. And so my topic for today is diabetes in young, what we should know. So whenever this topic is mentioned or spoken about in conferences, one incident that comes to my mind is I had a young patient about 32 years old who fit into the classical description of type 2 diabetes. So I saw him diagnosed with type 2 diabetes, wrote type 2 diabetes in his prescription, and he was well treated. But then again, his older brother, who was about 36-year-old, presented to me. He did not fit into the classical description of type 2 diabetes. He was quite lean and didn't have any markers of insulin resistance. So it was a busy OPD, about 40 patients. I did not have the time to, come to a diagnosis then. So I wrote diabetes in young and admitted him. So after this, his younger brother came to me and said, "Madam, I'm younger than him. I'm 32 years old. You labeled me as type 2, but my older brother is 36 years old. You wrote diabetes in the young." So this prompted me to actually look for the definition of diabetes in young. So we all know maturity onset diabetes in young is less than 25 years by definition. But by this definition, suppose I were to get diabetes today, I would not fit into the diabetes definition in young definition. So I looked more for papers which would enable me to fit into this definitions if at all I were to be diagnosed with diabetes. And thankfully I found a paper that diabetes in young has been classically defined as onset of diabetes less than 35 years of age. So a lot of concerns when this diagnosis is brought about. Patient has only one concern: do I need to take insulin? If so, should I take it forever? But we doctors have a lot of concerns. Is this type 1 or type 2 diabetes or something else? What complications are possible? Can I safely stop insulin? Should I order any special tests, C-peptide, antibody, or genetic testing? Or is there a benefit in classification? So the broad classification according to ADA, type 1, type 2, GDM, and others. But type 1 and type 2 is still the most common cause of diabetes in India, with both these types accounting to about 89 to 90% of diabetes. But why is it important to identify the type of diabetes, other types of diabetes apart from type 1 and type 2? So this is a paper that we published in 2019. It was a follow-up study with patients with Cushing's syndrome, followed up for a median of 6.5 years after bilateral adrenalectomy for various indications of Cushing's syndrome. And diabetes remission was seen in close to 25% of patients after the diagnosis of Cushing's syndrome. So that's a very, very high percentage of diabetes remission. And improvement in glycemic parameters, where we could stop insulin or bring down the dose of OHAs, was seen in close to 75% of patients. So very, very important to classify the type of diabetes. And this takes only a good history and examination to come to a diagnosis. Age of onset, weight of diagnosis, presentation, did the patient present with decay, weight loss, family history, what is the probable inheritance, if already on treatment, insulin or OHA, and if insulin free, for how long. Of course, the history of alcoholism, gallstones, recurrent abdominal pain, steatorrhea will help in coming to a diagnosis of type 3C diabetes or pancreatic diabetes. Secondary diabetes, Cushing's acromegaly from history and examination. Deafness and visual impairment is something that we don't ask about routinely, but it is very important to diagnose mitochondrial diabetes from deafness and visual impairment, which are not very rare. I have come across many patients in my clinical practice just by asking about history of deafness or visual impairment. Of course, polyuria, infertility, and drug intake will also help us in diagnosing the other causes of diabetes. Examination, the routine anthropometry, signs of insulin resistance, acanthosis, skin tags, subcutaneous fat wasting is something that we don't routinely look for, but this will help in diagnosing lipodystrophy. Hepatomegaly, androgen excess, look for clitoromegaly, and of course, striae, proximal myopathy, coarsening of facial features to rule out Cushing's or acromegaly. So, goal of history and examination is to see if the patient has insulin resistance or autoimmunity. So, all these types of diabetes are a continuum really. So insulin resistance goes up from type 1 to type 2, and the most will be lipodystrophy. And when we talk about autoimmunity, the most would be, of course, with type 1 LADA, and the least with type 2 and lipodystrophy. So when we talk about different types of diabetes, when we are asking history and looking for signs in the patients, our main goal should be differentiate autoimmunity from insulin resistance. So when we talk about autoimmunity, the first question that comes is which antibody to order in my patients. So when we talk about type 1 diabetes, if the patient's diagnosis is at less than 15 years, then IA2 antibody would be most sensitive because it's clinically available more than ICA, but of course the most sensitive would be ICA. And if the patient's diagnosis after 15 years, the anti-GAD65 antibody would be the most sensitive. So older patient, more than 15 years, anti-GAD65, and younger patient, less than 15 years, it would be IA2 in resource poor settings. But of course, the clinical practice is to order both these antibodies and then come to a diagnosis. So I had a case, a 21-year-old gentleman who presented with diabetic ketoacidosis. He had no history of chronic disease and no family history of diabetes. He had unhealthy eating habits and a sedentary lifestyle, and on examination, the patient was obese with a BMI of 30 kg per meter square. So with DK, I was already thinking about type 1 diabetes, but obesity was going against type 1 diabetes in this patient. So his RBS was 445, HbA1c was 16%, ABG showed metabolic acidosis, urine analysis showed ketonuria, GAD65 autoantibody was positive, and stimulated C-peptide was low, 0.1. So before you ask me, this case I had when I was just a first-year resident. So I learned only later that C-peptide should not be done during DK diagnosis and should be done at least after 3 weeks. So I did stimulated C-peptide anyway, and it was low. So just a quick recap of stimulated C-peptide. So less than 0.2 would be absolute insulin deficiency, and this gentleman had 0.1. So absolute insulin deficiency diagnosed, and I had all my pointers towards type 1 diabetes. So I labeled him with type 1 diabetes. To explain his obesity, I said this is hybrid diabetes, and his high BMI can be attributed to his unhealthy eating habits and sedentary lifestyle. So I discharged him on basal bolus insulin regimen. He required about 70 units insulin per day. I told him about lifestyle modifications, weight loss. And one most important advice that we tend to give all our type 1 diabetes patients these days is I told him not to stop insulin at any cost and to avoid going to any babas who will promise him remission of type 1 diabetes without insulin. So after 1 year, he did the unthinkable. He went to a baba and he stopped insulin, but surprisingly, he had no episodes of diabetic ketoacidosis. His HbA1c was 7%, and his stimulated C-peptide when we did then was also high. So he also told me to go consult the baba that he had consulted because he told me that you told me not to stop insulin, but I stopped insulin and see nothing happen. So only later when I was in my second year residency, this happened, and I learned the hard way that this was ketosis prone diabetes. So Ketosis-prone diabetes is a clinical entity which we see in the young, especially of Afro-Caribbean or Hispanic ancestry with unprovoked ketoacidosis, maybe new onset diabetes. And it's important to remember that up to 28% of these patients can have autoantibodies positive. So they are falsely labeled as type 1 diabetes and they go on to have remission later, or they do well with oral anti-hypoglycemic drugs. So this is male predominant among patients with unprovoked diabetic ketoacidosis, and male to female ratio is almost 3:1. But insulin should always be the initial therapy with reduction of cardiovascular risk factors. And C-peptide is often low or undetectable during diabetic ketoacidosis, and recovery is expected in more than 60%. So when we look at the clinical spectrum of young onset diabetes, first when we see the patient, classify them as obese or lean, and obese diabetes is likely to be type 2 diabetes or ketosis-prone diabetes, but type 1 and monogenic diabetes or LADA are non-obese, or even if they have a hybrid component, their weight is usually lesser than these other forms of diabetes. So we know type 2 diabetes is polygenic, but ketosis-prone diabetes is also polygenic. And type 1 diabetes, there is no role of HLA testing as of now. It's only in research purposes. So type 2 diabetes is more likely if overweight or obese, age more than 10 years, strong family history of type 2 diabetes, markers of insulin resistance like acanthosis nigricans, undetectable islet anti-antibodies, and elevated or normal C-peptide. When we talk about MODY, the newest MODY is MODY 14. We have 14 types of MODY, and APPL1 gene is the one responsible for the newest type of MODY now. So when to suspect MODY is strong family history, of course, 3 generations, persistent fasting hyperglycemia, very small increment on an OGTT should be suggestive of GCK, and very large increment on OGTT should be suggestive of the HNF1 alpha MODY. So good glycemic control outside honeymoon periods of 3 years is also suggestive of MODY, and of course they have a marked sensitivity to sulfonylureas and glycosuria at relatively normal blood glucose levels. So we know the pathway: diabetes in at least one individual, less than 25 years, in at least 2 generations, negative autoantibodies, and a good C-peptide response is compatible with the diagnosis of MODY. So for a genetic testing, there should be no evidence of autoimmunity, normal C-peptide level, and there's something that we do known as the assessment of MODY probability. So we have this Exeter Diagnostics, which has a MODY calculator. So you can just Google for MODY probability calculator. This comes up where you put in the patient's clinical details, and it gives you the probability of your patient having MODY. So if the probability on this calculator is high, you can go in for a genetic diagnosis. Coming to LADA, age more than 30 years, patient may be overweight, but typically leaner than those with type 2 diabetes, and autoantibodies should be present by definition. Patients have mild to moderate insulin resistance in these type of diabetes as well, but progression to insulin therapy is slower than for patients with type 1 diabetes, and they may have had a good glycemic control on OADs in the initial days of diagnosis. So when we talk about fibrocalculous pancreatic diabetes, very relevant to us, especially because the incidence in South India is very, very high. We know that these patients have a genetic mutation, the SPINK1 mutation, typically lean, low socioeconomic class, intermittent pain abdomen, steatorrhea, and management of diabetes early by OHA, but later they will require insulin. So one very important point why we should be diagnosing this type of diabetes is this is pre-malignant, and these patients should be monitored for pancreatic adenocarcinoma. So a simple algorithm: diabetes onset less than 30 years after infancy, sudden onset, severe osmotic symptoms, and ketoacidosis in the presence of islet autoantibodies will be type 1. So if the patient is obese, more than 30, with insulin resistance features, with family history of diabetes, of course it's type 2 diabetes, family history of mitochondrial inheritance, mitochondrial diabetes, and if it is an autosomal dominant inheritance, MODY. Fasting hyperglycemia, which is stable and mild, would be MODY 2. Progressive hyperglycemia will be the other forms of MODY, MODY 1 and 3. If the patient has extra pancreatic features, important to look for renal cysts and MODY 5. In the presence of optic atrophy and sensory neural hearing loss, the other syndromes, the Wolfram syndrome. And if not fitting into any of this, we can do the Modi panel, which is available in various centers, costs about 10,000 rupees. So when we, after we diagnose the patient based on this algorithm, we usually come to a diagnosis of one of the types of diabetes. Of course, there's no secondary diabetes included in that, the diabetes secondary to Cushing's, diabetes secondary to acro, but that would be mainly by history and clinical features, which I spoke about earlier. So why is it important to diagnose the cause of diabetes? So this is a patient I had recently who was diagnosed with PCOS, was referred to me because of irregular cycles, and she was also diagnosed with diabetes with a HbA1c of 7%. She had florid striae, suggestive of Cushing's syndrome. And this is not an advertisement for weight loss program, but this is a before and after pictures of the same girl after treatment for Cushing's. She had remission for diabetes. She lost a lot of weight, and her cycles also regularized. So to conclude, diabetes in young, one most important thing that we need to know, according to me, is that diagnosis may not be apparent at presentation. Revisiting history, examination, and investigations on follow-up will definitely help to come to a diagnosis of the type of diabetes, and identifying the type of diabetes is always rewarding, even for the clinician and the patient. So thank you.
Thank you, doctor. It was a wonderful session and very informative. Any idea of how many diabetes more common in females? Actually, nowadays, female women in diabetic, women in cardiovascular system, so more often it is coming more. So, in your experience, how do you?
Actually, since I've always worked at a tertiary care center, I don't see the early diabetes. So usually patients with diabetes are referred have chronic kidney disease or some complication, or usually the other forms of diabetes like type 3C diabetes are getting referred. So I think in my clinical practice, I see a lot more of men more than women, but I think Anil sir will be able to answer that better.
Of course, as she said, even women, of course, if you see the female-male percentage, it may be almost same, but in some studies we have seen male predominating female. But now we are seeing more and more women patients also. We should take care of the cardiovascular risk what they have. And of course, it was a very interesting session, and the case study you presented, the ketosis-prone diabetes, which was antibody positive, that was also quite interesting. And what are the, have you seen many more ketosis-prone diabetes like that?
Yes, sir, that was my first case, and after this case, I learned to recognize the ketosis-prone diabetes. So yes, I have seen a number of ketosis-prone diabetes, with antibody being positive. There are 4 subtypes of ketosis-prone positive, and one of them is antibody positive with beta cells. So
they actually divide into A plus, beta plus, and then A plus, beta minus, like that they divide. And of course, this is A plus, actually it was beta minus and then became a beta plus.
Yes, sir. So they do recover after insulin therapy. So especially I think this is more relevant to us because of all these alternate practices, suggesting remission of diabetes. So after this, I've been telling my patients that maybe it is possible to stop insulin. We need to do another C-peptide later.
And of course, even what you said about Modi, because if the Modi is diagnosed, some of our patients can be treated with sulfonylureas only. So in that, definitely we have to tell our patients. Some of our patients, maybe we can withdraw insulin and give, depending upon the clinical investigations. I think this was a basic presentation. Maybe after the 2 sessions, I have one more session. So we will have some clinically interesting cases in that. Thank you. I think.
Dr. Lakshmi,
any
I have a
questions from the
question.
audience?
Dr. Lakshmi, I think while you differentiate the different types of diabetes in young, one of the most important factors to be determined is the choice of therapy. Okay, it either is OHA or insulin, but in LADA and in pancreatic diabetes, would you like to clarify the choice of OHAs?
In in pancreatic diabetes, it is quite controversial actually. The ADA 2022 says that DPP-4 inhibitors may, they have a risk of pancreatitis, but in cases of type 3C diabetes which are not due to pancreatitis, there have been a few studies. Their sulfonylureas have been used. Recently there was a debate. People are always debating on this, whether insulin is optimal or OHA is optimal. So the studies are observational studies. There have been no randomized control trials comparing insulin versus OHAs, but few studies have shown in the initial stages of diagnosis, sulfonylureas can be used, but not very effective after the beta cell reserve is lost. So the best would be insulin therapy. As of now, we have only evidence from observational studies for the use of OADs, especially DPP-4 or sulfonylureas. And LADA, because we need to concentrate on preserving the beta cell, so sulfonylureas are not preferred in LADA. So beta cell preserving therapies like other OADs can be used, and I think Manohar sir is going to stop the audio now if I don't stop. So I'll end. Thank you, Maman sir.
Thank you. Thank you.
Thank you, Dr. Lakshmi, for your excellent deliberation on diabetes in young. It's a very good mention about the Babapati. It's a much needed need of the hour, because now it is surprising to see a lot of young people who are newly diagnosed are pulled towards this Babapati. So I think we need to address this issue in a large way. Yeah, thank you, Dr. Lakshmi. Thank you, chairpersons, for sharing this session. Can we have a quick photo with you? Before we move on to the next session, I have a small announcement. I'm sure everyone must be receiving quite a few messages in the WhatsApp. So we have made this WhatsApp channel for excellent communication. So you will be getting real-time communication and updates about the conference. In the same way, now we will be sending some questions, and there is a quiz competition happening tomorrow. But for the audience also, there are quite a few questions that will be coming in the WhatsApp. And the most number of questions answered person will be honored tomorrow in the valedictory function. So please actively participate in that. So with this, let's move on to the next session. I'll call upon Dr. Ishwar Prasad and Dr. Ravindra KR to please come on the dais and introduce the speaker. Dr. Arvinda Jagdisha.
Martin. Okay. Hello. Yeah. Good morning. Thank you, Dr. Manohar, for allowing me to chair this session. It's my pleasure to introduce Dr. Arvinda Jagdisha, who is an MD and MRCP and FRCP, triple FRCP, and he has got so many important awards, and he is a well-informed speaker, and it is really delightful listening to him. Of course, I'll be happy if he is, as usual, if he is going to give a humorous touch for this talk. Welcome. And
just a couple of sentences. Thank you for inviting me. There are two issues in diabetes as far as patients and patients' friends and patient relatives are concerned. One is prevention of diabetes versus reversal of diabetes. Both are hotly discussed and debated elsewhere. And of course, diet and diabetes go hand in hand. Proteins are becoming now part of the line of treatment versus prevention of diabetes. And also one evidence-based medicine says when you mix protein-rich diet, maybe soybean, along with carbohydrate diet, the carbohydrate absorption slows down, glycemic index comes down a little bit, and it may prolong or delay in the onset of diabetes or delay in the complication, something like that. And over to Dr. Arvind. Thank you.
So good morning, everybody. At the outset, thanks, Chairman, for the nice words. So welcome all of you to the Krssdi conference. So at 10 o'clock, we are seeing so much of crowd. It is very heartening to see early morning so many people coming. That shows the interest and the efforts done by the KRSS team from Dr. Suman, Dr. Vijay, and Dr. Manohar. So with all the new innovations with WhatsApp and all, kindly participate in WhatsApp channel. I'm sure you will be getting a reward for that. So I have an interesting talk today. That is, can adequate protein intake reverse or delay type 2 diabetes? I should not. This terminology is always controversial, isn't it? Reverse, I don't know whether it is true or not. We can always say remission. Remission is a better word than reversal, because reversal is one thing which attracts people. That is a thing. Everywhere you see the reversal of diabetes and all. Actually, it's not reversal. You can say remission. So, disclaimer is this talk is sponsored by British Biologicals. So, if you take the definitions of remission or reversal of type 2 diabetes, you can see this is a very important slide to know, for all of us to know what is remission of diabetes. You can see in this slide, American Diabetic Association. It says remission is there should be no diabetes medication. HbA1c should be less than 6.5% or fasting plasma glucose less than 126 milligrams for more than 3 months. This is ADA definition. Next, the direct and diadem 1 says remission is no diabetic medications for 2 to 3 months in previous 12 months. HbA1c should be less than 6.5% and duration is more than 1 year. Volta Health says reversal and remission, you can see here, there are no medications or metformin alone. HbA1c should be less than 6.5 years, more than 1 year. ABCD, that is the British Diabetic Association, what they say is cessation of all diabetic medication, fasting glucose less than 126, HbA1c less than 6.5%, more than 6 months. So if somebody comes and asks you, doctor, can you reverse or remission of diabetes? You say, I can't reverse your diabetes. I can make you remission of diabetes. That is, you can be cool for diabetes for 1 or 2 years, provided you have a lifestyle modification of diet and exercise. That is where this slide plays an important role. If you take the background of diabetes, we all know it is associated with complication. It represents a significant public health challenge. Medical nutrition therapy is the central component of type 2 diabetes care and has been shown to improve outcomes and reduce costs. A key goal of MNT is modest weight loss as defined by the ADA position statement as a weight loss of more than 6 kgs achieved through reduction in energy intake and intensive lifestyle intervention. Why weight loss? Weight loss is recommended for obese people with type 2 diabetes because obesity is closely linked to insulin resistance, elevated glucose, and their associated complications. High protein diets, this is where our topic is today, are strongly advocated by some diabetic experts as a strategy to ease weight loss as compared with other strategies of energy restriction. According to the RSSD 2022 guidelines, in a diabetic patient, protein intake should be maintained at about 15% of the total calories. The quantities of protein intake depend on age, sarcopenia, and the renal dysfunction. Kindly note this, renal dysfunction. Non-vegetarian foods are the source of high-quality protein. However, intake of red meat should be avoided. Protein intake goals should be individualized based on the current eating patterns. What is high protein? A diet is therefore considered high in protein if it exceeds 0.8 grams per kg body weight or the habitual 15 to 16% of the total energy. What are the benefits of high protein diet? They cause only a small increase in blood glucose due to the low carbohydrate content. They need less insulin for the metabolism of the protein. They increase postprandial thermogenesis. They reduce insulin-induced lipogenesis. Improves blood lipids because hepatic and adipose tissue use carbohydrates for lipogenesis. They maintain lean body mass and thereby improve basal metabolic rate after weight loss. Some various studies have shown it is determined that dietary protein does not increase postprandial glucose concentration, but rather acts as an insulin secretagogue, synergistically stimulating insulin secretion to reduce the blood glucose response to the ingested carbohydrate. If you take the pathophysiology, GLP-1 and GIP have been shown to be significantly increased with high protein diet. That is 30% protein, 30% fat, and 40% carbohydrate. This is an important thing. When it is compared to high carbohydrate diet like 55% carbohydrate, 15% protein, and 30% fat. So high protein diets have been reported to cause hunger suppression and promote longer lasting satiety. The hunger suppression of effects of high protein diets may be due to their ability to suppress ghrelin, which peaks in the fasting state and promotes meal initiation. Conversely, GLP-1 is released postprandially and promotes glucose-stimulated insulin secretion as well as inhibiting appetite. Any diet that leads to an increase in secretion of GLP-1 or GIP is beneficial in preventing the progression of type 2 diabetes and the remission of pre-diabetes. What are the clinical evidence for the high protein diet? So you can see in this trial, it's a counterpoint study where they have done, the patients were given a 600 kilocalories, very difficult to give a 600 kilocalories, only studies can be done, or only Karina Kapoor can do this. Otherwise, people very difficult to take 600. You want a zero figure diet, you want to do a 600 kilo diet, but still we can do it, at least to tell we can remedy the diabetes. What they've seen is the very good response in weight reduction as well as diabetes remission. You can see in this slide that counterpoint study shows in the liver fat is decreased, insulin sensitivity index has increased, pancreatic fat is also decreased, and first phase insulin secretion is increased. Another trial which shows the direct study, that is the diabetes remission clinical trial. Here, when they have intervened, compared to the control, what they have seen in this study, almost half of obese overweight individuals with type 2 diabetes less than 6 years duration who had 10 kg weight loss achieved diabetes remission. So 10 kg weight loss is a very simple thing, but very difficult to convince our patient. So recovery of first phase insulin response defined responders sustained at 12 months. First study to suggest that the ability of beta cells to recover persists after diagnosis and is linked to type 2 diabetes duration. However, this study, you can see the evidence of effectiveness beyond 2 years is limited. The culturally diverse Indian society hampers sustainability of liquid diets, leading to relapses quicker than the remission. Routine Western meal choices such as soups, bars, and shake does not satisfy the Indian carbohydrate-driven plate. We want plenty of Andhra meals. So we are very difficult to maintain this. So more data is needed in an ethically diverse population like India. We should tell our patient to reduce chitrana, dosa, idli, so that definitely that will help our patients. So this is an interesting study. ICMR India national study. This is a national study. The sample size was 18,000. You can see here 18,000. It's a cross-sectional study. What does this study say is it recommended an increase in protein intake for both type 2 diabetes remission and for prevention of progression to type 2 diabetes in pre-diabetes individual and normal glucose tolerance group. So what is the study of this is 4 macronutrients recommended emerged from is diabetic remission in the new onset diabetes mellitus. If there is a carbohydrate is 49 to 54%, protein 19 to 20%, fat is 21 to 26%. Pre-diabetes remission to normal glucose, if there is a carbohydrate of 15 to 16, you will kindly note protein is 18 to 20%. Prevention of progression to type 2 diabetes in pre-diabetes and the normal glucose tolerance, you can see here once again the protein concentration is 16 to 20%. Another study shows the effects of higher versus lower protein diets on health outcomes. A systematic review and meta-analysis, what they say is eating a high protein diet like 27% versus 18%, significantly reduced several cardiometabolic risk factors, including body weight, BMI, waist circumference, blood pressure, triglycerides, and fasting insulin, while also significantly increasing the HDL and satiety. Association of specific dietary protein with a longitudinal insulin resistance, prediabetes, and type 2 diabetes is a Rotterdam study. It was observed that the total plant protein as well as a protein from legumes and nuts, from grains, from potatoes or from fruits and vegetables was not associated with insulin resistance and the risk of pre-diabetes and type 2 diabetes. So an increase in dietary protein improves the blood glucose response in persons with type 2 diabetes. You can see in this study, the glycated hemoglobin decreased from 0.8 and at 0.3 after 5 weeks of high protein and a controlled diets, respectively. The difference was significant. Conclusion of the study was a high protein diet lowers the blood glucose postprandially in persons with type 2 diabetes and improves overall glucose control. The glucose concentration was consistently lower after the high protein diet, particularly in the evening. The insulin concentration increased rapidly after the meals as expected. The insulin excursion was not significantly different with either diet after breakfast and lunch, but was modestly greater after dinner with the high protein diet. So the commonly asked question is, what is the difference between animal fat and the plant protein? This is always the difference between tug of war between vegetarian diet and the non-vegetarian diet. You can see the difference between plant protein versus animal protein is a busy slide. What does this gist of it says is, plant protein is definitely more good than the animal protein. It doesn't mean you eat meat, you will be good. Plant protein is also sufficiently good enough in giving the good sufficient protein supplement. In a long run, it will help in diabetes remission. So you can see this, the RDA suggests cereal legume milk in the ratio of 3:1:2.5 to meet the amino acid requirements. So animal versus plant protein meals in individuals with type 2 diabetes and microalbuminuria, this study showed that two diets consisting of 17% of energy from protein, plant, that is plant compared to with animal, resulted in a reduction of in HbA1c compared to the baseline with no significant difference between the diets. So association between dietary protein intake and type 2 diabetes varies by dietary pattern. This is another study published in Diabetology and Metabolic Syndrome. It says higher intake of vegetable protein is negatively associated with type 2 diabetes mellitus risk. So all the vegetarians we all should be happy that taking the vegetable protein is also beneficial. So this another study says that higher protein diet, that is 30% of the energy from protein, resulted in an improved inflammatory profile, reduced lipids, and improved insulin sensitivity when compared to the baseline. Why plant protein? A systematic review of 4 intervention trials evaluating protein source in individuals with type 2 diabetes concluded that replacing some animal protein with soy protein may lead to the improvements in some cardiovascular disease risk factors with no changes in renal function. An intervention trial in 15 postmenopausal women with abdominal obesity showed that partially replacing meat with soya-based foods improved insulin sensitivity. This is where the protein supplements role will come. You are aware there are so many protein supplements available in the market. They will be asking whether these are beneficial. Definitely in certain groups of patients where these supplements if you give, for example, many companies have their British Biologicals have got the protein supplements also. If you give that particular protein supplement, various companies have got the supplements. Accordingly, you select the patients and give the supplements in a deserving patient, it will have a good beneficial effect. How much proteins is always a big question. Indians consume, we all consume 2,500 kilocalories daily with carbohydrate contributing to 65 to 80% intake. Indians, we are all deficient of protein. So ensure 20% of daily protein intake, 20%, very, very important. You ask your dietitian to help the patient to take the 20% protein, or from your side you can tell the patient to take 20% protein according to their diet pattern. This can help in reversal or delay in type 2 diabetes or remission of type 2 diabetes. So ladies and gentlemen, take home message from my talk is medical nutrition therapy is the central component of type 2 diabetes care, which consists of dietary and lifestyle interventions. It is established that dietary protein does not increase postprandial glucose concentration, but rather acts as an insulin secretagogue, synergistically stimulating insulin secretion. Eating high protein diet is associated with reduction in HbA1c and blood glucose level. So higher intake of vegetable protein is negatively associated with type 2 diabetes risk. The conclusion is reduction in carbohydrate calories and an increase in protein calories for both remission and prevention of type 2 diabetes in all glycemic categories. To prevent progression in pre-diabetes and normal glucose category, tolerance categories, a minimum protein of 14 to 60% or up to 20% is required. Physically inactive, obese, and older individuals, as well as those residing in urban locations, require greater reductions in carbohydrate intake and increases in the protein intakes. Protein supplements, this is an important thing, can be a viable solution to reverse or remit or delay diabetes. Thank you for your patience hearing. I am on time.
Thank you, Dr. Arvind Jagdisha. That was an excellent talk. And as usual, you have given a crisp talk relating to adequate protein intake. Can it reverse or delay the onset of diabetes? Yes, some studies have been done, and I think some more studies need to be done. As such, we know that Indians, we indulge in taking more of carbohydrates, like almost, as you told, it will be around 70 to 80%. So I think we need to cut down on that. And because our tongue, which is we try to consume with the tasty foods like more carbohydrates and more fat, so the food will be tastier. If you give more protein, which is almost like a tasteless, so even though we advise a lot of millets and all that, people tend to not to consume those foods. So I think we need to educate the patient, and as such, we Indians, we take even though non-vegetarians, if they tell, they'll be consuming only once or twice a week. So it is definitely not every day. So protein consumption as such in the Indian subjects is very less. So if this study, if it at least delays, if it does not reverse, at least if it delays the onset of diabetes, at least it is going to be very helpful. And any questions?
Yeah. Just add one sentence. I think I've heard one concept called as protein package of this, which is available only in vegetarian diet, not in non-vegetarian diet, which means it is a complex protein plus fiber plus micronutrients put together you eat. So therefore it has a different role compared to non-vegetarian proteins,
Especially
which
in
has got a more a
elderly
CV
patients.
risk factor.
Especially in elderly patients where they are frail and not able to eat well. So sometimes what happens, they may not be able to take this natural food, homemade food. So sometimes they are not eating at all. So at that time, you have to give a supplement. Yeah, you can give with milk or water, this protein supplement, that will be definite, because it will be associated with various micro and macronutrient involvement. So
Additional benefit.
Additional benefit will be there.
Now the open few questions from audience.
As usual, Arvind, it was an excellent presentation. So actually, you said the high protein diet can, of course, we have to say remit diabetes. So what's the long-term, this one, whether long-term benefits or any side effects you see in high protein diet?
So if you take 20% proteins, there are no long-term side effect at all. If you take the Western diet, it's almost like 20 to 25% of protein diet. See, they are healthy. Why their diabetes is less in Caucasian and more in Indians? Because we take only 12 to 14% of protein. They are taking 20%. But studies-wise, there is no long-term data regarding these beneficial. But obviously, we can see the indirect effects of our friends in Western countries, where from the beginning they are in protein-rich diet only. The beneficial is obviously there.
Okay. I'm happy that repeatedly you are telling remission of diabetes. Of course, many of the international organizations, there was a consensus meeting where they have decided you should use term remission rather than reversal or cure. But this reversal is only for business, I think.
Yeah.
Thank you.
So main thing you should all remember is if some patient comes to you and asks, can I reverse your diabetes? Can you reverse my diabetes, doctor? You said no. I will only remission your diabetes. I can remission your diabetes, but provided you have a good lifestyle modification. Remission is very important. Reversal is always false. It has become a business protocol, not for us. Yes. Reversal. Yes.
Can I give an input here regarding the protein thing? I am a dietitian.
Sure.
See, the basic difference between protein, animal protein, and the vegetarian protein, why the Dr. Arvind has said specifically the animal protein versus plant protein. Particularly in diabetes, the animal protein has a less fiber, which is not so helpful if we consider as an animal protein in the remission stage. Whereas the diabetic with high protein with vegetarian source has, as the doctor said, it has a complex fiber which helps in the glycemic, doctor usually they give SRs, that sustained release. The same phenomenon you can see high protein with vegetarian diet because of its complex carbohydrates in the form of dietary fiber. So that helps in taking the glucose level little slow release in the bloodstream. Thank you.
Any questions from the audience?
Hello. Yeah, you mentioned 20% in our diet should be protein. Remaining 80% what should be?
Yeah, in that you can say, you can make it as 20 minimum if you take, remaining 40-50% with carbohydrate and rest with the fat.
So, do you suggest this high protein keto diet better than whatever we are having?
Yeah, that's a very good question. I was expecting this. The keto diet is a big controversial thing. Unless proved otherwise, if the patient is not following with a doctor, it should not be recommended. What I see is still more data we need more data. Because you have seen the recent controversies. One of the film actors in West Bengal died because of the ketotic diet. So keto diet, high protein keto diet is a big controversial thing. We want more data. Some people still advocate if they are in a regular follow-up with their doctor. Otherwise, recommendation is dicey. So till we get a further data, I don't recommend. I personally don't recommend.
Yeah. Thank you, Dr. Arvind Jagdisha. Due to paucity of time.
Dr. Sidney.
One question. One last question.
Just to add a little humor to your topic, nothing against your topic. This is Professor Antia, a top gastroenterologist who is no more. He's written a book on this nutrition. He says the last small poem is there. Poem goes like this. Sugar is poison, don't ever look at it. Lipids will destroy your heart, so be away from it. Protein will destroy your kidneys, so never ever even touch it. So ultimately, listen to all the doctors and eat and dictate, go by their dictation and die of malnutrition with your arteries intact. This is in relation to coronary artery disease. I think it's a very nice topic, but lot of controversies. Hopefully, one day things will resolve. Thank you.
Thank you very much.
Thank you, sir.
Yeah, thank you.
Of weight loss and visceral fat loss?
Personally, what I feel is that if you look at the various weight loss programs, they have got a different agendas. Like they give a personal diet pattern and all. If you take the overall calories from the different protocols, what they have got, it's hardly like 700, 800 kilocalories. Like I always say to my patient, we are all human beings. We can't be a cow or a buffalo eating the grass every time, because you have to leave something, eat something to live. This program is patient enthusiastically enroll themselves, they lose weight, diabetes is also remission. But what happens after 6 months? If you see that, it's a tragedy. What they lost by 5 kg, 6 kg, they will gain by 10 kgs extras. So many who have gone there and come back to us and say, but if they do a dedicated thing for keep on doing that, my lifestyle is like that, I take only 800, 900 calories on an average, that will be beneficial. But how much our patient does is a big question.
No, it's not question of our patients or your patients. What I'm trying to tell you is that I have seen what Dr. Roy Taylor is doing in Newcastle. They depend more on a weight loss of about 12 to 14 kg over a period of 1 year, which improves the first phase insulin secretion. And the calorie restriction is, whether it is intermittent or whether it is continuous, it has given good results. And they have their own special diet, which is protein rich, goes up to about 35 to 40%.
And 750 calories per day.
750 to 800 calories. That is a very low calorie diet, which is impossible in our country. We cannot go beyond 1200. But what I'm trying to say is that, is it more related, reversal effect? Is it more related to the weight loss, or is it related to the high protein intake?
So it's a visceral fat loss. The remission, which the dietary pattern they take, they mainly concentrate on the visceral fat loss, where they try to, the liver, the fat percentage they try to minimize by giving the ketosis, by the keto diet what we were discussing. So the ketogenesis, all that, so mainly it's a visceral fat loss is the pathophysiology.
Thank you. Thank you very much. We can have a discussion.
I have a small comment. I'm Dr. Shivshankar. Dr. Arvind, that was an excellent talk. Just one point I'd like to comment and clarify. The Western diet, as you say, is very rich in meat protein, especially, and the Indian diet, more carbohydrates. And as far as you're concerned, and what you're saying is right, they have a lesser incidence of diabetes, but a high incidence of bowel cancer compared to the Indian population.
That is related to fiber intake. Yes. They have got a less fiber intake. So
fiber and red meat.
Yes, yes.
Fiber and red meat.
That is the most common reason for the colon cancers.
That's right. Thank you.
Thank you all.
Just want to thank.
Hey, 1 minute. So we can have a group photo.
I thank Dr. Arvind and chair people for this wonderful session and lot of conversations. We had a very good time in this.
Just a housekeeping announcement. Those of you who have not received your ID cards or registered, you can move out in multiples of 2s or 3s only at a time to collect the same. All have been received outside.
After the protein, the conversation, we have next session, the lobeglitazone and new Ormansure in the type 2 diabetes.
So moving on from one pillar of diabetes to the other, that's the medication part. We invite the chairpersons, Dr. Pradeep Kumar, who's the radiation oncologist, and Dr. Nirup K, who's a consultant physician and diabetologist. And they would be inviting the speaker.
Dr. K. Vijay Kumar.
I'd like to thank the organizers to inviting me as a chairperson. Now let's move on to the next speaker, Dr. K. Vijay Kumar. He is a honorary secretary of RSSDI, Karnataka chapter, and he is a secretary of DISA Continued Medical Education and is a governing council member of RSSDI. And as everyone know that he is a organizing secretary of RSDI today ongoing conference. And he had attended so many conference and has many publications. And he attended national and state forums as a speaker and also faculties. So over to you, sir.
Thank you, Dr. Pradeep, for your kind introduction. Before going to my slides, I just want to have a quick note on what my friend Dr. Arvind Jagdisha spoke just now. It is like we see many advertisements earlier, right from many years we have been seeing for obesity, like the VLCC and so many other companies, and crash course for obesity. So they definitely work. Everyone go lose weight, quite a wonderful weight loss they get, and then come back. But the question remains: do they maintain it? So the question remains on the maintenance of whatever they have learned when they went for the crash course. Similarly, when there is a remission of diabetes, whatever that is happened because of whatever treatment they have been given, it's all about how they take care of their lifestyle going forward, and that is how, and so much long the remission may be there. I think that's what I have understood about this remission and reversal. So why I had to say about this is, I'm going to talk about a new molecule which is going to be coming into our treatment guidelines. That is one of the PPAR alpha agonists, that is lobeglitazone. So this is the new addition to the diabetes armamentarium. So something that is connecting to the previous talk is the core defect in diabetes, the pathophysiology of diabetes. So it is mainly the insulin resistance and the beta cell dysfunction or the failure. So what we have understood over the years about diabetes is basically we cannot reverse completely these two main pathophysiological conditions. So insulin resistance can be improved but not completely reversed. Beta cell dysfunction can be taken care of or prevented from further dysfunction or failure, but cannot be made normal. So because of these two reasons, we are going to struggle between remission and control. So the core defects in diabetes, we all know. So what happens with this insulin resistance? It's mainly the atherosclerosis. There is increased CV risk, hypertension, dyslipidemia, ectopic fat distribution is there, and also the effect on the liver causing steatosis. Coming to the Indian scenario, India and what insulin resistance has in Indians. There is one study that can explain a little bit on this. The novel subgroups of type 2 diabetes was with the association with microvascular outcomes was taken. It's a data-driven cluster analysis called the INSPIRED study. Electronic medical records of more than 4 lakh patients across 9 Indian states was analyzed. The clusters were based on the common diabetic, taken from the common diabetes electronic medical records and the Indian Council of Medical Research India Diabetes Study. So with this, they were divided into 2 groups. Of this, 38% Indians has shown to have insulin resistant diabetes. So the main pathophysiological problem is basically in insulin resistance that has been seen in our Indian population. Of this, the insulin resistant obesity is about 25%, and more than 12% was combined insulin resistance and deficiency diabetes. So this much of variation is there in our the phenotype of the Indian scenarios. And we know the insulin resistance and what all drugs can be used to tackle these. So metformin basically decrease hepatic insulin resistance and has seen little or not much of effect on the peripheral insulin resistance. GLP-1 analogs have modest effect, and the SGLT2 inhibitors showed modest weight loss and thereby having a little effect on the insulin resistance. GLP-1 and SGLT2 secondarily decreases the insulin resistance, whereas because of weight loss. The TZDs are the one drugs which basically directly acting on the PPR receptors, alpha gamma receptors, so ameliorating the insulin resistance and metabolic syndrome, thereby decreasing insulin requirements. So with this, we can think the TZDs are the main agents that can primarily and specifically target on the insulin resistance. So unfortunately, we had a little bit of bad experience with earlier TZDs, and the pioglitazone had a lot of saga, basically starting with the rosiglitazone, and there was a lot of fear about quite a lot of complications that has been triggered because of the TZDs. However, when you look at the guidelines, we can see the latest ADA guidelines says we are to individualize the treatment and first look at the comorbidities and the risk of cardiovascular status, or also the increased risk of cardiovascular and renal status we need to look at before we start on any medications. And also we need to improve on reducing the chances of hypoglycemia and consider the cost, especially in Indian scenarios. So if the target is above, the HbA1c is above the target, then these patients we have to first look at GLP-1 analogs and the SGLT2 inhibitors, which basically has got a severe risk benefit, and also TZD is placed in this situation. So we should prioritize the use of organ protective medications, basically cardiorenal disease and NASH and other high risk. So benefits of TZDs: improves insulin resistance in insulin resistant individuals, 25% to 68%, and preserves beta cell function, which has got some effect on the dyslipidemia, and decreases the hepatic triglycerides. There is effects on the endothelium and inflammation, vasodilation, decreases systolic and diastolic to in a moderate conditions. It also decreases production of adhesion of molecules, which are pro-inflammatory. Neo-intimal tissue proliferation after coronary stent implantation is also seen in type 2 diabetes, as reduced by 50 to 70%. It's coming to the main molecule with this background. What this molecule has to offer to us, and what is it that we can expect and in the future. Not much of studies has been done though, but it is basically a little bit of quite a few information only we have got about this new molecule. We need to wait and watch in the future how much this will be faring, but let us go through what this molecule says. So it is it's a novel TZDs, basically founded in Korea, and it is approved. It was approved in 2013, and it is some changes, the structural introduced mainly in the pyrimidine of the rosiglitazone structure. So hence binding affinity of lobiglitazone is 12 times higher is what that has been claimed, rosiglitazone compared to rosiglitazone and pioglitazone. And the dual agonist, it is a lobiglitazone is a dual agonist, whereas pioglitazone or rosiglitazone, they lack the PPAR alpha activity. However, lobiglitazone is shown to have dual affinity and has 12 times higher binding affinities. So this is the difference between the alpha and gamma PPAR activation. In the alpha, we see increased fatty acid uptake, increased fatty acid oxidation, and decreased VLDL and the triglycerides, and decreased anti-inflammatory. This action is a little bit reduced, not seen in the rosiglitazone and the pioglitazone molecules. So pharmacokinetics, it is dosed at 0.5 milligram once daily. The half-life is 7.8 to 9.8 hours. Plasma binding is 99%, and it is metabolized basically in the liver. Renal excretion is less than 1%, and there is no effect on the food, so it can be taken before or after meal. Not real dose adjustment is required if there is any mild to moderate hepatic or renal impairment, and no significant drug-to-drug interactions has been reported. Well, so the efficacy and safety has been studied. So over 24 weeks in type 2 diabetes patients, the study mainly assessed the glucose lowering effect and lipid modifying effect and safety of the lobiglitazone compared to a placebo as a monotherapy. The 0.5 mg was used. the study says the primary endpoint, change in HbA1c from baseline, was studied at 24 weeks. The secondary endpoint, HOMA-IR and HOMA-B and LIPA parameters, B parameters, sorry for this. Change from baseline to 22, at 22 weeks of the fasting blood glucose, HOMA-IR and HOMA-B and lipid parameters, and the percentage of patients achieving HbA1c less than 7% at 24 weeks. This was the main aim of this study. So, difference from baseline in HbA1c was quite welcoming. There was, and also the number of patients achieving the HbA1c to below target of 7% was also very interesting compared to placebo. So there is a good reduction in triglycerides, and also the increase in HDL reduction was noted. And also free fatty acid and apolipoprotein also moderately reduced. So in conclusion, lobeglitazone showed improvements in glucose and lipid endpoints with favorable safety profile over 24 weeks. Similarly, as a extension for 52 weeks on-label extension, it was compared with placebo, and it also showed a balance of efficacy and safety and clinical benefits maintained through 52 weeks. So there is not much decrease in the effects even at 52 weeks. That's what they studied by extending the study. Comparing to pioglitazone, to assess the safety and efficacy, pioglitazone 50 mg was used, and duration 24 and 28 weeks. And the baseline characteristics was between the two groups were almost similar, and both lobeglitazone and pioglitazone was shown to significantly improve the triglyceride, free fatty acid, HDL, and small LDL. So that means there was no much difference in these parameters compared to all of these molecules, between all these molecules, even with lobeglitazone. However, that says that it was concluded it was non-inferior compared to the pioglitazone or rosiglitazone. So class effect was similar. Both lobe and pioglitazone reduced insulin resistance and beta cell function, and also the lipid variables. So it was non-inferior in this study. However, analysis said that there was slightly increased pedal edema with the use of lobeglitazone, which was the highlight of this molecule, and heart failure is not increased using this lobeglitazone. Well, that was the worry about the earlier conditions. Those who are having any heart conditions, we were worried about using this the TZDs. However, there was not the increase in the heart failure that was shown in this study. Peripheral edema was one of the concerns. It has actually showed higher peripheral edema compared to the pioglitazone group. The study also suggests long-term durability of lobeglitazone compared to pioglitazone. In naive patients, and it was much tolerable, and durability was well accepted. In the real-world study, safety results also showed there was no risk of any bladder cancer that has been reported in these studies. Weight change was slightly higher. Weight increase was seen with lobeglitazone. Edema was higher, and no bladder cancer. Another study, studying the triple combination with metformin, DP4 inhibitors, and TZD like lobeglitazone in a drug-naive patients. 12 months duration. Results, the initial triple combination therapy showed higher achievement of target HbA1c with lower risk of hypoglycemia, better restoration of beta cell function, and multiple metabolic benefits, implying durable glycemic control. So that means lobeglitazone is a good molecule, and it also has good effect on the liver, and also over 24 weeks there is reduction in, I'm just moving this NAFLD, this changes, apart from changes in HbA1c, liver fat reduction was seen. There was reduction in liver stiffness, also improvement in liver function, and reduction in triglyceride, LDL, and HSCRP. So lobeglitazone reduced intrahepatic fat, improved liver parameters, and lipid parameters in patients with NAFLD also. Albuminuria was also decreased, seen to decrease. Progression was reduced. New onset microalbuminuria was also not seen by using of lobeglitazone. So it had a comparable effects along with pioglitazone also. And it has no effect on bone mineral density even at the use of 52 weeks. So Indian study also, it was the Sensitize India study. The conclusion says there was similar effect seen across even in the Indian results compared to even pioglitazone. There was not much of difference except for the weight change that has been seen. We can see lobeglitazone has got little 2 to 3 kgs more compared to pioglitazone. And there was no serious adverse effects, no hypoglycemia. All adverse effects were mild and moderate, and overall lobeglitazone was found to be safe and well tolerated. So lobeglitazone was found to be non-inferior and a promising insulin sensitizer with these two studies. So in summary, it was mainly excreted in the renal and not, less than 1% excreted in the renal, not having any harmful effects on the renal. So bladder cancer is not our concern. And BMD was maintained. Femur neck fractures were also not of a concern. Lobeglitazone was not inferior to pioglitazone, and it is a promising insulin sensitizer in the management of type 2 diabetes. Thank you.
Thank you, Dr. Vijay Kumar. That was a descriptive insight into the molecule. It seems we are running short of time, so we take a message that it is a new armamentarium in diabetes with lesser side effects and very safe in liver toxicity and other things. But then the side effects continue to haunt us. That's for time and duration to say. Thank you very much for that. It seems we are short of time, so there's no time for questions. Anybody? So thank you for the talk. Thank you very much.
Thank you.
So we can have a group photograph.
I thank Dr. Vijay Kumar and chairing Dr. Pradeep Kumar and Niru for this their time and valuable inputs. Next, we will be taking forward you to all the clinical indication of C-peptide, a step towards precision medicine.
Again, remaining on the medicine part of the diabetes pillar, we invite the chairperson, Dr. Vasanta Kamath, who is a physician, and Dr. Venkat Ramanappa, who is a physician and a diabetologist. And the speaker would be Dr. Anil Kumar.
Dr. Venkat Ramanappa will have fond memories of being the chairman at 2017 at the same venue. Over to the faculty.
It is my pleasure to be here. Now the topic is already announced, and the speaker is Dr. Anil Kumar, who is a good friend of us and a very nice speaker. He has the vast experience of almost 3 decades working in the Institute of Diabetology. So earlier called KIDS, now it is Karnataka Endocrinology Institution. He is one of the main pillars of that institution, and he has done a lot of work, and you can see all these things. I think, let me not go into all these things. I am sure all of you are well known to him, and you know his credentials. I only request him to kindly proceed with the lecture.
Thank you, sir. I think in the same venue, Dr. Venkatramanappa was the chairman, and I was the chairman-elect, and Manohar was the secretary in 2017. Okay, thank you, sir. So I think first we should all remember this man. we lost him 4 months back. He was the pillar of Krssdi and of course even Karnataka Institute of Diabetology. And my topic is clinical indications of C-peptide, a step towards precision medicine. This is my 15 years of my clinical experience in KID and KER. So I want to just show some published original articles. This was one of the articles, evaluation of serum C-peptide in Indian type 2 diabetes patients attending Tertiary Diabetes Institute. Here in this study, we studied 150 type 2 diabetes patients, and the results were the C-peptide was high in 79.3% of the patients and normal in 20.7% of the patients. None of the patients had low C-peptide levels. And then this is the study published in RSSTI 2011 Mumbai. It is the prevalence of GAD positivity in type 2 diabetes individuals. We had about 17 patients having GAD positivity, out of which 10 had high titers and only 7 had low titers. And then, of course, we did this study. Latent autoimmune diabetes in adults clinical risk score was used, and most of our patients were having criteria more than 2. And then this is the latest study we did. This is funded by RGHS. Prevalence of GAD and IA2 antibodies in, again, type 2 diabetes less than 35 years. The second talk, we had young type 2 diabetes patients less than 35 years. Again, in this study, we could see 7.6% of the patients were positive for antibodies, out of which 6.4% were positive for GAD, and only 1 point something were positive for IA2. So I think GAD antibody, if we do in clinical practice, we can detect most of the LADA patients. And of course, our study was, I compared with some of the national and international studies. In India, I didn't find any study doing both GAD and IA2 antibodies. As we see here, in the European countries like UK, Finland, and other countries, the positivity was more. In the UK PDS, it was about 12%, and then in other studies, 9 to 10%. But if you take the other Asian countries like Japan and China, it was about 5 to 6%. In our study, it was 7.6%. Probably it was coincident with the other Asian countries. So just now coming to the main topic of C-peptide. What is the C-peptide? C-peptide is first described in 1967 with the discovery of insulin biosynthesis pathway. And actually it serves as a link between the A and B chain, and it facilitates the efficient assembly, folding, and processing of the insulin. And this actually acts as a marker of the insulin secretion, and it mainly differentiates between the type 1 and type 2 diabetes. And of course, this is the picture we can see, the C-peptide, this is the proinsulin. The proinsulin gets converted to the insulin and C-peptide in presence of pro-hormone convertases 1 and 2. And this, again, this is one of the diagrams where proinsulin getting converted to insulin and C-peptide. So this is the C-peptide, the 31 amino acid C-peptide, which links the insulin and this one. This is the proinsulin. You can see the yellow one is the C-peptide. So this is, I think it's very important for both undergraduates and postgraduates, why C-peptide testing is preferable to insulin as a guide to beta cell function. So we have 4 reasons. The degradation of C-peptide in the body is slower. It's about 20 to 30 minutes half-life. When compared to insulin, it was about 3 to 5 minutes. And then the half of the insulin is metabolized in the liver, but C-peptide doesn't have much metabolism, maybe very negligible metabolism. That's why it has been used as a marker of beta cell function. And also C-peptide is cleared in the peripheral circulation at a constant rate, whereas insulin, it's cleared variably. And then the insulin-treated patients with diabetes, if you have exogenous insulin, we have to use C-peptide. We cannot use insulin because it will give a wrong beta cell function. And then if you see the pharmacokinetics, the majority of C-peptide is metabolized by the kidneys, and only 5 to 10% is excreted unchanged in the urine. That's why in CKDs, this cannot be used. It will be inaccurate. And then modern ultra-sensitive C-peptide assays are able to detect values less than 0.0015 to 0.0025. Of course, C-peptide testing, why we have to just see the sample collection. how to do the sample collection. If you are doing C-peptide in your own laboratory, in your own hospital, we can collect either serum or EDTA blood, because the C-peptide is stable up to 6 hours in serum, whereas in EDTA blood, it is stable up to 24 hours. So if you are sending it to a different laboratory, transporting, then you have to take an EDTA blood and then transport for C-peptide testing. And then before we were doing radioimmunoassays, which was quite costly and cumbersome. Now we have assays like chemiluminescence, fluorescence. All these are very sensitive and less expensive. And then even optimal standardization of C-peptide is necessary, which is not being done. I think in future we should expect for this, because different laboratories give different readings that's very difficult to assess in practice. And this is the one which is used in our institute, electrochemiluminosassay. So what is the normal C-peptide levels? I think it's very important to remember this. Normal C-peptide level in the fasting state, it is between 0.3 to 0.6 nanomoles per liter. If you want nanograms, multiply by 3, it is 0.9 to 1.8 gram per ml. And the postprandial or stimulated one is between 1 to 3 nanomoles per liter, again 3 to 9 nanograms. You have to multiply. These are the two, these are the two measurements which usually give in most of the laboratories. And then by using C-peptide, we can classify diabetes. You can see here, C-peptide levels, if it is less than 0.2, you can easily consider that it is type 1 diabetes. If the C-peptide level is between 0.2 to 0.5, you should take the age of onset. If the age of onset is less than 30 years, you should do stimulated C-peptide level. If it is again less than 0.2 or 0.2 to 0.5, we can take it as type 1 diabetes. But if the C-peptide is between 0.2 to 0.5 and more than 30 years, again it goes to a diagnosis goes in favor of type 2 diabetes. And if C-peptide more than 0.5, it is definitely type 2 diabetes. And then we analyzed data from our institute. We did C-peptide in about 631 patients, out of which C-peptide less than 0.6 nanograms only in 4 patients. They are type 1 diabetes patients. C-peptide between 0.6 to 1.5 in 64, that is 10% of the patients. This is the gray area where we have to analyze and then see whether it fits into type 1 or type 2. And then C-peptide more than 1.5 nanograms, definitely it is type 2. 90% of the patients belong to this category. And what are the clinical indications of C-peptide? The first indication, you should do C-peptide in all cases of type 1 diabetes. Because if you see here, there is a heterogeneity of C-peptide in type 1 diabetes. Now, in 15 to 40% of the patients, we have what is known as double diabetes. That is, they will have, actually, they will be type 1 diabetes, but they will not be lean. There will be some obesity or BMI will be high. In such patients, if you do C-peptide levels, it is slightly higher. So because of this, we have to do in all type 1 diabetes patients. And then even treatment. Some patients respond to liraglutide. We have seen Victoza being used, they respond to that. But if C-peptide is slightly more, or if C-peptide is like 0.7, 0.8, they respond to liraglutide. But very low C-peptide levels, they respond only to insulin, they don't respond to liraglutide. And then few cases, this is a 27 years old, and you can see the C-peptide levels in this patient, it was 0.010. So definitely it is type 1 diabetes. And of course, we did the antibodies, which was positive. And then this patient, very interesting, 22 years old, she came to our institute as type 1 diabetes. She was 1 year duration, positive. Both parents were positive for diabetes. And you can see she was on insulin 3 times, 30, 30, 30, and HbA1c was 11%. When we did fasting C-peptide, it was 2.37. So that's why type 2 diabetes was diagnosed. And we gave premix insulin twice and added metformin and glimepiride, of course, slowly titrated to the maximum dose. And after 3 months, we can get the HbA1c to 6.8%. If we had not done, this patient would have been on insulin for lifelong. And this is the most important message. Of course, now we have that precision medicine. By doing C-peptide and antibodies, definitely we can have precision medicine in our practice. Of course, these are the findings of that patient. And this is one more patient, actually 65 years old. We were surprised. This patient I saw almost 10 years back, 10.2% HbA1c, actually I think 40 years duration of diabetes. But when he did C-peptide, this is the patient. If you see this patient, definitely everybody will think this is type 2 diabetes because of his obesity and old patient. But when we did the C-peptide level, it was 0.010, stimulated C-peptide levels. He was type 1, treated for 40 years with insulin. And then, of course, several type 1 patients. This is actually type 1A patients. All fasting C-peptide were on the lower side, less than 0.6. GAD positive. These are all type 1A. But remember, we have one more, type 1B or idiopathic, fasting C-peptide less, GAD antibody negative. That is, even in type 1 diabetes also, we have antibody negative cases. That's why we should be careful in our practice. And second indication, you should not do in all cases of type 2 diabetes. C-peptide should not be done, but you can do in young type 2 diabetes less than 35 years, very poor response to 3 or 4 drugs, and then few insulin-treated patients with type 2 diabetes. And of course, most of the potential clinical applications of C-peptide is only hypothetical. Still no evidence is available because actually in type 2 diabetes patients, we get false results because of insulin resistance. And this is one of the case, again, young 17 years old boy, and initially his BMI was 28, ketone body is positive, but on doing C-peptide, his HbA1c was 11.5%. On doing C-peptide, you can see the results. Fasting 5.99, stimulated 8.33, so definitely is type 2 diabetes young. Of course, still he is taking OHS, almost 28 or 29 years now without any problems. And then this is again just to see one patient's HbA1c was very high, 17.3%, 598, 846 is the FPS and ppbs. Again, when we did the C-peptide levels, it was quite high, and we was treated with insulin and then insulin sensitizers, metformin and pioglitazone, and of course we can get the blood sugar to normal. This is the latest case very recently about a few months back. We saw this patient, 15 years old. Actually, this is published in CME India. His father was diabetic. We thought it is type 1 because of HbA1c 13.8%. But the C-peptide was 1.81. It was not towards type 1 diabetes, and GAD antibody was negative. We had given aspart and degludac, and after 15 days, you can see the results. His blood sugar was almost normal, but C-peptide has gone up, like fasting 4.75, 5.08. This is because of the glucotoxicity will go off and the beta cell function will improve. And one more thing, the important thing is the beta cell reserve in this patient was very good. So that's why, of course, we did a genetic analysis. It came out as GLIS3 gene. And this gene, when I searched the literature, it could be associated with type 1, type 2, and then MODY. But in this case, we clinically diagnosed it as type 2 diabetes and subsequently started with glimepiride 0.5 mg. And now his HbA1c is normal, and now we have stopped the glimepiride also. And of course, these are all the type 2 diabetes cases. You can see here, the fasting C-peptide is high in all the patients in spite of the higher HbA1c levels. And then next indication is identifying the MODY. I think Dr. Lakshmi had already talked about this. C-peptide, actually in MODY, what happens, there will be persistence of C-peptide levels. C-peptide will be normal. It will not be high, but it will be normal. So when we detect MODY, 60% of MODY will be due to HNF1 alpha or HNF4 alpha, and they respond well to sulfonylureas. Just I want to illustrate one case. This patient came to us. He was treated as type 1 diabetes, HbA1c 16.5%, and actually his fasting C-peptide and stimulated C-peptide was normal, anti-GAD antibodies were normal. Father and father's mother was positive for diabetes. So we sent this for genetic analysis to Chennai in Dr. Mohan's Diabetic Center. It came out as ABCC8 gene heterozygous mutation, MODY 12, and he was responsive to sulfonylureas. So we gave glimepiride 0.5 mg after stopping insulin. So again, this precision medicine is the illustration of this case is for precision medicine. And of course, next is the LADA. What is this LADA? This is between type 1 and type 2. We also call it as type 1.5 diabetes. And of course, this is one of the indications for C-peptide, and these are the different characteristics. I think this shown by Dr. Lakshmi already. And these are the key. And again, the next indication, detecting absolute insulin deficiency. So this fast, I think I'll take another 2 minutes, sir. I will take another 2 minutes. So fasting C-peptide level less than 0.08 nanograms per liter or 0.08, and stimulated is less than 0.6 nanograms per ml. So in such case, we can take it as absolute insulin deficiency. And then prediction for need of insulin. Depending upon the C-peptide levels, we can predict the need for insulin. And then this is bariatric surgery. Before subjecting patient for bariatric surgery, C-peptide is a must. If C-peptide is at the higher level, they respond well to bariatric surgery. When C-peptide is low, definitely you should not subject them for bariatric surgery. And then islet transplantation, of course, very slow C-peptide, low levels of 0.1 nanomoles can be taken for islet transplantation. And then differential diagnosis of hypoglycemia. Here, hypoglycemia due to exogenous insulin and insulinoma or for sulfonylureas can be differentiated. And of course, this is again one of the points, marker for duration of type 2 diabetes. Whether the duration is 16 or 26 years, C-peptide was higher level. So that's why this cannot be used as a marker for duration of diabetes. And this, the latest one, the clusters have been done in type 2 diabetes using C-peptide levels. This is the Mohan et al. Study. And then, of course, the gold standard, what ADA advises is mixed meal tolerance test stimulation and then glucagon stimulation test for C-peptide levels. And whether C-peptide can predict diabetes complications. Higher C-peptide patients will have more cardiovascular complications, and low C-peptide levels will have more microvascular complications. And then again, this usage of C-peptide in type 1 diabetes, of course, still we have not used therapeutically. They say a lot of advantages of using C-peptide, but clinically we have not used. So again, take-home message, finally, I think the overall, given its comparatively low cost, accuracy of measurement, and range of potential applications, measurement of C-peptide in clinical practice may be a valuable and cost-effective tool to select clinical management of type 1 or type 2 diabetes. And then in this era of precision medicine, C-peptide measurement may assist in clinical management of type 1 diabetes and selected cases of type 2 diabetes. I think I will dedicate this talk to Dr. Munichudappa sir. He is the father of diabetology in Karnataka, and then Dr. Narasimha Shetty, who lost him 4 months back. And I wanted to call him as the father of diabetology conferences in Karnataka, because I think he has done 2 national conferences and many state-level conferences. So, thank you.
Thank you for a very lucid lecture on C-peptide. You also told the indications and that the lab values change from lab to lab.
Yeah.
Only thing is one clarification. Can there be false positives and false negatives when you do C-peptide?
Yeah, madam. If actually, as I said, standardization is not there. In some labs, even if they give the reports, if they have done for several patients and if you see the different values, you can trust that. But C-peptide is being done very less. Some of the labs, we cannot rely on that. But especially if they have done several values. For example, in our institute, if they do, one patient will be 0.010, and if you see the next patient, it will be high. So that means there is a variation, and definitely, I think now even the immunoassay, what they do, it detects very, very low levels of C-peptide also, but it depends on the laboratories, madam.
Thank you. And regarding Dr. Narasimha Shetty, I would like to tell that he was one-man army, managing everything on his own. He
Yeah.
has conducted so many conferences.
And
Very
of course,
rightly.
for
very
KRSSD,
rightly,
probably
Yeah.
is one of the pillars.
we remember him with nostalgia. Thank you
No,
very much
thank
for the lecture.
We were all colleagues, Dr. Narsim Chetty, myself, Madam Kamath. We were all colleagues in Bangalore Medical College. It was a pleasure to work with him, and he was such a nice gentleman, and very sad that we lost him. And he is the main pillar, as Anil put it. He was instrumental in starting our RS Day conference in Bangalore. Thank you, Dr. Anil.
Thank you, sir. Thank you.
I think for want of time, I think there are no questions. Later, during the lunch time, you can clarify with
Dr.
Dr.
Sidney,
Anil.
sir, Dr. Sidney, sir, has a question.
I think only one question. Sydney is allowed only one question.
Yeah. This is only to congratulate Dr. Anil because if Dr. Narsim Shetty has improved the whole Karnataka Institute of Diabetology, Dr. Anil Kumar has done in the research part of it. And his number of publications which I see is something which is, one should really applaud him. For having said that, a small question. He was talking so much on C-peptide. We have a lot of patients who even after 25 years, they do not want to take insulin. Now, is there a way of using C-peptide assay or augmented C-peptide to tell them, look here, you have got no beta cells. Why don't you take insulin? Is there any? Is it a good thing to do?
Yeah, that's true, sir. If they definitely have very low peptide levels, you can ask them to take insulin by demonstrating them, and they will see the values, and we can definitely tell them that you need insulin. And of course, as you said, some of our patients will be having high C-peptide levels. That's why they respond to liraglutide, even SGLT2 inhibitors, even when the duration of diabetes is more. And then even Dr. Sidney sir is very interested in research. As we were judges in some of the research papers, he is very fond of research and he encourages research. Even he said in the open forum, I think at 12 o'clock we have to give chance for the research presentations in KRSSDI. Thank you, sir.
We can have a group photograph.
I thank Dr. Vasanta Kamath and Dr. Venkatarappa for chairing this session, and Dr. Anil Kumar for taking such a wonderful session on C-peptide. The next we have the presidential oration. How important is the diabetes education in the treatment of diabetes? The IDF says, the standard, we need to have 27 hours of education when the type 2 diabetes is newly diagnosed. So on this, our Dr. Suban sir will take it further in detail. Thank you.
I would request all of you all to be in the hall. I think the most interesting part of the session. How many of you all are excited to hear this? I'm sure all of us. So inviting the chairpersons for the day, Dr. Karthik Munachudappa, who's the physician and diabetologist in Bangalore, and Dr. Sidney D'Souza, who's the professor and head of medicine for Puya Medical College. Welcoming all, and Dr. Suman, who would be the speaker.
Before we start the session, I request all of the delegates outside, can you please come inside the hall? And if anybody is there, can you just bring them, ask them to come inside, please. Okay, so we shall start with the session. Now, one second. Just wait for only 30 seconds. Everyone, please come inside. So we'll move on to the presidential oration, prestigious session. For this, I invite our chairman, Dr. Suman R. Dr. Suman R, please. So before he starts giving his oration, we would like to first give him a felicitation. Can you bring the chair? So for this, can I invite our scientific chair, Dr. Manohar, Treasurer Dr. Suresh, Dr. Arvinda Jagdisha, immediate past Dr. Sydney D'Souza sir, to please come over the dais to felicitate, and Karthik Munichudappa, please join us. Yeah. Yes. So Dr. R. Suman, chairman for this organization, KRSSDI, in the last 2021 to 2022. Dr. Suman R., consultant diabetologist and occupational health physician, was born in Bangalore, 29 September 1974, to late Mr. Ramchandra, who was a retired accountant officer at High Court of Karnataka, and late Mrs. Chandramati. He did his school and college from Bangalore, so he's native of Bangalore. Dr. Suman R., in the journey in the field of medicine. He graduated from the prestigious Kempegoda Institute of Medical Science in 1999 and completed fellowship in diabetes from Karnataka Diabetes Club, affiliated to the M.S. Ramaya Institute of Medical Science in 2001. He also has done his post-graduation in occupational health at Sri Ramchandra University, Chennai in 2004. And after completing, he started practicing independently, and he started his own diabetes center called Madhumeha Diabetes Education and Treatment. Madhumeha Healthcare, which is a one-stop solution for employee healthcare and wellness. It's a center which will cater to occupational health of various occupational health centers in software companies, and to help and address the employees' health issues. So he has a staff strength of more than 250 currently, working for the cause. So Dr. Suman, Hospital and Mallige Medical Center, he has set up close to 50 medical units at various companies like Toyota, GE, Bosch, and etc. During his tenure as occupational physician, he was awarded the best medical service provider by GE company and Wipro, and also few other companies. Dr. Suman was also nominated by the Times Group as the rising star in the field of diabetes in 2020. Dr. Suman R. was very keen in the field of research too. He had been a co-investigator for various clinical trials done in Bangalore Diabetes Hospital, and he has done various phase 4 clinical trials in the field of diabetes. Dr. Suman R. has a passion to impart knowledge. He conducted various CMEs and conferences in the state chapter. He was also instrumental in developing a dog skill training program for doctors.
He's been an epitome of nephrology, and is a big guide and mentor to many of us who know him in and outside the hospital. Welcome, sir.
Next, we will be going to this right OAD for the right patient.
Thank you very much.
It was an excellent, the practical presentation from Dr. Manohar. We sincerely thank. And also I extend my thanks to Dr. Karnesh and Dr. Syed for chairing this session. So next, we will be moving on. The right, oh, sorry. Yeah.
So we are just delaying the inaugural for some time, and we'll have one more topic before the inaugural. So in MBA, I was taught segmentation and targeting. I think this is going to come in play here, where we talk about right OAD for the right patient. For this, we welcome Dr. Shrihari Kulkarni, who is a senior physician and diabetologist, Manipal Hospital, Yashwantpur, and Dr. Suresh KG, who is consultant physician and diabetologist at Manipal Hospital, Old Airport Road. And the speaker for today would be Dr. Mohan Badgandi.
Thank you very much. Good afternoon, everyone. Good afternoon, sir. It's an honor to introduce Dr. Mohan Badgandi. I know Dr. Mohan Badgandi does not need any introduction, but he is a senior diabetologist and endocrinologist at Manipal Hospital, Old Airport Road. He completed MBBS, MD, MRCP, and also FRCP. He has memberships in many esteemed medical societies and also has research experience in various clinical trials. Over to you, sir. Thank you.
Thank you very much. Thank you very much, RSSDI. Thank you very much, Scientific Committee, as well as the Karnataka chapter of Central RSSDI. My topic has been made simpler by the previous speakers. So let's straight away move on to the topic. My topic today is right OAD for right patient. I think the days are gone when we used to talk in terms of, say, I'm a gray head, so the patient should take what I write on the prescription. Those days are gone. I think today we need to be really based on evidence-based medicine and also on having a conversation with the patient, as well as considering what is the natural history of the disease. So these three things rule the treatment prescription that you hand over to the patient. So if you look at the approach, my talk will cover the patient-centric approach, as well as how we manage hyperglycemia, and what is the overall approach, that is, what are the molecules that are available, what are the new concepts in this treatment, and also what are the pharmacological variations that we use, and what are the take-home points. Now, if you look at patient-centric approach, I think the most important part of this phase is that you need to have a conversation with the patient. You need to understand what is the patient's concept about the disease and what the patient has to say. And if you don't talk to the patient, or if you don't spend 5 minutes with the patient, you are not likely to achieve or build a rapport, and the results will be disastrous. So that's why I think it is very important you gauge the patient's preferred level of involvement, involve the patient in decision making, and you share the decision making along with the patient's relatives, or the patient's family. And also explain all the choices, therapeutic choices, and also use what decision making aids you are going to use, explain to the patient. And this is very important. And also, if the patient has been referred to you by a family physician or another physician, also have a communication established with that, that line, so that you can explain what you are doing. And then finally, you must continue using lifestyle modification program in all these decision making. So you have a lot of molecules now available. I think it is wise to divide the molecules based on the recent concept, that is insulin-dependent pathway, the molecules which act on the insulin-dependent pathway and insulin-independent pathway, because these two are very important in understanding the oncoming problems that you face in the outpatient. If you remember that diabetes endocrinology is mostly an outpatient discipline, and most of your patients will come to the OPD. Once you start the treatment, they'll be in touch with you, and if you have established a diabetes helpline or a diabetes nurse educator, they'll be contacting you. So that is why I think it is very important to know that there are three molecules, that is metformin and SGLT2 DPP4 inhibitors, and also acarabose derivatives. These act on the insulin-independent pathway. And there are sulfonylureas which act on the insulin-dependent pathway. Why this is important? Because the hypoglycemic events and weight gain are indirectly related to the usage of these molecules. So you have various molecules. I'm not going to go into each molecule and how many milligrams to use it. These data is available on all the national formularies. You can follow that, and you can have your own way of treating your type 2 diabetes patients. So now, decision cycle for patient-centric glycemic management in type 2 diabetes. The most important thing is, when you talk to the patient, what is important is the duration of diabetes. And diabetes, along with it, what are the other comorbidities? And diabetes and complications, that is another important. And what the patient is already on, what is the patient's present medications, and how many times the patient has been admitted to the hospital for diabetes complications or diabetes related problems. And then how much is the support that patient is getting from his family physician and the family. Both are very important. Now, if you look at, there are two approaches. Either you can follow the ADA guidelines or a NICE guidelines or RSSDI guidelines, or you can follow guidelines from your own practice, which has given you a lot of confidence and a lot of insight into the patient population that you are dealing with. So when you look at your own experience or the guidelines, the most important again comes back is the duration of diabetes and what is the HbA1c when the patient is presenting to you, and then what is the patient presents when the patient presents to you, what is the fasting blood glucose or the daytime blood glucose. These are very important, along with the comorbidities and what are the other medications that the patient is taking. Now, if you look at glucose lowering medications, again, these are indirectly related to whatever historical data you have accumulated. So if you look at NICE guidelines, this is something very useful and very simple to follow, and this is followed all over United Kingdom and many European countries, and this is purely based on clinical practice guidelines or good clinical practice GCP guidelines. And then here you have again those which are insulin independent pathway and those which are dependent on insulin dependent pathway. So person's HbA1c not controlled below individually agreed threshold, or the person develops any cardiovascular event or a complication, large vessel or a small vessel disease, you decide whether the patient needs oral antidiabetic therapy, oral plus insulin in order to achieve good glycemic control as early as possible. So now, if you move further from this, always it is very important to stratify the risk or stratify the complications. If the patient is at a higher risk, you try to find out what are the arterial risk factors that the patient has got when he comes to your clinic. Like for example, smoking, hypertension, dyslipidemia, and as we have been discussing, waist-hip ratio or BMI or his simple, body weight, more than ideal body weight. So these are very good indicators for you to decide about the treatment modality. And also look at the other side of the coin, that is what complications the patient already has. For example, small vessel disease, large vessel disease, patient has undergone some bypass surgery, peripheral vascular disease surgery, or the patient has undergone PTCA and he's at a higher risk, or he's, the daily activities are restricted. So these are the things that one needs to have. So if you look now at individual points, you take HbA1c. If the patient presents to you with a HbA1c of 7.5%, and if you want to start one medication, you are most welcome to do that, and the patient is likely to respond very well to that. You can either start metformin if he's overweight or obese, and you can also add SGLT2, which works very well in obese or overweight patients, and you can get a good glycemic control within a short time. And if the patient has more than 9% HbA1c, the patient will need also a basal insulin or a sulfonylurea along with these baseline drugs like metformin and SGLT2. Now, the guidelines, AACE or the ADA will tell you the same thing, that cutoff point of 8.5 to 9% HbA1c is called as the uncontrolled type 2 diabetes. Once you have a patient in front of you with the HbA1c which is higher, also try to correlate and find out what is his fasting blood sugar if he's monitoring at home. If it is more than 160, 170 milligrams, and if the daytime blood sugar is more than 270, 275, then definitely he needs either a basal insulin or a basal plus insulin along with the OADs in order to get a good glycemic control. And once the patient is on these medications, the blood sugar starts to improve, you see him more frequently, and once his targets are achieved, you can start seeing him once in 3 months. That is a regular pattern of seeing patients, and you can do once in a year annual review for all these patients. So the comorbidities are very important because they also reduce the quality of life, and they'll be on multiple medications. They may interfere with your OADs, and sometimes the patients may be depressed because they are taking so many medications and so many problems they have. That is why it is good to know. And many times you have patients with COPD, bronchial asthma, or SLE, or rheumatological disorders where the patient will be taking steroids. And these patients will have a higher blood sugars in the daytime as compared to the fasting or the late night blood sugars. These patients need to have a good dose of sulfonylureas in the morning or insulin in the morning so that the daytime blood sugars are well controlled in these patients. And if somebody has got a large vessel disease, I think it is, along with the OAD, it is better to add a basal insulin in order to have a good glycemic control. And most of these patients will already be on an optimum dose of sulfonylureas, like for example, glimepiride 2 milligram twice a day, or 2 milligram in the morning, and 1 milligram with a smaller meal, and 1 more milligram with the late supper or a dinner. So these things will help you in the management of type 2 diabetes. Now, if there is no large vessel disease in your patient, what are you looking at? How to improve the quality of life in these patients? So you want to make sure that the patient does not gain weight. Why our patients gain weight? Most of the time, it is a defensive snacking that is giving rise to weight gain rather than sulfonylureas or insulins. Most of the time, insulins give rise to about 2 to 4 kg of weight gain and not 10 kg. Most of the patients start defensive snacking in order to prevent hypoglycemia, and that is how they gain weight. And the other compelling factor is that you want to restrict or you want to reduce nocturnal hypoglycemia as well as you want to reduce daytime hypoglycemia in your patients. And how to do that? You want to minimize giving a larger dose of sulfonylurea at night or a larger dose of short-acting insulin before dinner so that the patient is more comfortable. Also encourage your patient to have a bedtime snack. He can have a small sandwich or a couple of biscuits with a buttermilk, something like that, which gives him a little bit of more calories before he goes to sleep. These small tips will help the patient to have a better quality of life. Then cost is the last factor, but of course we can't do much about the cost factor. We need to really discuss with the patient and the patient's family what they can afford and what they cannot afford. So when we have taken care of all the other factors, the cost factor does come into play. But if you can help them with the pharmaceutical industry or the NGOs, you can help the patient, and that will be very useful in our day-to-day management. But ultimately, we need to really achieve good glycemic control, and HbA1c should be closer to 7%, and fasting blood sugar should be closer to 100 to 120, and daytime blood sugar should not cross 160. And this is our target today. And we can achieve this with sulfonylureas and SGLT2 metformin in the first, say, 4 to 6 years of duration of diabetes. After that, majority of our patients do need insulin. And the best insulin to start is the basal insulin, which is a longer acting, flatter, and Glargine is one of the best insulins that we have seen through after doing origin study where the patients were on insulin for almost 7 to 8 years with a good glycemic control and without any increase in hypoglycemic events. So these are the few tips that you can take home when you think in terms of establishing an algorithm. Cost-effective glycemic control algorithms are available where you start with metformin, add either sulfonylurea or SGLT2 if the patient is on normal weight. Sulfonylureas are good. And if the patient is obese or overweight, you can give SGLT2. And then if the control is not achieved, you can add sulfonylurea. And if the patient cannot tolerate 3 drugs or cannot achieve control, then you can add a basal insulin and try to prevent or delay the complications. That is, our ultimate aim is to prevent or delay the complications and reduce the hypoglycemic events and weight gain and improve the quality of life. So glycemic control algorithms again take into consideration not only the cost factor, also the quality of life. And then patient preferences are very important in all these discussions, and that is most, and take home messages, as I told you, most professional societies do not get involved with cost factor and do not get involved with the conversation of the patient, and it is very important to establish a good rapport with the patient and have a patient-centric approach. And the third thing is shared care approach is very good, and you take into consideration what are the patient's needs, what the patient can afford, what the patients can or the family can support, and also look at what is the availability in the area and what is affordable by the community, and also whether HbA1c can be achieved, the patient can improve quality of life and continue to be active and also productive in his life. Thank you very much.
Thank you, sir, for a nice deliberation. After the lifestyle modification, which drug to choose is very, very important. You mentioned it rightly. If patient has ASCVD or heart failure, which drug to be chosen. And also now the SGLT2 inhibitors have become cheaper. We can use for large number of populations. Any questions from the audience? Somebody give mic there.
Thank you, sir. That was an excellent presentation. My question is, you mentioned somebody having a HbA1c of 9, it is better to start a basal insulin along with glucose lowering drugs. And thing is, once the HbA1c comes down below 8.5, do you suggest continuing basal insulin or?
It depends on the duration of diabetes. If somebody has got diabetes less than 6 to 8 years duration, you can stop the basal insulin and see. If the patient's duration of diabetes is more than 8 to 10 years, probably that patient will need basal insulin.
And my one more question
And
is,
also another important factor or the parameter that you can look at it is if the patient's fasting blood sugar or the pre-breakfast blood sugar is going up and up when you stop insulin, that is a clear indication that the patient's insulin secretion at night is more defective and he needs a basal insulin.
and coming
irrespective of duration of diabetes.
Okay, thank you. Coming to the hypoglycemia events, basal insulins, they don't have a peak, and metformin is not known to cause hypoglycemia. Then when it is combined, of course, sulfonylureas, they are known to cause hypoglycemia. If we combine metformin with a gliptin along with basal insulin, will it still cause hypoglycemia?
Many of our patients have hypoglycemia not just because we are giving them metformin and insulin. Many of them develop renal impairment, septic focus, chronic liver disease. Sometimes the patients are taking steroids in the morning. You are not aware of that. So these are the factors, hidden factors that if you're not taken into history, this is very important. That is one of the reasons why patients get into hypoglycemia, and you start wondering why my patient is having hypoglycemia when he's taking only metformin.
Thank you.
Also, due to skipping of the meals, they can get hypoglycemia. Any other questions? If there are no questions, we'll wind up the session.
We can have a group photo of the speaker and chair. Thank you, Dr. Mohan Burgundy, for enlightening us with such an important topic, and thanks to the chairperson. Now we move on to our Indian culture, where we'll move on to the inaugural function. For this, I would like to invite Dr. Surekha Shetty, who would like to share a few words before we start.
Well, I'm just here to announce that the program is delayed slightly. Before that, I have an important announcement to make. While we have scientific session, the most important aspect is take-home messages. So many of our speakers have been giving us important messages. What have you learned from it? That will be tested through the quiz that is being sent to your WhatsApp mobiles. So please look at it, answer it, be sport, which aims at generating interest in diabetology and also to stimulate your brain cells. We'll be looking forward to interacting with you. Do sit through the sessions. There are many points that will be asked in that quiz. So we'll be waiting to host you the last session of tomorrow, postgraduate quiz on diabetology. So with that, I think we pause for a minute here because we are awaiting the arrival of our chief guest. Possibly we can take it forward by interaction or any questions that are further there.
If anyone has any questions, you are most welcome to ask the questions to the concerned person.
I think it's now important to make the waiting period also more interesting. Probably we won't need that. Our chief guest is here.
afternoon, delegates. It's time to start the inaugural function. Our Honorable Minister for Health and Family Welfare of Karnataka has arrived. And I invest Dr. K. Sudhakar to please grace the stage. Along with, I invite our guest of honor, Dr. Sudarshan Ballal, to also give. I invite all the chair. Sir. So, since we'll yes, now without any delay, we will start with the invocation. I'll call upon Ms. Yukta Naidu to start on the invocation song.
पार्वती नंदन बालगणेश पार्वती नंदन बालगणेश विघ्न विनाश वरद गणेश विघ्न विनाश वरद गणेश सुरमुनिवन्दित सुमुख गणेश सुरमुनिवन्दित सुमुख गणेश सुन्दरवदन ज्ञान गणेश सुन्दरवदन ज्ञान गणेश पार्वती नंदन बालगणेश पार्वती नंदन बालगणेश. I request all to stand for the state anthem. जय भारत जननीय तनु जाते जय हे कर्नाटक माते जय सुंदर नदिवनಗಳ ನಾಡೆ जय हे रस ಋಷಿಗಳ ಪೀಡೆ जय भारत जननीय तनु जाते जय हे कर्नाटक माते ಭೂದೇವಿಯ ಮಕುಟದ ನವಮಣಿಯೇ ಗಂಧದ ಚಂದದ ಹೊನ್ನಿನ ಗಣಿಯೇ ರಾಘವ ಮಧುಸೂದನರವತರಿಸಿದ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ಜಯ ಹೇ ಕರ್ನಾಟಕ ಮಾತೆ ಜನನಿಯ ಜೋಗುಳ ವೇದದ ಘೋಷ ಜನನಿಗೆ ಜೀವವು ನಿನ್ನಾವೇಶ ಹಸುರಿನ ಗಿರಿಗಳ ಸಾಲೆ ನಿನ್ನಯ ಕೊರಳಿನ ಮಾಲೆ ಕಪಿಲ ಪತಂಜಲ ಗೌತಮ ಜಿನನುತ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ जय हे कर्नाटक माते जय हे कर्नाटक माते जय कर्नाटक जय हिंद.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಸ್ವಲ್ಪ ಪ್ರೋಟೋಕಾಲ್ ಚೇಂಜ್ ಆಗಿದೆ. ಅಫಿಷಿಯಲಿ ನಿಮ್ಮನ್ನೆಲ್ಲ ಕೂಡ ನಾನೇ ಇನಾಗ್ರೇಟ್ ಮಾಡ್ತೀನಿ. ಎಲ್ಲರೂ ನಿಮಗೆ ಇನ್ವೈಟ್ ನಾನೇ ಮಾಡ್ತೀನಿ. ಇವತ್ತು KRSSDIನ ಅಧ್ಯಕ್ಷರಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಸುಮನ್ ಅವರೇ, ನನ್ನ ಆತ್ಮೀಯರು, ಹೆಸರಾಂತ ಖ್ಯಾತ ವೈದ್ಯರಾಗಿರ್ತಕ್ಕಂಥ ನಮ್ಮ ಡಾಕ್ಟರ್ ಬಳ್ಳಾಲ್ಜಿಯವರೇ, ಸುದರ್ಶನನ್ ಬಳ್ಳಾಲ್ ಅವರೇ, ಈ ಒಂದು ಸಂಸ್ಥೆಯನ್ನು ಮೊದಲು ಕಟ್ಟಿದಂಥ ಡಾಕ್ಟರ್ ಮುನಿ ಚೌಡಪ್ಪನವರೇ, ಡಾಕ್ಟರ್ ಮನೋಹರ್ ಅವರೇ, ಡಾಕ್ಟರ್ ಸೈಯದ್ ಅಜ್ವಾರ್ ಅವರೇ, ಡಾಕ್ಟರ್ K ವಿಜಯ್ ಕುಮಾರ್ ಅವರೇ, ಡಾಕ್ಟರ್ ಶೇಖರ್ ಅವರೇ, ವೇದಿಕೆ ಮೇಲೆ ಉಪಸ್ಥಿತಿರುವ ಎಲ್ಲ ಖ್ಯಾತ ವೈದ್ಯರುಗಳೇ, ಮುಂಭಾಗದಲ್ಲಿ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಭಾಗಿಯಾಗಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ ವೈದ್ಯ ಸಹೋದರ ಸಹೋದರಿಯರೇ, ಮಾಧ್ಯಮ ಗೆಳೆಯರೇ, ಇಟ್ಸ್ ಇಂಡೀಡ್ ಎ ಗ್ರೇಟ್ ಪ್ರಿವಿಲೇಜ್ ಆ್ಯಂಡ್ pleasure mine that I am able to be a part of this meaningful summit of KRSSDI. This is the third conference summit today I am attending. The first was organized by the Kumar. It's based on mental health issues, from disability to ability ಅಂತೇಳಿ ಅವರ ಘೋಷವಾಕ್ಯ. Secondly, I had to attend the FANA's conference on national health. ಅದೇ ಥರನೇ ಇವತ್ತು ಮೂರನೇದು, ದಿಸ್ ಇಸ್ ಆನ್ ಸ್ಟಡಿ ಆಫ್ ಡಯಾಬಿಟೀಸ್ ಇನ್ ಇಂಡಿಯಾ ಆ್ಯಂಡ್ ಕರ್ನಾಟಕ. And in between I had to go for one cabinet subcommittee very important meeting. ಇದಾದ ಮೇಲೆ ಮತ್ತೆ ಖಾದಿ ಗ್ರಾಮೋದಯದ್ದು ಒಂದು ಕಾರ್ಯಕ್ರಮ ಚಿಕ್ಕಬಳ್ಳಾಪುರಲ್ಲಿದೆ. ಅದಕ್ಕೋಸ್ಕರನೇ ನಾನೇ ತಡವಾಗಿ ಬಂದು ಭಾಳ ಬೇಗ ಹೋಗುವಂಥ ಕಾರ್ಯಕ್ರಮ ಇದೆ. ಆದರೆ ಐ ವಾಂಟೆಡ್ ಟು ಬಿ ಎ ಪಾರ್ಟ್ ಆಫ್ ದಿಸ್ ಕಾನ್ಫರೆನ್ಸ್, though it is for a brief time. I wanted to make a point that I had to be, because our department and our government is very committed to address the issues on diabetes. So this we wanted to make it a statement by being physically present for this very important conference. So ಈಗ 360 degrees diabetes ಅಂತ ಹಾಕಿದ್ದೀರಿ. ಇದರಲ್ಲಿ ಮೊದಲನೇದು ಲೈಫ್ ಸ್ಟೈಲ್. ಈ ಲೈಫ್ ಸ್ಟೈಲ್ ನೋಡಿದಾಗ ನಾನು ಮಾತನಾಡ್ಬೋದಾ ಬೇಡವಾ ಅಂತ ಅನಿಸಿದೆ. ಯಾಕೆಂದರೆ ರಾತ್ರಿ ಬೆಳಗಿನ ಜಾವ 2 ಗಂಟೆಗೆ ಮಲಗುವಂತಾಯಿತು. ಬೆಳಗ್ಗೆ 5:30 ಎದ್ದು ಕಾರ್ಯಕ್ರಮಗಳು ಸ್ಟಾರ್ಟ್ ಆಗಿದೆ ನನಗೆ. ಅಂದರೆ ಸ್ಲೀಪ್ ಈಸ್ ಎ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್ ಕಾಂಪೊನೆಂಟ್ ಆಫ್ ಎ ಲೈಫ್ ಸ್ಟೈಲ್, ನಮಗೆಲ್ಲ ಗೊತ್ತಿದೆ. ಸೊ ಆ ಸ್ಲೀಪ್ ಡಿಪ್ರಿವೇಷನ್ ಆಗ್ಬೋದು, ಡಿಪ್ರೈವ್ ಆದರೆ ಮತ್ತು ರೆಗ್ಯುಲರ್ ಫಿಸಿಕಲ್ ರೆಜಿಮೆಂಟ್ ಇಟ್ಕೊಳ್ಳದೆ ಹೋದರೆ, ಫಿಸಿಕಲ್ ಎಕ್ಸಸೈಸ್ ಇಲ್ಲದೆ ಇದ್ದರೆ, ಮತ್ತು ರೈಟ್ ಈಟಿಂಗ್ ಹ್ಯಾಬಿಟ್ಸ್ ಇವ್ಯಾವು ಇಲ್ಲದೆ ಇದ್ದರೆ, ಇವತ್ತೇನು ಇಂಡಿಯಾನ ನಾವೊಂದು ಅಪವಾದವನ್ನು ಹೊರತಾ ಇದ್ದೀವಿ. ಏನಂತ? ಮಧುಮೇಹಕ್ಕೆ ಇಡೀ ವಿಶ್ವಕ್ಕೆ ನಾವು ರಾಜಧಾನಿ ಆಗಿದ್ದೀವಿ. ವಿ ಹ್ಯಾವ್ ಬಿಕಮ್ ದ ಡಯಾಬಿಟೀಸ್ ಕ್ಯಾಪಿಟಲ್ ಆಫ್ ದ ವರ್ಲ್ಡ್. ಅನ್ಫಾರ್ಚುನೇಟ್ಲಿ ನಾವು 80s ಕೂಡ ನನಗೆ ತಿಳಿದಂಗೆ ಪ್ರೊಸೆಸ್ಡ್ ಶುಗರನ್ನು ನಾವು ಯೂಸ್ ಮಾಡ್ತಾ ಇಲ್ಲ. ರಿಫೈನ್ಡು ಪ್ರೊಸೆಸ್ಡ್ ಶುಗರ್ಸು ಭಾಳ ಕಡಿಮೆ ಇತ್ತು. ಅದಕ್ಕೆ ಮುಂಚೆ ಎಲ್ಲ ಈ ಆಲೆ ಮನೆಗಳು, ಎಷ್ಟು ಜನಕ್ಕೆ ಗೊತ್ತಿದೆ ಇಲ್ಲಿ ಗೊತ್ತಿಲ್ಲ ನನಗೆ, ಈ ಬೆಲ್ಲವನ್ನು ಉಪಯೋಗ ಮಾಡ್ತಾಯಿದ್ವಿ ನಾವು. ಆರ್ಗ್ಯಾನಿಕ್ ಅಂತ ಏನು ಹೇಳ್ತೇವೆ, ಬೆಲ್ಲವನ್ನು ನಾವು ಉಪಯೋಗ ಮಾಡ್ತಾಯಿದ್ವಿ. ಇವತ್ತು ನಮ್ಮ ಆಹಾರ ವೈವಿಧ್ಯತೆಯಲ್ಲಿ ಬದಲಾವಣೆ ಆಗಿಬಿಟ್ಟಿದೆ. ಭಾಳಷ್ಟು ನಮ್ಮ ಮಕ್ಕಳು, ವಯಸ್ಕರು, ಹಿರಿಯರು ಇವರೆಲ್ಲ ಕೂಡ ನಮ್ಮ ಒಂದು ಏನು ವೇಗದ ಓಟ ಇದೆ ಆಧುನಿಕ ಜಗತ್ತಿನಲ್ಲಿ, ಅಭಿವೃದ್ಧಿ ಅನ್ನುವಂಥ ಹೆಸರಿನಲ್ಲಿ ಡೆವಲಪ್ಮೆಂಟ್ ಅನ್ನೋದು, ಆ ಡೆವಲಪ್ಮೆಂಟಿಂದ I don't know really whether we should say we are developing or we are in the regressive mode. ಇದು ಆರೋಗ್ಯದ ದೃಷ್ಟಿಕೋನದಿಂದ ನೋಡಿದರೆ ನಾವೆಲ್ಲೋ ಹಿಂದ್ಗಡೆ ಹೋಗ್ತಾ ಇದ್ದೀವಿ ಅನಿಸುತ್ತೆ. ಓಕೆ, ಜನ ಹೇಳ್ಬೋದು ನಮ್ಮ ಲೈಫ್ ಸ್ಪ್ಯಾನ್ ಭಾಳ ಚೆನ್ನಾಗಾಗಿದೆ, ನಾವೇನು ಸ್ವಾತಂತ್ರ್ಯದ ಸಂದರ್ಭದಲ್ಲಿ ನಮ್ಮದೆಲ್ಲ 50-55 ವರ್ಷ ಲೈಫ್ ಸ್ಪ್ಯಾನ್ ಅಂತ ಏನು ಸರಾಸರಿ ಇತ್ತು, ಈಗ 65ಕ್ಕೆ ಬಂದುಬಿಟ್ಟಿದ್ದೀವಿ, ಕೆಲವು ಸಂದರ್ಭದಲ್ಲಿ 70 ಇದೆ. ಹಾಗಾಗಿ ಆರೋಗ್ಯದ ಇಂಡಿಕೇಟರ್ಸ್, ಹೆಲ್ತ್ ಇಂಡಿಕೇಟರ್ಸು ಇದೆಲ್ಲ ಕೂಡ ಭಾಳ ಇಂಪ್ರೂವ್ ಆಗಿದ್ದೀವಿ ಅಂತ ನಾನು ಯಾವಾಗಲೂ ಹೇಳ್ತೀನಿ. ನಾವು ಇಟ್ ಈಸ್ ನಾಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಹೌ ಲಾಂಗ್ ವಿ ಲಿವ್, ಹೌ ವೆಲ್ ವಿ ಲಿವ್. ಇದು ನಮ್ಮ ಕಾನ್ಸೆಪ್ಟ್ ಆಗಬೇಕು. ಹೌ ವೆಲ್ ವಿ ಲಿವ್ ಅಂತಂದರೆ ಇವತ್ತು ನಮ್ಮ ಡಯಾಬಿಟೀಸು, ಹೈಪರ್ ಟೆನ್ಷನು, ಬಿಕಾಸ್ ಆಫ್ ದಿಸ್ 10 ವರ್ಷ ಕೆಲವರು ನಮ್ಮ ಡಾಕ್ಟರ್ ಬಳ್ಳಾಳ್ರಿ ಅಂತ ತಿಳ್ಕೊಳ್ತಾರೆ ಗೊತ್ತಿಲ್ಲ. ನಾನು ಇದರಲ್ಲಿ ಮೆಂಬರ ಸರ್ ಅಂತ ಕೇಳಿದೆ. ಇಲ್ಲ, ನನಗೆ ಡಯಾಬಿಟೀಸು ಬ್ರೆಡ್ ಆ್ಯಂಡ್ ಬಟರ್ ನಮಗೆ ಕಿಡ್ನಿಗೆ ಅಂತ ಹೇಳಿದರು. ಹಾಗಾಗಿ ಇವತ್ತು ನಿಜವಾಗಿಯೂ ನಾನು ಕೂಡ ಈಗ 30,000 ಸೈಕಲ್ಸನ್ನ ನಾವು ಸರ್ಕಾರದಲ್ಲಿ ಡಯಾಲಿಸಿಸ್ ಮಾಡ್ತಾ ಇದ್ವಿ. ಬಟ್ ದಿಸ್ ಇಯರ್ ವಿ ಹ್ಯಾವ್ ಅಂಡರ್ಸ್ಟುಡ್ the dialysis cases are going up. So we have doubled this year. From 30,000, we have increased to 60,000 cycles per day in government institutions. ಇದರ ಜೊತೆಗೆ ಪ್ರೈವೇಟ್ ಸೆಕ್ಟರ್ ಇದೆ. ಸೊ ನನ್ನ ಪ್ರಕಾರ 1.5 ಲಕ್ಷ ಸೈಕಲ್ಸ್ ಪರ್ ಡೇ ಆಗ್ತಾ ಇದೆ ಇವತ್ತು ರಾಜ್ಯದಲ್ಲಿ. ಸೊ ದಿಸ್ ಈಸ್ ಅನ್ ಅಲಾರ್ಮಿಂಗ್ ನಂಬರ್. ಅದರ ಮೂಲಕ ಏನಾಗ್ತಾ ಇದೆ, ಮಾರ್ಬಿಡಿಟಿ, ಮಾರ್ಟಾಲಿಟಿ, ಡಿಫಾರ್ಮಿಟಿ ಇವೆಲ್ಲ ಕೂಡ ಹೆಚ್ಚಾಗ್ತಾ ಇದೆ. ಅದಕ್ಕೋಸ್ಕರ ನಾವು ಎನ್ ಸಿ ಡಿ ಕ್ಲಿನಿಕ್ಸು, ಅವೇರ್ನೆಸ್, ದಟ್ ಈಸ್ ವೈ ದ ಹೋಲ್ ಕಾನ್ಸೆಪ್ಟ್ ಏನಿರಬೇಕು ನಮ್ಮ ಹೆಲ್ತ್ ಕೇರಲ್ಲಿ ಅಂತಂದರೆ, ಒನ್ ಈಸ್ ಪರ್ಸನಲೈಸ್ಡ್, 4 ಪೀಸ್: ಪರ್ಸನಲೈಸ್ಡ್, ಪ್ರಿವೆಂಟಿವ್, ಪ್ರಿಡಿಕ್ಟಿವ್ ಆ್ಯಂಡ್ ಪಾರ್ಟಿಸಿಪೇಟರಿ. ದ 5th ಪಿಲ್ ಅನ್ನೋದನ್ನ ಅವಾಯ್ಡ್ ಮಾಡಬೇಕು ನಾವು. ಹಾಗಾಗಿ ಯಾವಾಗಲೂ ಕೂಡ ಡಾಕ್ಟರ್ ಸೆಂಟ್ರಿಕ್ ಹೆಲ್ತ್ ಕೇರ್ ಇತ್ತು. ಫ್ರಮ್ ಡಾಕ್ಟರ್ ಸೆಂಟ್ರಿಕ್ ಹೆಲ್ತ್ ಕೇರಿಂದ ವಿ ಶುಡ್ ಮೂವ್ ಟುವರ್ಡ್ಸ್ ಪೇಷಂಟ್ ಸೆಂಟ್ರಿಕ್ ಹೆಲ್ತ್ ಕೇರ್. ಹಾಸ್ಪಿಟಲ್ ಎನ್ವಿರಾನ್ಮೆಂಟಿಂದ ಹೋಮ್ ಎನ್ವಿರಾನ್ಮೆಂಟಿಗೆ ತರಬೇಕು ನಮ್ಮ ಹೆಲ್ತ್ ಕೇರು. ಇವತ್ತು ಪ್ಯಾರಾಡೈಮ್ ಶಿಫ್ಟ್ ಆಗಿದೆ. ಟೆಕ್ನಾಲಜಿ ಹಸ್ ಕಮ್ ಇನ್. ಟೆಕ್ನಾಲಜಿ ಈಸ್ ಹೆಲ್ಪಿಂಗ್ ಅಸ್ ಟು ಎ ಗ್ರೇಟ್ ಡೀಲ್. ಬಟ್ ನನ್ನ ಪ್ರಕಾರ ಹೆಲ್ತ್ ಕೇರಲ್ಲಿ ಇಂಪ್ರೂವ್ ಆಗಬೇಕು ಅಂತಂದರೆ ಖಂಡಿತವಾಗಿಯೂ ಅವೇರ್ನೆಸ್ ಹೆಚ್ಚಾಗಬೇಕು. ಪ್ರಿವೆನ್ಷನ್ ಈಸ್ ದ ಬೆಸ್ಟ್ ಫಾರ್ಮ್ ಆಫ್ ಇದು ನಾವು ಪ್ರೋಗ್ರೆಸ್. ಹಾಗಾಗಿ ದಟ್ ಈಸ್ ವೈ ಅವರ್ ಗವರ್ಮೆಂಟ್, ಅವರ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಈಸ್ ಡೂಯಿಂಗ್ ಆಲ್ ಇಟ್ಸ್ ಬೆಸ್ಟ್ ಇನ್ ಇಂಪ್ರೂವಿಂಗ್ IEC. ಇನ್ಫಾರ್ಮೇಷನ್, ಎಜುಕೇಷನ್, ಕಮ್ಯುನಿಕೇಷನ್ ಇದ್ದರೆ ಜನರಿಗೆ ನಿಜವಾಗಿಯೂ ಕೂಡ ಅವೇರ್ನೆಸ್ ಪ್ರೋಗ್ರಾಮ್, ಬಿಕಾಸ್ ಆಫ್ ದ ಪಾವರ್ಟಿ, ಬಿಕಾಸ್ ಆಫ್ ಲ್ಯಾಕ್ ಆಫ್ ಎಜುಕೇಷನ್, ಬಿಕಾಸ್ ಆಫ್ ಲ್ಯಾಕ್ ಆಫ್ ಅವೇರ್ನೆಸ್, ಡಿಸ್ಪ್ಯಾರಿಟಿ ಬಿಟ್ವೀನ್ ರೂರಲ್ ಆ್ಯಂಡ್ ಅರ್ಬನ್ ಏರಿಯಾಸ್, ಇದೆಲ್ಲ ಕೂಡ ದೀಸ್ ಆರ್ ಆಲ್ ದ ಪ್ರಾಕ್ಟಿಕಲ್ ಇಂಪೆಡಿಮೆಂಟ್ಸ್ ವೈ ವಿ ಆರ್ ನಾಟ್ ಏಬಲ್ ಟು ಡೂ ಬೆಟರ್ ಇನ್ ಲಾಟ್ ಆಫ್ ಹೆಲ್ತ್ indicators. Even while we compare to South India, in terms of MMRs, IMRs, ಇನ್ನೂ ಕೂಡ ಓವರಾಲ್ ನ್ಯಾಷನಲ್ ಹೆಲ್ತ್ ನೋಡಿದಾಗ ಇಂಡಿಕೇಟರ್ಸು ಕರ್ನಾಟಕ ಈಸ್ ಡೂಯಿಂಗ್ ಮಚ್ ಬೆಟರ್ ದೆನ್ ದ ನ್ಯಾಷನಲ್ ಜನರಲ್ ಹೆಲ್ತ್. ಬಟ್ ವೆನ್ ವಿ ಕಂಪೇರ್ ಟು ಕೇರಳ ಆರ್ ತಮಿಳ್ನಾಡು, ವಿ ಆರ್ ಸ್ಟಿಲ್ ಲ್ಯಾಗಿಂಗ್. No doubt in the last 7-8 years we are improving. In the especially last 2-3 years, even despite COVID, we are doing better. ಇವತ್ತು ನಾವು NCD clinics, or what we call as health and wellness clinics and sub-centers, is now called as health and wellness centers. ಆರೋಗ್ಯ ಮತ್ತು ಕ್ಷೇಮ ಕೇಂದ್ರ ಅಂತೇಳಿ. ಇವತ್ತು PHCs, sub-centers, ಇಲ್ಲಿ NCDs ಜಾಸ್ತಿ ಮಾಡ್ತಾ ಇದ್ವಿ ಸ್ಕ್ರೀನಿಂಗ್. ಡೇಟಾ ಈಸ್ ಎವ್ರಿಥಿಂಗ್. ಬಿಗ್ ಡೇಟಾ ಈಸ್ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್. ಇವತ್ತು ಎಷ್ಟು ಜನ ನಮ್ಮಲ್ಲಿ ಡಯಾಬಿಟೀಸ್ ಪೇಷಂಟ್ಸ್ ಇದ್ದಾರೆ, ಹೈಪರ್ಟೆನ್ಸಿವ್ ಪೇಷಂಟ್ಸ್ ಇದ್ದಾರೆ, ಹೂ ಆರ್ ಸಫರಿಂಗ್ ಫ್ರಮ್ ಕ್ಯಾನ್ಸರ್. ಭಾಳ ಜನ ಹೋಗಿ ಸ್ಕ್ರೀನೇ ಮಾಡಿಸ್ಕೊಳಲ್ಲ. ಸೊ ವಾಟ್ ಡೇಟಾ ವಿ ಹ್ಯಾವ್, it is not the right data for any government department to come out with a program. Only program can be done based on the data. ಅದಕ್ಕೋಸ್ಕರ ನಾನು ಇವತ್ತು ಎಲೆಕ್ಟ್ರಾನಿಕ್ ರೆಕಾರ್ಡ್ಸ್ ನೀವೇನು ಮಾಡಬೇಕು, ಪೇಷಂಟ್ ರೆಕಾರ್ಡ್ಸ್, ದಿಸ್ ಶುಡ್ ಬಿ ಮ್ಯಾಂಡೇಟ್ರಿ. ಈವನ್ ಫ್ರಮ್ ಪ್ರೈವೇಟಲ್ಲಿ ಮಾಡ್ತಾ ಇದ್ದೀರಿ, ಪಬ್ಲಿಕ್ಕಲ್ಲಿ ಕೂಡ ಆಗಬೇಕು. ಇದು ನಾವು ಗೌರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾ ಸ್ಕೀಮ್ ಆಗಿದೆ. ಇವತ್ತು ನಾನು ಹೆಲ್ತ್ ಮಿನಿಸ್ಟರ್ ಆದ ಮೊದಲನೇ ವರ್ಷನೇ ನಾನು ಹೆಲ್ತ್ ರಿಜಿಸ್ಟರ್ ಬಗ್ಗೆ ಮಾತಾಡಿದ್ದೆ. ಹೆಲ್ತ್ ರಿಜಿಸ್ಟರ್ ಈಸ್ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್. ಹಾಗಾಗಿ ಇದನ್ನು ನಾವು ಮಾಡಬೇಕಾಗಿದೆ ಮತ್ತು ನಮ್ಮ ಜನರಲ್ಲಿ ಅವೇರ್ನೆಸ್ಸನ್ನು ಕ್ರಿಯೇಟ್ ಮಾಡಬೇಕಾಗಿದೆ. ಅರಿವು ಮೂಡಿಸುವಂಥದ್ದು ಭಾಳ ಮುಖ್ಯ. ಭಾಳ ಜನರಿಗೆ, ಮಹಿಳೆಯರಿಗೆ ವಿಶೇಷವಾಗಿ ಆರೋಗ್ಯ, ನಮ್ಮ ಗ್ರಾಮೀಣ ಪ್ರದೇಶದಲ್ಲಿ ಅವ್ರು ಮಾಡುವಂಥ ಅಡುಗೆ ಕೆಲಸ, ಅವ್ರು ಮಾಡುವಂಥ ಬೇರೆ ಬೇರೆ ಸಂಸಾರಕ್ಕೆ ಸಂಬಂಧಿಸಿರುವಂಥ ಕೆಲಸಗಳಿಂದನೇ ಅನೇಕರು ಏನು ತಿಳ್ಕೊಳ್ತಾರೆ, ಅದೇನೇ ದೊಡ್ಡ ವ್ಯಾಯಾಮ ಅಂತೇಳಿ. ಅವ್ರಿಗೆ ದಿನನಿತ್ಯದ ನಡುಗೆ ಆಗಲಿ, ದಟ್ ಈಸ್ ವಾಕಿಂಗ್, ಅಥವಾ ಇವತ್ತು ಯೋಗ, ಲೈಟ್ ಎಕ್ಸರ್ಸೈಸ್, ಇವೆಲ್ಲ ಕೂಡ ಎಷ್ಟು ಒಳ್ಳೆಯದು ಅಂತೇಳಿ ಇನ್ನೂ ಕೂಡ ಅರಿವು ಇಲ್ಲ. ಅದರಿಂದ ಕೂಡ ನಮ್ಮಲ್ಲಿ ಭಾಳಷ್ಟು ಮಧುಮೇಹ ಹೆಚ್ಚಾಗ್ತಾ ಇದೆ. ಇದು ನಿಜವಾಗಿಯೂ ಕೂಡ ನಮ್ಮ ದೇಶದ ಒಂದು ಆರ್ಥಿಕತೆಗೆ ಇವತ್ತು ಸವಾಲಾಗಿದೆ. ನಾವಿವತ್ತು, ಇಫ್ ಯು ಹ್ಯಾವ್ ಟು ಬಿಕಮ್ ಎಕನಾಮಿಕಲಿ ಪವರ್ಫುಲ್, ವಿ ನೀಡ್ ಟು ಎನ್ಶ್ಯೂರ್ ದಟ್ ಡಯಾಬಿಟೀಸ್ ಈಸ್ ಚೆಕ್ಡ್ ಅಂಡರ್ ಆಲ್ ಸರ್ಕಮ್ಸ್ಟೆನ್ಸಸ್. ಇದನ್ನು ನಾವು ಚೆಕ್ ಮಾಡಲೇಬೇಕಾಗಿದೆ. ಹಾಗಾಗಿ ಇವತ್ತು ಎಲ್ಲ ಖ್ಯಾತ ವೈದ್ಯರು ತಾವೆಲ್ಲ ಕೂಡ ಇದ್ದೀರಿ. ಈ ಒಂದು ಸಮ್ಮಿಟ್ನಲ್ಲಿ ರಿಸರ್ಚ್ ಭಾಳ ಪ್ರಧಾನವಾಗಿರುವಂಥ ಅಂಶ. ನಮ್ಮಲ್ಲಿ ರಿಸರ್ಚ್ ಬರಲಿ, ಯಾವ ರೀತಿ ನಮ್ಮಲ್ಲಿ ಆಹಾರ, ದಿನನಿತ್ಯದ ಚಟುವಟಿಕೆಗಳು ಮತ್ತು ಇವತ್ತು ಹೊಸ ವಿನ್ಯಾಸ ಆಗಿರುವಂಥದ್ದು, ಇನ್ನೋವೇಷನಿಂದ ಬಂದಿರುವಂಥ ಹೊಸ ಔಷಧಿಗಳು, ಯಾವ ರೀತಿ ಒಬ್ಬ ವ್ಯಕ್ತಿಗೆ ಮಧುಮೇಹವನ್ನು ನಿಯಂತ್ರಣ ಮಾಡಲಿಕ್ಕೆ ಸಾಧ್ಯ ಆಗ್ತದೆ ಅನ್ನುವಂಥದ್ದನ್ನು ತಾವೆಲ್ಲ ಕೂಡ ಈ ಒಂದು ಸಭೆಯಲ್ಲಿ ಚರ್ಚೆ ಮಾಡಿ ಇದನ್ನು ನಮ್ಮ ಸರ್ಕಾರಕ್ಕೆ ಕೆಲವು ಸಲಹೆಗಳನ್ನು ಅಥವಾ ಈ ಸಮ್ಮಿಟ್ನಿಂದ ಬರುವಂತಹ ಭಾಳ ಇಂಪಾರ್ಟೆಂಟ್ ಸಲ್ಯೂಷನ್ಸ್ ಏನಾದರೂ ಇದ್ದರೆ, ಪ್ಲೀಸ್ ಶೇರ್ ಇಟ್ ವಿತ್ ದ ಗೌರ್ಮೆಂಟ್ ಆ್ಯಂಡ್ ವಿ ವಿಲ್ ಟ್ರೈ ಟು ಇನ್ಕಲ್ಕೇಟ್ all the valuable suggestions that come out of this seminar, this summit. ಒಟ್ಟಾರೆಯಾಗಿ ನೀವು ಪ್ರೈವೇಟ್ ಪಬ್ಲಿಕ್ ಪಾರ್ಟ್ನರ್ಶಿಪ್ should be robust and it should be continuous to ensure that a public health care delivery services is mooted to the most underprivileged person across the state. This is the ultimate goal of ಇದು ಸಿವಿಕ್ ಸೊಸೈಟಿ. ಯಾಕೆಂತಂದರೆ ಇವತ್ತು ಮೊದಲು ಅವೈಲಬಿಲಿಟಿ ಇರಬೇಕು ಹೆಲ್ತ್ ಕೇರ್, ಅದೇ ಥರ ಆಕ್ಸೆಸಿಬಿಲಿಟಿ ಇರಬೇಕು, ಮೂರನೇದು ಅಫೋರ್ಡಬಿಲಿಟಿ. ಇವು ಮೂರು ಕೂಡ ಇಲ್ಲದೆ ಹೋದರೆ, ಯಾರಿಗೆ ಉಳ್ಳವರಿಗೆ ಮಾತ್ರ ಆರೋಗ್ಯ ಅಂತಂದರೆ ದಟ್ ಈಸ್ ನಾಟ್ ವಾಟ್ ಎ ಡೆಮೋಕ್ರೆಟಿಕ್ ನೇಷನ್ ಶುಡ್ ಬಿ. ಎ ಪರ್ಸನ್ ಹೂ ಕೆನಾಟ್ ಅಫೋರ್ಡ್ ಶುಡ್ ಅವೈಲ್ facility, the facility that an affordable person can get. ಅದೇ ಥರದ ಒಂದು ಸ್ಟ್ಯಾಂಡರ್ಡ್ ಆಫ್ ಹೆಲ್ತ್ ಕೇರ್ ಅವ್ರಿಗೆ ಸಿಕ್ಕಿದಾಗ ನಮ್ಮ ಪರ್ಪಸ್ ಆಫ್ ಏನು ಇವತ್ತು ಡೆಮೋಕ್ರೆಟಿಕ್ ಕಂಟ್ರಿ ಇದೆ, ರೋಬಸ್ಟ್ ಕಂಟ್ರಿ, ಡೆವಲಪಿಂಗ್ ಕಂಟ್ರಿ ಅಂತ ಹೆಸರಿದೆ, ಅದಕ್ಕೆ ನ್ಯಾಯ ಮಾಡ್ದಂಗೆ ಆಗ್ತದೆ. ಅದಕ್ಕೋಸ್ಕರ ಇವತ್ತು ಭಾಳ ಸಂತೋಷ ಆಗಿದೆ ನಿಮ್ಮೆಲ್ಲರ ಜೊತೆ ನಾನು ಸೇರಿ ಇವತ್ತು ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಉದ್ಘಾಟನೆಯಲ್ಲಿ ಪಾಲ್ಗೊಂಡಿದ್ದೀನಿ. ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಮತ್ತು ಈ ಒಂದು ಸಂಸ್ಥೆಗೆ ನಾನು ಹೃದಯಪೂರ್ವಕವಾದಂಥ ಅಭಿನಂದನೆ ಮತ್ತು ಯಶಸ್ಸು ಆಗಲಿ ಅಂತೇಳಿ ಹಾರೈಸಿ ನನ್ನ ಮಾತನ್ನು ಮುಗಿಸ್ತೀನಿ. ನಮಸ್ಕಾರ. ಜೈ ಹಿಂದ್, ಜೈ ಕರ್ನಾಟಕ.
Sir, thank you very much for your wonderful words and encouraging words. Sir, to come to your notice, in the same line of your thoughts, noble thoughts, we also conducted one wonderful program which is called Dysglycemia Detection Drive, 1 month long across the state, where many doctors took part in screening for diabetes and explaining and giving awareness to their patients in their locality. So this is called a 3D program, which we intend to do every year and award those people who will do the maximum screening and then give them recognition in this dais. I request now to felicitate Dr. K. Sudhakar. Hello. Now I request Dr. Sudhakar sir to give away the 3D awards who have done the best screening programs in this award. I'll call upon Dr. Srinivasan, who has done the maximum screening thousands and has been doing this work for many years, and he's got a mobile clinic which he will be screening every day, in fact, doing a large service to the society. Dr. Srinivas, please come over, sir. Dr. Sri Hari Kulkarni. Dr. Achi Ashok. Dr. Karnesh Kumar. Dr. Sureka Shetty. Dr. Syed Fazal Ahmad. Dr. Amar Badagi. Dr. Sureka Shetty. Dr. Anasuya Shetty. Dr. Karnesh Kumar. So we are done with this. Dr. Ansuya Shetty is not available. Dr. Ansuya? Yeah. Anasuya Sugaya, sorry. Yes. Can I call upon Dr. Rajendra Kumar on the dais for getting the best member of KRSSDI for the year 2022. Dr. Amar Badagi. And one to our
Dynamic Secretary, Dr. Vijay Kumar. And my teacher, Dr. Prabhadikari is missing. I don't know if someone wants to collect it on her behalf or I can collect it on her behalf.
Sir, we are very humbled for your presence here. Thank you very much for your attention. So with this, it is time to move on with the next events in this inaugural function. Yeah. So, as the organizing secretary and the honorary secretary for the KRSSDI, I would like to mention about a brief about KRSSDI. Karnataka chapter of the RSSDI, that is the Research Society for the Study of Diabetes in India, was formed 18 years ago. However, the parent body, RSSDI, was born 50 years ago. So we are celebrating the Golden Jubilee this year, and with this, there had been huge celebrations across the country and a lot of activities done to create more awareness in the country. And as the state chapter, we also were actively involved in this novel program and participated throughout this year in creating more and more awareness. With this, we had an opportunity to showcase our Karnataka chapter, and our membership grew to double. Where there were 400 registrations in the last 17 years, we got another 400 registers in this one single year. So the membership now is 800 plus in the Karnataka State Chapter Association. So with this, I request Dr. K.N. Manohar, the scientific chairman, to brief us about the making of this conference and the scientific agenda of this conference and how it is formed.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ ಹಾಗೂ ಸುಸ್ವಾಗತ. ಮಾನ್ಯ ಆರೋಗ್ಯ ಸಚಿವರಾದ ಸುಧಾಕರ್ ಅವರು ಕಡಿಮೆ ಸಮಯ ಇದ್ದರೂ ಅಟ್ಲೀಸ್ಟ್ ನಮ್ಗೆ ಬಂದು ಗ್ರೇಸ್ ಮಾಡಿ, ಆ್ಯಂಡ್ ಐ ಥಿಂಕ್ ಹಿ ಸ್ಪೋಕ್ ಲಾಡ್ ಆಫ್ ವರ್ಡ್ಸ್ ಆಫ್ ವಿಸ್ಡಮ್ ಟು ಟೇಕ್ ಟು ದ ಗ್ರಾಸ್ ರೂಟ್ ಲೆವೆಲ್ಸ್, ಆ್ಯಂಡ್ ಹಿ ಅಲೂಡೆಡ್ ಟು ನಾಟ್ ಟು ಫರ್ಗೆಟ್ ಪ್ರಿವೆನ್ಷನ್. ಡಾಕ್ಟರ್ ಸೆಂಟ್ರಿಕ್ ಹಾಸ್ಪಿಟಲ್ಸ್ ಕ್ಲಿನಿಕ್ಸಿಂದ ಪೇಷಂಟ್ ಸೆಂಟ್ರಿಕ್ ಅಂತ ಹೇಳ್ತಾ ಇದ್ದಾರೆ. ಅಟ್ RSSDI, I would like to add that we should become public centric. He was talking about primary prevention. We should go one step ahead and look at primordial prevention and education. We always tell diet and exercise is not only after you are diagnosed of hypertension, diabetes or heart disease or kidney disease. Everyone should follow this. We don't glorify our healthcare as we glorify our IT and telecom. 1 in 5 doctors and 1 in 4 nurses in the world are Indians. And we are a favored destination for health tourism. I'm sure Professor Balal would agree with that. And Sudhakar ಅವರು ಕೂಡ ಹೇಳಿದ್ರು, we are unfortunately branded as diabetes capital of the world. But we at RSSDI want to take measures and make India as a diabetes care capital of the world. So friends, it's a matter of immense pleasure for me as scientific chairman to welcome one and all for this 18th annual conference of KRSSDI. Science should be the essence of any medical meeting. Professor Narsim Shetty ಹೇಳ್ತಾ ಇದ್ರು, ಹೂರ್ಣನೂ ಇರಬೇಕು ತೋರಣನೂ ಇರಬೇಕು ಅಂತ. So I hope we have done justice from the organizing committee. We wanted to set a benchmark in the science which is discussed here much more than anything else. We all agree that knowledge is one of the only few entities which enhances as we share, apart from maybe love. In the present era, of course, we are receiving a lot of inputs from trials and registries, and what it has made is we have changed over diabetes management, as I showed in my slide also, from glucose centricity to being holistic, and most importantly, being patient-centric. Future of precision, personalized medicines are to come by. So to keep in all these things in mind, we have selected the team of Diabetes 360 degree to try and cover as far as possible all aspects of diabetes. So most topics have been alluded. If you glance at the agenda, you would see that from pathogenesis to technology, lifestyles to multi-morbidities, what we call, and addressing the guidelines was the first talk, and also to the newer molecules. I've incorporated few unique workshops on lifestyle management, which is close to my heart, and mind and body connect. I would request all of you to attend that, a unique program from which is being actually helped by the Nimans colleagues. We do a mind and body workshop, and we are a research body. So the first workshop will be on publish and flourish. Professor K.J. Shetty, with whom I used to work, used to tell it, in the West, they used to say, publish or perish. If you don't publish, you don't perish. And even Dr. Sudhakar alluded to it, data is important. In God we all trust, rest of us should show data. So, and also we have a new kids on the block to address the new molecule and insulin incretin workshop. To intrigue the audience, I have introduced one edutainment, the debateology. I call it as a democracy in diabetes. It will follow the lunch session, and I hope all can actively participate. All of these amounts to about 30 talks, more than 125 eminent faculties, 5 workshops. We got an overwhelming response that we need to close the abstracts at 50. Quiz on the go. I'm sure all of you are experiencing the WhatsApp channel, which is the first time we have done it. And a lot of them have already called back and given a very good feedback to keep the interest in the conference. During the conference and pre and post, we'll be doing it. And some of the people, our younger colleagues have asked me for the slides. We will also work on that. And as I said, this WhatsApp channel gives us a taste of technology beyond our medical science. Of course, we are at Bangalore, and technology should be at the forefront, and I'm glad that you people are appreciating it. We hope these memories of this academic feast will be cherished for long. Friends, if knowledge is power, learning is superpower. Let us learn, unlearn, and relearn from each other and improve the way we practice and cater to our population. During my tenure as secretary, I had promised that I'll bring back research, publications, quiz, that is, in short, encouragement to the younger audience, younger generation who will take the baton forward to the forefront, and I hope I have done some justice to that. I would welcome you all, the students, the scholars, the scientists, the stalwarts, and also the spirituals, not so much of it with all the new regulations. Jai Krssdi, Jai Hind, Jai Karnataka. Thank you. Short of time, so over to the our chairman, Dr. Suman, for his words.
Thank you, Dr. Manur. It was really enlightening, to have seen that. Respected guest of honor, chief guest, Dr. Sudhakar sir, dignitaries on the dais and off the dais. Well, we are meeting for the physical conference after 2 years, and we always say that the conference becomes successful when we see a huge number of gatherings, when we see the number of delegates are really good. And I'm very happy that we can really see a lot of delegates have really attended. That shows the number of interest what people really have in this conference, and thank you so much for that. Well, as a chairman, when I just took it over from 1 year back, I had 2 challenges to face. One was taking it from Dr. Sidney sir, who is so simple but so effective. And he brought a lot of things to the thing, and he saved a lot of money for the organization. Not only that, he instituted an award, that is a research award, and it's something really good for us, and really you set a standard for me to follow. Thank you, sir, for that, actually. Well, the second thing what happened was the COVID was there, and we wanted to change over from the virtual conference to the physical conference, and it was a real big challenge for me to really take it forward. And I just took it as an acceptance to really take it forward and do the physical conferences also, taken from one of the past chairmen, Dr. Arvinda, really, enlightened with a lot of CMEs, monthly CMEs, what we used to do. I took it forward, and almost like around 9 to 10 CMEs, we were able to do it across. Not only that, we also brought in something called as a dog skill program, where the soft skills training was really done, and a lot of people enjoyed it and liked it. In fact, I would like to thank Dr. Shekhar sir. He was a star of that, and he really helped us out, and people appreciated a lot. And just believe it or not, almost like around to a tune of 10,000 people had viewed his talk. Something like very great. Something like, soft skill training, how to listening skills, oral presentation, all those things were really done. Thank you, sir, for being with us and really helping us out in this journey, actually. We just didn't stop at that. We just went on and we did a lot of rural health programs. We did a lot of other programs also, the walkathon and all. Because of that, our chapter got the second best chapter in the national things, and it was really something great for us. And all this was possible because of the young team, Dr. Manohar, Dr. Vijay, everyone. I just don't want to name everyone. The whole team really helped me out in this journey of this. So I thank each and everyone, and kindly do enjoy this scientific feat. And I really thank for each and everyone for coming for this. Thank you so much.
Thank you, Dr. Suman, for your kind words. It has been a very good journey and the whole year under your guidance. Thank you. Now we'll move on to honoring our guest of honor, Dr. Sudarshan Ballal. Please come. Sir, we are very happy to have you on our dais, and please accept our honor, sir. I request Dr. Sudarshan Ballal to have a few words with us.
A very good afternoon to you. The first thing that struck me today is that I have hardly been to any conferences where there is no place for seating. You have more people standing here than sitting, and that goes to show the valuable conference that this is, and I congratulate the organizers for making this such a well-attended conference. Dignitaries on the dais, Dr. Suman, my good friend Dr. Manohar, Dr. Syed Jawaz, Dr. Vijay Kumar, Dr. Shekhar, Dr. Munichodappa, and of course, our Honorable Minister for Health, Family Welfare and Medical Education, who enlightened us on his thoughts of healthcare, especially regarding lifestyle, prevention, and diabetes. At the outset, I would like to thank the organizers for inviting me to be part of this very important conference. If I didn't become a nephrologist, I would probably be a diabetologist. I'd be feeding the nephrologist and not be taking patients from the diabetologist. But we cannot turn the clock back. But it's very exciting to be a diabetologist now. The whole concept of diabetes has changed. And I wish I could become a student again to learn all the new aspects of diabetes, but I have some very good friends in diabetology and endocrinology who I'm sure will train me whenever I need it. I mean, talking about diabetes to this audience is like carrying a coal to Newcastle. As you're aware, we are the diabetic capital of the world with over 70 million people with diabetes. I would like to draw your attention to two of the pandemics that we faced recently, but we only keep talking about COVID, the unprecedented, devastating, once-in-a-lifetime pandemic that turned our life topsy-turvy. That was the pandemic that we saw. Unfortunately, diabetes is also a pandemic that we don't see as much. I compare this to cyanide poisoning versus arsenic poisoning. COVID was like cyanide poisoning. It was acute, the damage was immediate, and the death was immediate. So it was very, very visible. However, diabetes is like arsenic. It's a slow, invisible poisoning, and you don't see the death coming, which may happen many years from the time that you become a diabetic or a pre-diabetic. But both of them are equally important, and in the long run, probably diabetes will kill more people than COVID ever did. So please, ladies and gentlemen, spread the news of diabetes, spread the news of prevention of diabetes, early treatment and appropriate treatment to the general public. We have over the years learned, and I think Dr. Manohar elucidated very well in his talk, that diabetes is not a matter of high blood sugar, but a serious metabolic vascular disease that can cause kidney failure, blindness due to retinopathy, heart disease, strokes, peripheral vascular disease requiring amputation, so on and so forth. So please encourage the youngsters and the postgraduates right from the beginning to look at diabetic holistically and not as sugar control alone. And I must admit that the government of Karnataka has one of the best diabetology institutes, Karnataka Institute of Diabetology, where you cannot see the diabetologist after registration till you go through dietitian, counselor, podiatrist, nephrologist, neurologist, and finally you get to see the diabetologist to give you the final word. And that is what I call as holistic medicine of diabetes. You need to see all the aspects of diabetes, not just the sugar alone. And that certainly is an institution that I'm very proud of. And we're also proud of that Manipal has been representing the nephrology part of KID ever since its inception. Fortunately for us, diabetes is an eminently preventable and controllable disease. Many new insights into this illness in the spheres of diagnosis, monitoring, and treatment are now available. And I'm sure over the next 2 days, the experts will deliberate on this and help us manage diabetes better. I wish the conference and the organizers the very best. Thank you again for the invite. God bless. Jai Hind. Jai Karnataka. I won't come in the way of neither the academic feast or the lunch feast you're going to have, but Manohar will be watching you carefully whether you're in the red zone, amber zone, or green zone. So watch what you're eating, but I'm sure you'll all have a great time. God bless.
Thank you very much, sir, for your wonderful speech.
Dr. Ballal.
Now I request Dr. Simon Chudappa to give a few words.
Dr. Ballal and dignitaries on the dais. I'm asked to speak for 2 minutes. Now, as a patron in the Central RSSDI, I was asked to nominate the first governing council members and secretary and president. Dr. Basavan Gaudappa from Mysore was made president, and Dr. K.R. Narasimha Shetty was the secretary. Now later on, Narasimha Shetty became chairman of the KRSSDI Governing Council, and then under his guidance and Syed Jawaz, the KRSDI has grown. Now at that time when I nominated the office bearers, there was not a member. And then now today I believe I was told 400 members are there. So I am very happy about it.
Now it is 800.
Huh?
Now it is 800 plus.
Apa?
Now it is 800 plus.
Okay. So I am glad that it has grown, and activities also, I think now and then they have some CMEs, and also annual conference like this. I congratulate. Unfortunately, Nasim Sethi is not with us. He passed away about 4 or 5 months ago. And then Syed Jawaz is with us, and I will believe he will work for the betterment of Kerala.
Thank you, sir. Thank you for your humble words. Now we move on to the next event, presenting the Lifetime Achievement Award. I request Dr. Mohan Badgandi, sir, to please come on the dais. So I request Dr. Sudarshan Ballal to initiate the process of honoring Dr. Mohan Ballal. Mohan Badgandi. So with this, I request our Dr. Mohan Badgandi to please address the gathering.
Thank you very much. It has been a great honor and pleasure. And I like the way the meeting is well conducted and well attended. And also I thank our health minister who spent some time with us and also gave his, path of prevention and how diabetes is very important for all of us. And I also admire our chairman, Dr. Sudarshan Ballal, who is here with us and who has been very supportive and very encouraging when it comes to clinical work, research, as well as the patient care. And I also thank the RSSDI, Karnataka chapter, as well as the central. And there is Dr. Suman, who stays very close to my house, but I'm work in a different direction and he works in a different direction. And Dr. Manohar, who has been with us for the last 25 years, and Dr. Shekhar, who has been there, and Dr. Vijay Kumar, whom I know very well, and all my friends and senior colleagues and senior partners in healthcare, and all of you who are on my side of the fence and who treat diabetes just like me or I treat just like you all. So I think it has been a great honor and pleasure. Thank you very much for giving me this opportunity, and thank you very much for this occasion, as well as I will wish you Merry Christmas and Happy New Year, and God bless you all. Thank you very much.
Without wasting much time, I do not want to stand between the audience present here with patiently listening to everyone and the lunch that has been arranged. I would like to thank the Honorable Minister who had graced the occasion, Dr. Sudarshan Ballal, and all the dignitaries present on the dais and all the delegates who have patiently been sitting and listening to everyone, listening to those wonderful talks, and you have already made this conference a success. Thank you everyone. We'll break for lunch now.
As usual, I have to cut short the lunch. Please have a quick lunch and we'll assemble back at 2 o'clock. A tightly packed scientific agenda, which is as tantalizing as the lunch. See you back soon.
A very good afternoon to all. I just request all the delegates to gather inside. We'll be starting the session in another 5 minutes. Request all the delegates who are having the food to finish and please come inside. We have Hall B also. There is a workshop, mind and body workshop, which is going to happen. Sorry. Hall B workshop is also there. It will be starting in another 5 minutes. Those of you who are interested, please kindly proceed to the Hall B, which is there in the ground floor.
The chairperson will be. Okay, he will.
Good afternoon to one and all. I think after having a carbohydrate-rich food, hope your oxytocin level should not hinder you. So I would request all of them to concentrate here and enjoy the sessions, afternoon session. Now we have the role of yoga and mind-body medicine in type 2 diabetes, the current evidences.
The most important part of the day after lunch. So that's the reason I think Dr. Suman has kept an activity, yoga after lunch, so that we are all awake. We don't sleep. That's the reason I think Sir has kept this session later on. And to chair the session, we request Dr. Govindappa, who's the senior consultant physician and diabetologist, and Dr. Satish Kumar, who's a physician, to chair the session. And the speaker would be Dr. Hemant Bhargav. So I think Dr. Govindappa is not here, so we can request Dr. Anil Kumar to chair the session. Dr. Anil, please do the honors. Fine, thank you, sir. How are you? I'm fine.
One chairperson is okay. Hello. Welcome to the afternoon session of KRSSTI 2022. We have now Dr. Hemant Bhargav, who is MD, who has done MD in Yoga and Rehabilitation, PhD from Swami Vivekananda, Yoga therapy, and 10 years of experience in treating patients suffering from major non-communicable diseases through yoga therapy. And ongoing fellowship awards. They welcome DBT India Alliance Early Career Fellow, Promising Young Faculty Scholarship from Duke University, and then awarded gold medal for best MD as well as PhD thesis. And he had several research publications in yoga for depression and he has a chapter in textbook of yoga in mental and neurological health care. And then he's a member of several organizations. Over to Dr. Hemant Bhargav.
Thank you very much, Anil sir. It is indeed a great pleasure for me, to be in front of this esteemed audience and share my views. What role yoga and mind-body medicine can play in the clinical care for type 2 diabetes. Before I go into the presentation, this is the definition of mind-body medicine. It focuses on the relationships between the brain, body, mind, behavior, and their effect on health and disease. When we look at NCCIH, yoga, tai chi, pilate, guided imagery, guided meditation, mindfulness, these are all parts of mind-body medicine. But in the last 2 decades, we see that yoga in particular has emerged as a very, very important component of mind-body medicine, predominantly for its application in wellness. We, in our clinics, we see patients who come to us and they say that we see their reports, we see that their thyroid levels are under normal limit, sugar levels are under normal limit, but still, patient says, doctor, though my reports are normal, I do not feel normal. So this is something which we call as the component of positive health or wellness. A person needs something more to feel energetic, to feel positive in his mind, to have certain quality of life. So it is here that these mind-body interventions come into clinical practice. When we look at lifestyle, these are the 4 major pillars of lifestyle. In clinical practice, we see that we also practice holistic medicine. We advise patients many things to do. You should go for a walk, you should eat certain kind of food items, you should sleep on time, you should adjust your biorhythms. But then very few are able to implement it. Why? It is because the mind plays a very important role here. Everybody knows what is to be done, but it is very difficult to make the mind understand or comply with the change in the lifestyle. So this is here. We see that because of these irregularities in lifestyle, the psychosomatic disorders are increasing in prevalence. In any usual clinical OPD, we see that at least 60 to 70% of the patients have certain psychosomatic components which are very difficult to define clinically. They do not fall under any diagnosis, but they have some complaints. There will be some bloating, there will be some non-specific pains, and you cannot make out any diagnosis, but they are troubling the patient, and we as a clinician do not know what to do with them because they do not want to take any more medications. And it is here, that the stress in the mind comes into picture, the response to external demanding situation that can be there because of relationships, because of certain deadlines in the work, because of illness, and internal demanding situation. I am not able to reach my own perfectionism, my own goals. So therefore, yoga, that it was a secretive kind of a practice till about 3 decades ago. Only it was considered that it should be done only by yogis who are in Himalayas, and it is a very mystical kind of a practice. But then, from the early 1990s, the research in this field grew. And now, if you look at PubMed, there are more than 7,000 yoga publications with its application in medicine. And yoga now, especially after 2015, when the whole world celebrated International Day of Yoga, it became a global phenomena with more than 200 countries over the globe, including countries, which follow Islamic religion, doing yoga, incorporating yoga, suggesting that it is a practice which is more secular and has a scientific basis to it. Whereas the scientific definition of yoga came from Patanjali in 400 BC. He wrote a treatise on yoga known as Patanjali's Yoga Sutra. And it is a real wonder. Now we think that yoga is something related to physical practice. But when the sage defined it, he says that it is a systematic practice to calm down the agitations of the mind. So predominantly the effect is on mind. Now this is a very interesting parable that describes human body. It comes in one of the Upanishad, Katha Upanishad. So the whole thing is the body. 5 horses are 5 sense organs which are always drawn outwards. And the reins are the mind, which is on one hand connected to the senses, and on the other hand it is held by the intellect. And it is between the senses and the intellect that the mind is being pulled. And behind that, this fellow who is sitting there is the consciousness, the witness, the observer, which is ever neglected in our life. So this externalizing of the consciousness that is promoted by our education system is the main cause of the stress that we accumulate according to yogic science. And the whole approach of yoga is to turn the consciousness inwards so that the horses follow the reins follows the rider, and the rider is dedicated to the person sitting behind. There are various schools of yoga that have come up. Some emphasize physical practices, some emphasize breathing practices, some use meditation, some combine them in different formulations. And fundamentally, we see that all these kind of practices actually are aiming at calming down the mind. Now, this is a thing in our clinical practice. We see that, okay, I tell the patients to go for a walk, patient does some cardio, he goes for a gym. Then what is the need for yoga? They are already, fulfilling the physical part of it. Now, if we scientifically also look at it, our researchers show that the physiological effects of these two kind of interventions are actually very different. Immediate effect of yoga is actually a reduction in the heart rate, bringing the parasympathetic dominance, and moreover, you see that the last point here is that when you do exercise, the mind still continues in its habit of continuously thinking, and these racing thoughts in our mind never stop. But in the yoga, the mind, breath and body get aligned together, and that mindfulness component of yoga brings the difference. So regarding this, we have planned a workshop tomorrow morning, 8 a.m. to 9 a.m., where we will be randomly dividing people into 2 groups. All of you are, invited to participate. One group will do 40 minutes of yoga, other will do a standard exercise package for 40 minutes, and we will do certain parameters, psychological and physiological, and we will see, what results get. So tomorrow probably towards the valedictory, we will announce the results also. Now, is there a connection between body, breath and mind scientifically? Now, this is a common sense, a logic. Which person would a person adopt when he feels very sad? If you feel very sad, naturally what happens to your body language? We see that the person stoops forward, the shoulders are dropping, the neck drops down, psychomotor activity reduces. And what happens when a person really feels happy? Imagine that you, on a wonderful Sunday morning, you are fresh and you go for a trek and you reach the peak of the mountain and see beautiful scenery in front of you. What posture would your body adopt then? So, when we see with the change in the emotions or the mood in the mind, subconsciously the body takes into certain postures. Now, what if, if we voluntarily adopt certain postures which can bring positivity in our mood? So there is a practice called as hands in and out breathing. I request all of you to just join hands in front of you, please. Just join hands in front of you. Okay? Now take a deep breath in and turn your face slightly upwards and gentle smile on your face. Breathe out. One more round as if you are breathing through your hands. Gentle smile on the face. Breathe out. Relax. So this is a very simple practice where your mind has come down to the present moment, your breath is connected to your body, and your mind is connected to your breath, and you are aligned. So this can bring a change in the way the thinking pattern is going on in the mind. Similarly, there are researches that have shown that the pattern of breathing is intimately connected to the kind of emotions that we feel. So if the emotions can change my breathing pattern, when I am angry, breathing becomes more erratic, more deep. Whereas when I am meditating or I am with my loved one, I am really relaxed, it follows a very rhythmic pattern. Now, if consciously the breath can be regulated to follow certain ratio of breathing, can we manage the emotions better? So it is here, there are different kinds of pranayama techniques that utilize the whole lung and focus. It is also now scientifically proven that as compared to breathing through the mouth, the breathing through the nose has selective effect on the cerebral hemispheres. The olfactory bulb and its connection, through the nerve channels to the hypothalamus can actually bring about a shift in the autonomic nervous system. And the slow paced breathing, when you are able to bring out your rate of breathing below 6 per minute and shift the breathing from thoracic to abdomen and observe a ratio of 1:2 in inhalation and exhalation. If you are able to just do this for some 10 minutes through the relaxation response, we are able to bring a shift from sympathetic dominance to parasympathetic dominance. And now we know, when parasympathetic system is dominant, there will be more insulin release, there will be better control over the sugar and less release of sugar. So this way we can manage. There are other studies that are showing that particular phase of breathing, if prolonged, has effects on the mood, anxiety, concentration, cognition. This is a study, it was my MD thesis topic. Kapalabhati is a very popular pranayama popularized by Ramdev Baba, where you pull your abdomen in and throw the breath out. So I was wondering why this kind of a name. Kapala means forehead, Bhati means shining. It has nothing to do with forehead, you are just flapping your abdomen. But then when we use this FNIRS device to understand the oxygen flow in the prefrontal frontal cortices, we observed that actually when the practice was done above 90 per minute, it brings oxygenation to bilateral prefrontals. So the sages meant that the Kapala is prefrontal and Bhati is oxygenation. So this is the kind of result that we observed. Similarly, in another study, we observed that chanting of the mantra Om, O and Ma in the ratio 1:2. Om, 5-second O and 10-second Ma. 10 sets of this chant was able to bring about a deactivation of the limbic cortex. Now we know that limbic system is associated with lack of control over emotions, frustration, anger, rage, negative ruminations. All those areas of the brain calm down after doing such kind of breathing practice. Now this is another very interesting idea. In Mandukya Upanishad, they say that the consciousness of human being has 4 legs. A is Vaishvanara Purusha, where the consciousness moves out through the senses. Now I am talking to you, you are listening to me, you are in the A mode. U mode is when the consciousness is not going out, but it is being projected in a mental space. So when you think, when you imagine, when you project it in past or future, you are in U mode. And when the consciousness does not project anywhere, but turns inwards into deep sleep, that is Ma mode. So every human being has A mode, U mode and Ma mode going on throughout the day. And there is a transcendental mode which is beyond all the 3. That is the silence between the 2 ohms. So here in yogic philosophy, every human being is either attached more in his consciousness to A. If he is attached more to A, he will be more prone to anxiety and will have a type A kind of a personality. If he is more attached to U, he is more prone, for losing the touch with reality and get more, addicted to screen or games or, Netflix and such kind of thing. Whereas if he is more attached to Ma, he will find it difficult to take initiatives and will be more prone for depression, social withdrawal and lack of social cognition. So this is the way, we actually performed a study and put people into MRI scanners. And we were actually able to see that when you chant A, there is more recruitment of the attentional networks, whereas the Ma brings the DMN into the play. And therefore, there is a biological basis to this philosophy that comes in. And therefore, when we design the yoga program, we use particular kind of chants. Now, this has nothing to do with religion. It is a biological effect of a particular sound, a non-invasive neuromodulation technique that we use at Nimhans. Now, the last part of my presentation is about the evidence base. You can see rising, strength of RCTs that have been published in the field of yoga. Major countries are India, US, UK, Australia. Major disorders are breast cancer, asthma, depression, and the fourth most prevalent is T2DM, where yoga research has been done. And in total, there are 13 meta-analyses of 27 RCTs till date. Overall, if you see the effect of these meta-analyses, yoga particularly enhances muscle strength, cardiorespiratory fitness, and there is a reduction in HbA1c and FBG, which is if you perform a regular practice for 3 months, there is on an average 0.5% reduction of HbC over and above the medications that the person takes. So these are the evidences. There are many RCTs showing many kind of effects. I don't want to go into the detail. But this is the RCT that we have done at NIMHANS, a RCT of 1 year follow-up, and 160 people were randomly divided into 2 arms, and they received 1 month yoga as a direct supervision, and then COVID came and we shifted them to tele-batch, tele-exercise, tele-yoga, and followed them up for 11 months. And of course, during COVID time, there was a lot of dropout, so already 28 and 23 in each arm completed the trial, and a yoga module that focused on some loosening practices, Surya Namaskara, and these kind of breathing practices and chants. This was the way the module was implemented, and what we observed was that in the 6 months time, both yoga and exercise group reduced, but after that, compliance with exercise came down and yoga showed a improvement. So there was an improvement in HbA1c, reduction in BMI and waist hip ratio in both the group. Yes. So this is the scientific mechanism through which yoga works. Predominant mechanism is bringing the state of parasympathetic dominance. The bottom-up approach is through the vagal afferents. It is bringing that effect, whereas the top-down effect are majority due to enhancement of GABAergic tone. And yoga is as safe as any physical activity. Yoga is cost-effective. You do not require any equipment, any gym, and it just requires a little bit of space and a yoga mat. And it empowers the patient. Patient does something for himself, and the session can be completed in group also. So this is the model. Now football matches are going on. So the front line is the attack, the people who are center forward who attack, and behind is the defense. And I believe that the center forward is modern medicine, and the defense is yoga and mind-body medicine. And when both of them come together, we can win the match. So thank you very much. This is the textbook of yoga that we have published. So thank you.
Hello.
Namaste.
Thank you. It was an excellent presentation. So actually, we know that diabetes, the depression and anxiety, the most important accompaniments. I think depression in one of the studies, they said up to 50 to 60%.
Yes, yes.
So
Sir.
in diabetics.
Yes.
So
Sir.
maybe yoga will definitely help in such patients. And what is of course, you showed so many exercises. What's the main, maybe the exercises that they can do it for about few minutes, maybe 15, 20 minutes or a half an hour. What exercises, yoga, this one you suggest?
Thank you, sir. So sir has asked me to tell the most useful exercises, yogic practices for diabetes. So based on the evidence base that is there in all the yoga studies, predominant component that has been used is that you start by loosening of all the joints. This enhances the microcirculation of the body and enhances, the entry of the glucose into the muscles. So loosening of the joints, synchronization with the body, with the breath, and with mindfulness. The whole body joint loosening is number 1 practice. Second, there are 4 asanas. Number 1 asana that has been suggested is known as Vakrasana. You can all search. Number 1 is Vakrasana. Number 2 asana is Paschimottanasana. In Vakrasana, you twist, you sit and twist. In Paschimottanasana, you sit and you try to touch your hands to your legs. Number 3 asana is Dhanurasana, where you lie down on your back and then turn backwards, the bow pose. And number 4 asana, they say, is Shavasana, where you are just lie down like a dead body and performing deep abdominal breathing. This asana has also been shown to be very useful in depression itself. When you feel very low, just lie down like a dead body and perform deep abdominal breathing in a ratio 1:2. And then 2 pranayamas, one is Kapalabhati pranayama and second is selective right nostril breathing. Their left and right is connected to the sun channel that activates the metabolism and enhances the calorie. It helps in weight loss also. Whereas the left improves quality of sleep and other factors. It is the moon channel. So these are the practices.
Thank you very much, Dr. Hemant Bhargava, for your lucid presentation on the science, yoga, body and mind, how they are interconnected. As we all know, yoga was originated in India 5,000 years back. Taking this concept, our central government of India emphasized and celebrating June 21st as the International Global Day, which has been a good initiative by our Prime Minister, and it has been practiced all over the world. Nearly 150 countries are following this international yoga practice on 21st of June of every year. As you rightly said, definitely it harmonizes the body and mind. It helps a lot, several benefits, what you have told, described, meta-analysis and summary, all that. It will connect the body and mind. It helps a lot, various psychosomatic problems, reduction in blood sugar, not only reduction in blood sugar, it helps a lot in the reduction of hypertension, cholesterol, acidity, whatnot, pancreatic secretion of the insulin. So many benefits are there. You have seen people who are practicing regularly yoga, their face, their appearance, their charming appearance, you can distinctly differentiate the persons who are yoga practice, persons who are not yoga practice. You have seen in our practice, and as soon as he appears, come to the consultant, you know, you are practicing yoga, we can ask them. There is a lot of difference. If you incorporate this yogic exercise practice in your daily life, I am sure we are going not only preventing diabetes, we can prevent most of the complications of diabetes. Thank you very much.
Thank you, sir. Thank you for endorsing my presentation. Namaste.
We can have a group photo of the chairperson and the speakers. I think stress is very common in today's world. So yoga, not only for diabetics, I think it's very important for non-diabetics also. So thank you, doctor, for enlightening us on this very important topic. Thank you, doctors. Namma Bengaluru, which is a tech-savvy city. I think the next topic is related to that. Intelligent use of artificial intelligence in comprehensive diabetes care. And we invite the chairperson, Dr. Srinath KM, who's a consultant physician, and Dr. Suresh SM, who's the endocrinologist. And speaker would be Dr. S.R. Arvind.
Yeah. Good afternoon, everybody. The topic for the session now is intelligent use of artificial intelligence in comprehensive diabetic care. I think all the senior colleagues and my friends would agree with me. We are living amidst epidemic of diabetes. To tackle this particular disease, probably we require novel approach, novel technologies, especially for early detection and management of this particular disease. So, probably the novel technologies, that is artificial intelligence, is the one which is very important to tackle this particular entity. Artificial intelligence has got a lot of applications, probably in early detection of this particular disease, maybe in terms of diabetic retinopathy, and early prediction, especially on diabetic foot and its amputation results, and moreover, and even markers, prediction of markers, and last but not the least, development of certain apps, particularly useful for the patient for self-care management. Finally, probably the artificial pancreas. To talk on this nice topic, we have none other than Dr. S.R. Arvind sir. Probably the scientific team has chosen a right person for this right topic. Over to you, sir.
Thank you. Thank you so very much. And thanks to Krssdi, thanks to Suman, Vijay Kumar, Manohar,
Anil, and so very many of you. And then this is the great thing. So the first thing I told him as soon as I came today was there are more people, or 3 times more people than what I saw at the IDF, and that's something very real. In fact, Dr. Mohan's talk at the prime time had about 42 people, and 30 of us were Indians. So I was just mentioning that to Dr. Shekhar actually about it. So intelligent use of artificial intelligence. So obviously the name itself suggests that I and Shekhar don't use it because we don't have the intelligence. So sometimes we actually have to back up on the artificial intelligence part. There's a lot of misconception about this word artificial intelligence, okay? In fact, it's a concept that has no single unequivocal definition. People have been trying to define this word for almost last 10 to 15 years. They have not found a definition for this. It aims to accurately make advanced inferences on a large amount of data. It's an extension of your statistics. There are 2 things. One is a strong AI, which refers to a highly versatile artificial intelligence that can establish a consciousness close to human thinking. And there is weak AI, wherein you do not see that consciousness and ability to make very comprehensive judgments. So these are the terms that are being used in the IT world who are developing artificial intelligence. Example of strong AI. Well, we already know this. We see them in the movies, right? And we have seen C-3PO from Star Wars, Comic Doraemon, Skynet from Terminator example. And these are the examples of strong AI, okay? These are the examples of weak AI. In fact, I was surprised to find that these are the examples of weak AI in the international journals. You know, the IBM Deep Blue computer program, which actually competes with the best in the field of chess, is called a weak AI. Google's AlphaGo is said to be weak. And Siri on your iPhone is said to be a very weak AI. So in case you want to take Siri out on a date, and if she refuses, she's a weak AI. You can do without her. So the question now is a strong AI actually there for us to use? No. People have only been talking about it. The strong AI is still in the research stage. And whenever we hear about the practical application of AI, this is almost always the weak AI, as per definition. The weak AI technology is only weak in name, as some of their processing capacities outperform even the human beings in many fields. Okay. So today, as we go on, we'll be talking about this. Now, how is AI used? You just have to remember 3 things. In anything, there are 3 things. One is an input, another is an analysis, and third is an output. AI is used in the analysis part. And in fact, the words machine learning and deep learning are the words that people today use. How is AI used? The primary approach of using AI in diabetes today could be to use machine learning and deep learning as analytical tools to obtain the target output. And if the goal is to determine whether a patient has diabetic retinopathy based on retinal imaging, we can then develop a classifier using machine learning that would select images, and imaging as the input, deep learning as the analytical tool, and classification purpose and output. So you need to have thousands and thousands and thousands of images which is fed, and the machine is taught to analyze them, and over a period of time with validation, you start getting the right answers. And as you go on, it's just an extension of the statistics itself. In fact, in statistics, we estimate the values in ideal population. We perform hypothesis testing to assess correlations and things like that. And we build the models around it. And statistics, actually, AI is actually statistics at a fantastic speed and probably with more data assigned to that. So it's like a black box which tries to kind of tell you everything. You don't have to really go through this. Now, people ask the question, should I have to use statistics or AI? The answer is very simple. Appropriately use each technique according to what the researcher wants. You understand the benefits and the risk of both this. And then you start using artificial intelligence. In fact, in 2012, the Body Guardian was actually FDA approved. It was the first AI, but never used in the field of diabetes. And now there are close to 12 approvals by FDA. And most of these FDA approvals are linked to radiology, cardiology, or oncology. Now, when it comes to diabetes, it's very, very simple. There are 4 areas in which the world is working today. One is automatic retinal screening, which is the need of the hour. Clinical diagnosis support, and this is what the chairperson was talking about. Patient self-management tools and risk stratification. I think I will tackle the last 3 first because there isn't much to really talk about it. When you come to diagnostic support, Advisor Pro, manufactured by Driamet, which is FDA approved in 2018, is the first one. It gets the information from the CGM and SMBG, and this information is sent to a cloud server, and that uses an AI to fine-tune the insulin dosage. In fact, they compared this with physicians. They compared this with the best of the endocrinologists in the US. In fact, the study demonstrated that targeted blood glucose maintenance and hypoglycemia rates were not inferior in the AI-guided group. The only problem with this is the cost. If somebody can afford a CGM and SMBG, and if the insurance pays for it, it's as good as an endocrinologist. In fact, a number of type 1 patients are already on this, but a huge amount of money is being spent. Now let's come to the self-management tool, right? This is the Guardian Connect, right? And we have a person from Medtronics, and he'll be very happy to now sit back and relax and then see, finally, my Guardian Connect system has come. Of using this system, we can talk to Deepak later here, but I don't know whether he can do anything about it. The attention of the chairperson who made this. This is where the statistics and AI has problems, predicting the onset of diabetes based on the data that you have. Well, you can use the statistical methods and predict and say your chances of developing type 2 diabetes in the next 4 to 5 years can be about. Therefore, those who are in the AI field are very conscious about it. They don't want to make predictions when we are not too sure. And these are some of the studies that have already come. We can keep this. Coming back to lifestyle guidance. Now, this is where some work on AI is being made. There are several mobile app-based, be similar to face-to-face nutritionist sessions, as long as somebody is making use of it. And these apps enhances the effectiveness of dietary intervention. There is also machine learning, which has helped in improving the complexities. This is what they claim. But all that it is doing is assessing what you're eating, and rest of the time, it's just monitoring. When it comes to diet, AI is being used to see how exactly. So let's come to retinopathy, which is the biggest problem. why diagnose diabetic retinopathy? We already know how important to diagnose diabetic retinopathy early because it's one of the microvascular complications. Most of the times patients are not, don't go out. So the question is, who should screen for diabetic retinopathy, because there is a shortage of retina specialists. Teleophthalmology was one of the promising fields, but the problem is how reliable is the reporting of teleophthalmology. You will be surprised to find the reporting of teleophthalmology is extremely poor worldwide. I'm not talking about India. Just to satisfy ourselves, before we did the SMART studies, we looked into whether this data is true or not. What is known as a kappa scoring is given. 5 specialists and then make a diagnosis. A kappa score more than 0.7 means it is good. Anything less than 0.7 is bad. So only for PDR, when they looked at the images, there was some amount of concurrence. Even for macular edema, teleophthalmology is a bad option. There are a number of reasons to the physicians to screen. If we don't screen, the good chances that the patient will go. I think the cost-effective camera and the cost-effective AI tools are the need of the hour. There are a number of cloud-based AI, but we do have a lot of problems in India because internet is still a problem. You can't take it to the smaller places. So the cost is a problem, convenience, need for internet, training. So cloud-based will not work. So we had to move into something which is there every less than 15 seconds. Another study looked at mydriatic images, and again, the referable DR was 93%. And also the Bombay municipality people working there, and then he could screen patients in the Mumbai municipality. And these are the results he got from his study, because AI never gets tired. All that you need to do is you just focus it, click the photograph. Even that job is done now. It has an auto clicks. As long as you take it near the eye, take it near the retina, immediately it clicks. So these are some of the study highlights. This is the staging. When you put the eye drops, whether glaucoma can be a problem. In fact, this actually came out just this morning. In the Times, this is an American ophthalmology journal, which came out with the same Remedio FOP, where glaucoma is also a part of your AI-based algorithm now. So it picks up glaucoma, it picks up retinopathy, it picks up AMD, it picks up cataract. Probably takes about 2 to 3 minutes to completely look at your patient and give a report. And these are some of the work that we have done in the last 4 to 5 years, restricted to that. A number of people have helped. Apart from this, I think Dr. Mohan, Dr. Banshi, and many others, especially from the field of ophthalmology, have actually helped us. So in conclusion, the research will continue in the field of AI. At this point of time, in the field of diabetes, it's diabetic retinopathy. Probably app-based programs are helping in picking up the glycemic index and the amount of calories that one uses when we take the food. But apart from that, the usage is absolutely limited to retinopathy screening. But over a period of time, I'm sure everyone will start using these retinopathy screening tools so that it becomes much easier to make a diagnosis of retinopathy. Thank you very much, and sorry for taking a couple of minutes more. I didn't know it would ring the bell at 17 minutes. I thought it would go till 20. Thank you.
Thank you, Dr. Arvind sir, for giving a very informative talk on this interesting subject. If there are any questions, we'll allow 1 or 2 questions.
If anybody is using the Remedio camera, I'm sure you will have some questions to ask. Sanjay, it's unfair you asking me the question. Yeah. Uh, the glaucoma, this particular article just came out this morning. It was sent by Dr. Divya from US.
Because we
where
use
this-
another device to, I'm just trying to tell everybody, in the last 10 years, we have picked up 27 glaucoma just by screening, not by an ophthalmologist, not even by using the regular tonometer, but another instrument which picks up glaucoma in a non-touch method, just a screening part. And out of that, we were able to, and two were malignant. So that's enough of money invested. Not to tell about the amount of people we screen and pick up diabetic retinopathy. Just to say that.
In fact, they have updated the software now. They are moving into 90 degrees. In fact, I must tell them, Revenue have agreed to give all RSSDA members the entire camera with 1,000 free AI-assisted diagnosis for 3 lakhs, and that too on EMIs. And I'm sure KRSSDI can actually contact people, and then EMI is very low without any this one.
Thank you, sir. Just to say that it helped a lot in screening rather than sending into an ophthalmologist at the beginning.
Dr. Arvind, nice talk. We are becoming more of technocrats than doctors now. Very nice. My one small doubt is, a patient with the immature cataract, how good is this under camera?
Sir, once you have the cataract, you can't see the retina clearly at all. It clearly tells you that the image quality is not good, probably because of the cataract. Mydriatic images, there is no problem. It can bypass the cataract, but non-mydriatic images, if it is more than 5 millimeters, it still clicks. Less than 5 millimeters, it still has a problem, but it clearly tells you image quality not good. That is when the ophthalmologist comes into the picture. But this is in a very small set of our patients. Majority, you can just put eye drops, it dilates. Even if they have some amount of cataract, it can still get good pictures of retina. Once you focus it into the retina side, it automatically takes the shot. And then it goes on giving you 5-6 different fields. And then you ask for a diagnosis. So it will tell you cataract, glaucoma, AMD, and retinopathy with the binary staging.
Okay. Thank
and offline, no electricity, no power needed. iPhone is used actually. Yeah.
Invariably, cataract is common. Ophthalmologists, what is happening, their cataract they will detect, they will operate without assessing properly retina. Many times you have seen patients, sir, surgery ಮಾಡಿದ್ರು ಏನು ಉಪಯೋಗ ಇಲ್ಲ.
Sir, I was surprised. I showed you the data. There are 1,500 retina vitreous surgeons who are trained in India, and only 4,000 medical retina specialists registered with Ophthalmology Society. So the number is extremely small. There is no money in the medical retina field or in the medical retina vitrectomy field. The money is in the cataract. So majority want to go to the cataract line or anterior or posterior chambers. So that's become our practice pattern. It's very sad, but that's the truth.
Thank you, Dr. Arvind, sir. The message is very clear. Though artificial intelligence is a novel technology, at present it's prohibitively expensive. Probably the future days to come is going to help us in a long way to tackle the issues in diabetes. Thank you very much, sir.
We can have a group photo with Dr. Arvind and Chairperson and Dr. Suman. Today's era is very ironic. A robot tells me to confirm my identity. So thank you, Doctor, for enlightening us on this topic of artificial intelligence. So the next topic for the day is 2 decades in the 21st century. We are 2 decades in the 21st century. Where are we in the realm of diabetes? For this topic, I would like to call upon the chairperson, Dr. Kiran Nidagundi, who is a consultant diabetologist at Shubham Diabetes Center, and Dr. Padma Prasad, who is a physician and a diabetologist. Speaker for the day would be Dr. M.A. Shekhar.
Good evening, friends.
Thank you.
So today we almost finished 22 years in this century. So in these 2 decades, we have seen many new inventions, new drugs in the management of diabetes. So today, where exactly we stand in the management of diabetes? So to discuss on this thing, I invite Dr. M.A. Shekhar, sir, who doesn't require any kind of introduction. Over to you, sir.
Thank you. Team Suman, thank you for this opportunity to stand here and face you people. And thank you very much, all of you, for having had a hearty meal and still awake to listen to, as Arvind says, idiots. Now, let's give a hand of appreciation to Dr. Hemant, shall we? For an eye-opener. And let's give a big boo to Arvind for saying I'm an idiot. I was just joking. Okay, having said that, the disclosure that we have to see is, did you see the photo of Dr. Hemant when it was presented? And did you see him standing here? Can you compare them? If it's not, you're not good clinicians. He had a mustache in the photo. He did not have hair. He can afford to do it because he has a lot of hair on his head. Can you imagine me not having my mustache and beard? I have nothing here. Probably nothing inside, as Arvind says. Anyway, let's go further. Look at this picture. Dr. Manohar, the scientific chairman, called me some time ago and said, sir, you have to speak to people like that. Subconsciously, I said yes, and this is it. Can you put a caption to this? If I had kept my mouth shut, I would have been happy in Mysore. Now I have to stand in front of you and talk to you about this. And the second disclosure about what I'm going to talk to you, nothing about drugs, anything. My perspective in the last 35, 40 years of practice, and as we stand today, is this. Question for 1 crore rupees, 2024. Which one is the right one? This is exactly the story of diabetes today. There is no exact or the right answer for how we have to tackle the pandemic, whatever demonics of diabetes. With these two, let's go. I'll just talk simply about 4 paradigms and be done with it. Definition, diagnosis, classification, and treatment. I'll not talk much about treatment because you will boo me out if I say treatment part of it. Definition, has it changed? We remember hyperglycemia. There are 5 components to definition which cannot be changed for many, many years or decades or centuries to come. The one is chronic hyperglycemia. Second one is all the 3 macronutrient abnormality in metabolism. Third one is insulin deficiency and insulin resistance. The last one is vascular disease. The 5th one is an idiot like me. Keep this in definition. If the idiot is okay, these 4 will get some activity, otherwise nothing works. So definition has not changed for many number of years, almost 2 decades now. Now diagnosis, has it changed? This was 1997, reviewed in 1999. Has it changed? Let me not bore you. But what has really changed? The paradigm of diagnosis of diabetes, especially type 2, all this is fine, but what's important is this. This has been added. I hope all the people who are sitting in this AC room practice this. Do not brand a person who comes with hyperglycemia, blood glucose being high as a diabetic without confirmation within 14 days or 30, a month or what more about it. Everybody, a lot of people come with, sir, my HbA1c is 6.7, am I a diabetic? This is fine. But what is it that has come out are the culled, C-U-L-L-E-D, okay? Culled knowledge of HbA1c. I'm sure many of you know, but unfortunately is in your subconscious mind. It's not a conscious decision you take. When you look at that, 2 things you should know. HbA1c as a diagnostic tool of type 2 diabetes should be on NGSP standards. How many in this hall can confidently say the HbA1c the patient brings to you is NGSP standardized? Keep this in mind, without which I do not diagnose by HbA1c alone. The other one is IFCC, International Federation for Clinical Chemistry, millimole per mole. Funny things, most of us have already got our graduation, we don't care a damn, but it's very, very important. Why?
this is it. I'm not going to talk much about it. The relationship of NGSP, standardized, IFCC, HbA1c, and EAG, estimated, whatever you want to call it as. This is theory part of it, but what's important is designated comparison methods. This you should keep in mind and do HbA1c. Is there a designated comparison method to say this HbA1c done by that so-called test is comparable to NGSP? This is where we have to make a difference. We have to take the first step today after you listen to me. If most practical thing that happened in the last half a decade is this. Especially so, population which has very mid-percent vote to this, leave it to you. Beyond that, let's not go anywhere exactly. Coming to classification, have you changed this classification, type 1, type 2, others, and gestational diabetes for the last 3 decades? No. Whereas other specific diabetics or types, there is a huge list. I don't think any one of us can enumerate them. If any one of you can enumerate all the other specific, what really happened is the gap between young people and old people, which is now merging. And today, we have a young population who are diagnosed with diabetes. So diabetes in the young children, adolescents, and young adults, whatever way you want to talk about it, is type 1, type 2, MODY, fibrocalcareous, GDM, endocrine, secondary to genetic syndromes. How many of us have geared ourselves in clinical practice to look at this? We still talk about type 1 and type 2. Thankfully, if it's a male, you cannot put a diagnosis of GDM. I don't know, in 20 years it may happen. Arnold Schwarzenegger, one of them was putting it. He has done a movie where he becomes pregnant, in the peritoneal, okay, right? But ಎಲ್ಲರನ್ನು ಮೋಡಿ ಮಾಡಿಬಿಡ್ತಾರೆ ಅವರು. When it comes to diabetes in the young, as far as Modi is concerned, he can give a big discourse on this. But what's important is, he has already spoken authoritatively in the morning. When we look at a young diabetic, instead of muscle activity, A plus, B plus, A minus, B minus, A plus minus, all those 4 things is extremely important, because this alpha beta classification or A beta classification has this sensitivity of nearly 100% and specificity of 96, positive, negative statistics. Have I told you about definition of statistics anytime? Let me tell you. Statistics is defined as put your head in fire, feet in ice, your gluteal region is in comfort zone. I leave it to you. Next came ketosis-prone diabetes. You all know flatbush diabetes, which is hardly seen or not seen in India and all that. They looked at ketosis-prone diabetic, and again they have said type 1A, 1B, 2A, 2B. But I request all of you to go through this. It is available, all this knowledge is available. Try to internalize this and put it in your practice. Most of the times you will not be wrong. Okay. Can you tell me what is the diagnosis of that boy? If you don't know, please get out of the hall. Just joking. It's very easy. The way to diagnose other specific types of diabetes is dysmorphism, when they look abnormal. They look as if they are going to eat you and they're sweating. Diagnosis is hyperthyroidism. If they are very, very drowsy and fat, that's the way it is. So you please train yourself to look at the patient. You don't even look at the patient. That's what I keep telling my postgraduates. Look at the patient, but don't stare at them. Okay. Now what happened with classification? They said, SID, SIRD, MOD, MARD, MARD. Hindi mein mard kya bolta hai? I do not know. So this is the 5 subtypes of type 2, which became very, very clinically apparent today. It's very easy to look at this diagnosis. But Indians are always way apart from anybody in the world. They came out, Danish study, let's not talk much about it. We, in Indian context, it is very, very well entrenched today in 2022. SID, MARD, and IROD and CIRDD. IROD is insulin resistant obese diabetic. Very funny. CIRDD, combined insulin resistant and deficient diabetes. Combined. Classic deficiency as well as resistance. is very, very peculiar to India. So your job is to look at an obese young person who is highly insulin resistant, or they have both deficiency and resistance. This is about, and I hope you all know about diabetes staging system, which is becoming very, very popular because it's easy for you to really understand in a overall concept of what diabetic you are looking at. Just like your TNM classification of cancer, you can all request for this slide, and as Anil was telling, I have this habit of, when I put a new concept in front of you, I request 5,000 rupees. If you give me 5,000, I'll give you this slide. Last one is the treatment. Look at the treatments. Sulfonylurea, 5 glyce. Glymenclobide, all those glyes. Bigonides, just 1. Meglitinide, 2. Glitazone, 1. Deep whole armamentarium. But what's important is, how do you approach them when the treatment comes? Because if you had 2 drugs, you had no choice to use either one of them or both of them together. Now you have 9 or 10 or 11, 12, 13, it's going on. You're left with approach. You all know the story about triumvirate, guideline approach, works here. When you go to Dirty Dozen, Treacherous 13, Faithless 14, Formative 15, all those funny names are very, very catchy names. You need pathophysiological approach. So you have to gear up yourselves to look at your type 2 diabetic patient and look at their numbers and decide what is the predominant pathophysiology or pathophysiologist. You do that, you can do the best. Otherwise, guideline SGLT2 today, finished. We will not use AGI, we will not use sulfonylureas, and all that makes little sense. It becomes biased and bigotry, if you ask me. And the greatest thing that happened was this. The best approach to treatment of type 2 diabetes is RSSDA therapeutic wheel. Somebody spoke about this? Okay. They must have done a great job. I will not go through. A, B, C, D, E, F. That's it. Investigational drug. My mentor, Dr. Prasanna Kumar, will be talking about the first one. I request all of you to be there. The rest of thing, you can always discuss with me and with Arvind or Dr. Baswarna. He is with me here at tea time. Everybody knows about it, but please look at the, what you call the phrases I put: impact on weight, comorbidities, patient preferences, hypoglycemia risk, efficacy, and cost. This is the patient-centered approach, not putting the patient in front and all those people surrounding him and doing this, that, and all that. It's not so. Okay? Last, I'll come to the end. I still have 4 minutes. You can ask me a lot of questions, 5,000 rupees per question. 3 finalists in an interview were asked to memorize the person in photo who is sitting in the waiting room and tell how they will identify him. You got it? Person sitting outside, 3 people are asked, go out, look at him, come back and tell me how you will identify him. The first fellow said, easy man, the man with 1 eye and 1 ear. Second one said, oh, very easy, the man wearing cap, 1 eye and 1 ear. And you know what? My dear student, I can say many of them are here. The beautiful lady, please stand up. Neene Kanema. Both of you, I say, you're all beautiful, yes. He said, it's very, very, very simple. I say, stupid people. He's the one who is wearing contact lens. Can you imagine why? How can a person with 1 ear and 1 eye wear a glass like me? It's impossible. So contact lens. The simple philosophy of this is, please think out of the box. Please look at your type 2 diabetic in a different manner. You will win, the patient will be happy. Thank you. Jorak chappala odiri Swami.
Thank you, Shekhar sir, for making the diabetes after 2 decades from the hotel capital to the new era of diabetes, which has to be think over beyond the limits what we are limiting ourselves to diagnose. So it is my great privilege to be a chairperson to the pioneers of diabetology among Shekhar sir, whom I adore much. Any questions?
Sir. Nobody's asking.
Wonderful
Yes, got one
lecture,
question.
sir. 2 decades in 21st century. I want to talk about the other perspective which you have not spoken. The world, 2 decades in 21st century, the world is sicker today than it has ever been before. And the sickest species, complications of diabetes, hypertension, ischemic heart disease, chronic kidney disease, diabetes has reached pandemic proportions. Today we can't find ICU beds. Diabetes, understanding and treatment of diabetes, is it flawed? Is it that the way we are looking at the problem is the problem?
Okay, I'll answer in two paradigms. The first one, I'm sure many of you are teachers here, and I'm sure almost all of them have gone through training of trainer programs. There is a very, very important concept called as educational spiral. Teachers, please nod. The spiral starts in the beginning, it completes and goes to the next circle and all that. This is what's happening in the field of medicine. Take it as cancer medicine, nephrology medicine and all that. It's a spiral. Every time there is reinventing and rediscovering. This is the first thing. And today, what was 50 years ago population and what is now population is almost 2.5 times. That's why we are seeing more. The second one is, before the independence of India, what was the average lifespan of Indians? It was 40, 45 years. So most of them, before diagnosing with all these non-communicable diseases, would be dead of gas. And you have added all those environmental pollutants that can give us disease. So it is not that we are blind to what is happening. It is just that.
Shekhar, I have a question. Of course, very intelligently you did not speak about the management, and you left it at the RSSDI.
I told you I wouldn't.
And I saw the 2 weeks, okay? This is still the copy which was being circulated. Surprisingly, it is as a drug which doesn't do anything except reducing HbA1c by a very small number. And they're now saying if you want to use a medication, okay, at the cost of hypoglycemia, I mean, this will come as a shock when the ADA guidelines come out in January. That, okay, so I think there's going to be a lot of surprises in years
It
to
is
come.
their mindset and they're talking. I will not accept them. Second one, I'm sure our GIT is happy with DP4 production. So carbohydrate eater put on DP4.
No, I mean, it's very right. No. Different from not the ADA.
Rightly said, guideline is only
Last
guideline. But the ultimate decision is your judgment. Your judgment based on the respect to all that assessment. Then you choose your own drug. Not necessarily should follow the guidelines.
Yes.
Not necessarily.
Nice to see that the
After this, Dr. Shekhar and Dr. Arvind will have a boxing contest.
Nice to see that the two stalwarts of the loggerheads. With this closing now for the next session. Thank you very much, sir. Dr. Shekhar, sir, for a wonderful talk.
Right.
We can have a group photo. Thank you, doctors, for enlightening us on the topic 2 decades into the 21st century. Where are we in the realm of diabetes? Yes. Chairperson or this one, the debates. So now mixing the history along with science, we have a debate coming up. I would like to invite the judges for the session who will be enlightening on the topic. We'll have Dr. Sanjay Reddy, who's the Dr. Not. Dr. Sanjay Reddy, who's the diabetologist, and Dr. S.R. Arvind.
Hello everyone. And so we have two teams. Hoysalas by Dr. Swaraj Vadankeri.
Thank you. So the next session is going to be extremely fun to watch. So I'm extremely happy to represent my team of excellent debaters. I have with me medicine practitioner, Saga Hospital, Jayanagar. Big round of applause. To be joined by Dr. Srihari Kulkarni, also internal medicine specialist, Manipal and Columbia Asia Hospital, Yashwantpur. And our third speaker, Dr. Shalini Joshi, extremely difficult time.
I couldn't, sugars aren't dipping. So nobody is going to get sleepy. I'll make sure about it. So we are the Hoyslas. I think I'll be introducing first. Since the IPL music played in the background, I think I'll invite Dr. Raja Selvarajan, consultant physician and diabetologist from Kaveri Hospital. He is the Virat Kohli of our team. Cheer him up, please. Next, after the dashing Virat Kohli, we have somebody to calm down. So we have Dr. Shobha, consultant internal medicine and diabetologist from Saga Hospital. Dr. Shobha. Then we have Dr. Leela Mohan. He is a doctor. He is an internal medicine specialist. He is also an actor. He is also a producer. So we have all the glam quotient also along with that. He is a consultant internal medicine for Sagar Hospital, for Manipal Hospital, Motherhood Hospital, and his own clinic, Pediam. Please come on to the dais. Dr. Leela Mohan, PVR.
So, of course, entertainment is there, but education and knowledge sharing is at the forefront. So we'll start with the toss was put on the backdrop to save time. And the first topic was bariatric surgery versus drugs in type 2 diabetes. To go for bariatric surgery, from Wadeyars, we have Dr. Pratyush. He will speak for 5 minutes, and after that, the other team will speak, and then 2 minutes rebuttal for each. And they can have a captain's corner. A word or two from the captain about the topic and what you want to highlight, and then over to Pratyush. I hope the slides are ready.
Okay. Good afternoon, everybody, and thank you, KRSSTI, for putting this wonderful thing across.
How many are for bariatric surgery, show of hands, and how many are for drugs? Because at the end of it, we'll again poll, and then whatever the shift happens is the winner. So how many wants bariatric surgery for diabetes?
Okay.
That is not the win. They may change their mind, and if there is shift is more, then the team wins, whoever has the shift. And how many for the drugs? Rest are all of them? You can't be sitting on the fence? Okay, that's a great show of hands. You have a tough task, but I'm sure you're prepared well. We have been working on it for a month.
1 second, we have some ground rules. Gentlemen, please listen. Please stick to the time. Please stick to your time if you don't, and don't mislead the audience. You may have data, but remember this is science. Keep it to science. Do not make too many personal comments. It's unwelcome. I've been many times on the same forum, and sometimes these are not welcome. So these are some ground rules. Keep the science on top. Thank you.
Hello, everyone. I don't know if I should say thanks for the opportunity, because the raise of hands showed that, how challenging this is going to be. Nonetheless, I want everyone to keep an open mind here, because especially now, before any time before this, we are seeing more and more of young cardio-diabetic deaths, young people, cardiac patients, metabolic patients, falling like a pack of cards without any explanation. And maybe this is the reason for us to question ourselves, is there anything else that we can do for the patients, we can bring on the table? Of course, to do it or not is a very calculated decision, like everything else in field of medicine, but weighing the pros and cons, risks and benefits, and being able to offer the patients in cardio-diabetic patients. Everyone here knows this. These are the established surgical options for bariatric surgery: gastric banding, sleeve gastrectomy, Roux-en-Y procedure, and BP diversion. It's an endoscopic balloon, but they are still in earlier stages. Few cases have been done, and it is under observation. The long-term effects are still not known. The criteria, as per the latest guidelines defined by AS, TOS, AS, MBS, is on the screen. morbidly obese patients without comorbidities, or BMI 35 and patients who are known to be diabetic, not well controlled on drugs, and patients who have very poor diabetic or metabolic control, and and that has to be explained, discussed, and weighed before going for the surgery. Metabolic complications of bariatric surgery, well known because of nutritional deficiency, the malabsorption that is induced by the surgery. Certain deficiencies can happen, and that is why which are desirable to us in terms of cardiometabolic finesse. Those effects are incretin effect, the insulin sensitivity being increased in skeletal muscle and hepatic tissue, and at the same time GLP effect increasing, and ghrelin effect reducing, which cuts down the appetite. Also the cutoff in the cortical center of the brain, so that the brain is set to have a lower hunger and lesser weight perceiving for the body. Now the data that we have, this is the well-respected data in this field. SOS study has been the landmark study. This study was conducted, enrolled patient, prospective cohort study, enrolled patients for 14 years, and it has a follow-up period of around 20 years by now. So it has a very strong long-term data. Here you can see that over a period of 20 years, the weight loss has been consistent for these patients. But here, we are not only worried about the, and this is one of them. Now, CV events, acute MIs, stroke, the incidence for all of these events were reduced significantly in the surgical group as compared to the patients who were just on medicines over a long follow-up period. Similarly, long-term diabetes remission after bariatric surgery, the remission was long-standing and more effective, and weight-related comorbidities as per ACS bariatric surgeries. So as we can see, everything, all the parameters which are more important to us as diabetologists, they were significantly down, effectively down over a period of time. Better BP control, more sustained lipid parameters over a period of time. There was improvement in fertility, in weight, type 2 diabetes remission, cardiometabolic parameters improving, long-term benefits, remissions may stay for a longer period of time, patients' quality of life improves, patients' microvascular complications and their severity reduces over a period of time. It's an important additional therapeutic tool against diabetes, but yes, there are certain limitations that we are able to give patients in combination of that. So it is time, I think, we should acknowledge the strength, weaknesses, and opportunities that this another mode of management can offer to us in effective control of our cardiometabolic diabetic patients. Thanks.
Pratyush did a wonderful job. Within 5 minutes, I think Captain Chitra is under tension because he exceeded 30 seconds extra. So she might have a match or fees reduction. Match fees reduction may be there. Now over to Dr. Raja to counterattack for drug in type 2 diabetes.
Okay. Well, we all know that obesity come up to be classified as disease. Do you really want your patients who are having a lifestyle-related disorder to be under a knife? How many of us would want to get your patients under a knife just for a lifestyle-related disorder, right? So, and if you look at the indications, what did Pratyush said, the indication for BMI was 35 and 30 and 30 plus and 35. How many of Indians are 30 and 35 above? We are thin fat Indians. We have more of visceral fat. So when we have visceral fat, how do we qualify for the so-called benefits which Pratyush did show, right? So we have to get in some very quick pharmacotherapy which could probably get not only the weight-losing benefits, glucose-lowering effects, and offer the maximum cardio-renewable benefits to our patients. Pratyush did show very good evidences about showing a good amount of weight loss and remission. But then also, he has shown only selective studies. He has not shown the other side of the study. There's also a good amount of weight regain which happens in 15 to a tune of 15% and in about 20 to 25% of the patients in just a period of 2 to 5 years. So the main indication, so I'm not going to stress on it, of type 2 diabetes was much higher when they used liraglutide. It did better HbA1c reduction and the weight reduction, which showed that the remission was still even better. What are the options which we have for our, or we have in our pharmacotherapy? You have the SGLT2 inhibitors, you have the GLP-1s, Tirzepatide, which is yet to come, and Krssdi, which is again in the pipeline. These are wonderful drugs which are going to take over the weight management under the belt without going to the OT, right? And we have already the old anti-obese drugs like Orlistat, Bupirovine, and Tropimet, which we all know about it. SGLT2 inhibitors, we have been using it over the past 7 to 8 years. Good amount of evidence. It is to 1%. Let's look at the GLP data. Liraglutide at 3 milligram. Superb data. Look at the scale studies. Scale obesity and pre-diabetes studies say that there's almost a reduction of 8% weight loss, and in scale diabetes to a tune of 6%. Look at the summary. It's even more impressive. The HbA1c reduction is up to 1.3% with scale diabetes, and the scale obesity says that 80% there is a probability of preventing developing a type 2 diabetes within a period of 3 years. Right? Now, let's look at the STEP studies. This is semaglutide semaglutide treatment and efficacy in people with diabetes or patients with diabetes. Step 1 to 8. I'm not going into details, but there's a mean weight reduction to a tune of 18 kgs, which is very, very documented. Let's look at the A1C reduction. A1C reduction is as well across the step. Maybe the step 1, step 2, the A1C reduction is to a tune of 0.5 to 1.7% as a therapy. In a nutshell, if you look at the GLP-1 RAs, irrespective of whether it has been injectable or oral, there has been significant weight reduction, significant HbA1c reduction, so even a good amount of redemption. Okay. Now let's look at the twin creatine, Tirzepatide, which acts at both the level of GLP and GRP. Wonderful HbA1c reduction to a tune of 1.9% and weight reduction to a tune of 8.7 kg, irrespective of the dose. But we did see that they were all the dose-dependent weight loss, which was more. Maybe the 1, 5, 10, 15, the more the dose was, the more the change was in terms of weight and A1C reduction. Cagrilintide is an amylin derivative, which is also, as a monotherapy, has shown to have 8.1% weight reduction, and with combination with semaglutide, it did 15.6% reduction without affecting the safety and tolerability. Right? And other pharmacological agents we know, so it has weight loss of 3 to 5.51 kgs. That's with the drugs which we had. Well, bariatric surgery, he said that he lost weight, patients get better. But what are the pharmacological benefits or pharmacotherapeutical benefits which we did achieve? There's nothing. So in total, we can say that apart from the weight losing, apart from the glucose lowering, there was significant reduction in MACE, myocardial infarctions, stroke, hospitalization to heart failure, and risk of kidney failures, which were not properly addressed by the bariatric surgery. Thank you. It's probably, we have to follow a pharmacotherapy to remit, early pharmacotherapy to remit, rather than try and fail later. So follow pharmacotherapy to remit and control diabetes at the earliest. Thank you.
The second batsman was well on time. So now the time for the rebuttal. The captain is very aggressive.
And the player is grounded because player knows the data. So, my friend Dr. Raja spoke about weight reduction. I'm not worried about weight reduction here. I'm talking about beta cell function improvement, cardiometabolic parameters improving. The certain studies, the medical group, 1/3 of the patients had MACE events there, where only very few patients had in the surgery group. I'm talking about the associated improvements that the patient can have apart from the weight reduction. The newest guidelines, they are not even talking about, they want us to look beyond the weight reduction. The adiposity, that can cause prolonged micro and microvascular side effects to the patients. And we are not saying that there is no rebound weight gain. Weight gain happens, but the weight gain with the drugs, rebound weight gain is even higher. The loss is just single numerical loss. So the loss is lesser, rebound is happening with the drugs also, what Dr. Raja pointed out. And at the same time, let's not talk only about diabetes, because we are talking about patients' quality of life here. Longevity. Patients are living longer and healthier. If there is, of course, we are going to choose the right candidate, the right patient for the surgery. The patient who will benefit the most. There are two groups of patients that will benefit the most. One, person who is fat and young, and we know that he's gonna, and if he's interested in that as an option, he wants to stay on lesser drugs for life. So it's either surgery once or drugs for life. That may be a fit patient. Second group of patient is who is having very poorly controlled diabetes. He's on high, he's very fast insulinizer. his diabetes progression is rapid, and we can see the complications coming, they're going to attack him very soon. So if this patient is found fit for the surgery, why does not he deserve a chance? This is my rebuttal for Dr.
Okay, Raja.
Well,
This,
already said
this is just like a super over. Yeah, this is just like a super over. Yeah.
Yeah, he already accepted his defeat. He did say that bariatric surgery didn't offer weight loss. He said that weight regain is there, and probably the microvascular complications are on the slighter side. But we have enough data across the GLP-1 arrays, injectable, oral, which is more affordable or more easily givenable to the patient rather than a bariatric surgery. Two. Thirdly, how many of our patients undergo bariatric surgery? It's only less than 2% of our diabetes patients. Can you suggest everyone a diabetic patient? Can you suggest every diabetes patient to a bariatric surgery? It's not possible on a realistic manner. So looking at the whole cohort of people whom we cater with a lesser or middle or socioeconomic status, we have to suggest a therapy which will be on long term, giving not only the glucose lowering effect, giving a cardiometabolic effect, irrespective of whatever the weight loss which they achieve. Maybe they achieve a little bit more weight, but they regain it faster than the oral therapy. Thank you.
So we have the captain's word here, and I think it has to be a balanced one. Over to the captain's.
All right, so you've heard both sides of the argument. The Vodayars, are we arguing for surgery for every person who walks through your door? Definitely not. But are we trying to get the audience to think about whether there could be potentially a small subset of patients who could benefit from this therapy, whom we are probably not considering, probably because we are too caught up in the way we have been doing things? I think everybody in the audience will agree, yes. Diabetes is occurring much, much younger, and you and I are losing people in their 40s to CKD, heart disease, and heart failure. All of us have lost those patients. Would it be because we haven't considered bariatric surgery as an opportunity? Maybe yes. BMI is no longer a criteria for recommending bariatric surgery at all. In fact, irrespective of BMI, if you choose the right candidate for surgery, you can still gun for diabetes remission. I think this is something, as an entire hall filled with people who take care of diabetes, we have to get used to. Remission of diabetes is very much a reality, and I think we should try and explore all available options to reach that end. And Dr. Raja, the WHO has reclassified obesity as no longer as a lifestyle disorder. It is now recognized as a chronic condition which requires continued medical care. There is weight gain after surgery, no doubt, but the chances of remission and the duration of follow-up has accumulated over 2 to 3 decades to recommend that you can have people living longer, healthy lives, even post-surgery, with an improved chance of reduced cardiovascular risk. Is that what we should be thinking about? Definitely yes.
That was a good one from Dr. Chitra. Now Swaraj has a good task ahead now.
Yeah, I think the player didn't perform as expected, so the captain had to come in for that. So in my case, my player has done probably very comfortable, so it will be much easier. So basically, we are Southeast Asians. We have visceral fat. We come from an area wherein there were a lot of famine, and that is the basis of the thrifty gene hypothesis. So we were hunters and gatherers. So we ate, so whatever we ate little, we conserved. So now with this revolution of industrialization, globalization, whatever we want to call it, we are accumulating whatever we are eating, and hence this obesity. After having said that we have so many number of obese people staying, how many of them will be ideally, inverted commas, well-chosen patients who have gone through the OT and come out, they regain weight, and still the same problem. And how many? Less than 2%. You want to cater to the less than 2% of the population with bariatric surgery? Hell no, I would not be doing that to my patients. Second thing is rightly chosen. Rightly chosen also will have certain side effects, which we have already elucidated in our presentation. So that is also not a thing that we should be considering. So we do not have general obesity, we have visceral obesity. For the Europeans, for the Caucasians, for the Americans, yes, probably bariatric surgery is going to help. But for us Indians, at least not now, but probably another 20, 30 years, then later, if we are having this debate, probably I will speak for bariatric surgery. But for today, it is no. Thank you.
Okay. Well spoken, both of you, but I have a question which I'm going to ask the audience in a different manner. do you all consider bariatric surgery as a legal option for your patients for remission of diabetes? Please raise your hands. That's what Chistra wanted. Please, do you want to consider bariatric surgery as an option for your patients in the treatment of diabetes and obesity?
There are more hands up now than before.
Yeah, that's what it means.
Yeah.
See, that's the way to ask it, and thank you very much.
So who won, sir?
Who won? Okay, we ask you.
So the other partner, who is for drug in type 2 diabetes?
Sir, the drug people were always drug people. How many people converted to surgery?
You don't have a say here. It's a political. Voting is done. Then we can debate over it later. Okay.
So the first round goes to Hoysalas, according to the crowd panel. Yeah. So you have another 2 rounds. So to be frank, this particular topic was like RCB versus Mumbai Indians. So it was a tough one. So it was a good one. So only thing is, what is the take-home message from this particular session is, drug still plays an important role in the management of type 2 diabetes, especially obese. Now the newer drugs are there which have the weight reduction benefit along with the cardiovascular safety data as well. But the bariatric surgery, never they say, to be considered in a selected group of patients, especially the people who are morbid obesity or the person who is obese with multiple comorbid conditions like severe osteoarthritis, the lifestyle, they were not able to walk around. If those group of patients are there, definitely bariatric surgery to be considered. One more thing to be said, recently in WhatsApp, you would have seen some videos saying about the diabetes surgery. They claim that doing a particular surgery, diabetes is cured. It is not so true about it. It is not diabetes surgery actually, it is the bariatric surgery. I'm sure many of your patients would be asking about. So moving on to the next session now. So basal bolus versus the pre-mix insulin regime in type 2 diabetes. We have Dr. Srihari Kulkarni for basal bolus.
I recommend everybody to read the history of the Deccan, called Lords of the Deccan. I think one close person who's close to the place where this all started is Swaraj. That's why it's taken. So please read these books because you've named it Hoysalas and Odiar. Right. Over to you, Doctor.
Srihari is for premix, sorry.
Thank you. Good afternoon, everyone.
Before that, sorry for a disturbance. How many of you are for premix insulin? Kindly raise your hands before the talk. Premix insulin in type 2 diabetes versus basal bolus. How many of you are for premix insulin? Kindly raise your hands.
How many of you write premix insulin regularly? More than basal bolus. Raise your hands. That's how I had to ask the question. Is it not? Many of them write premix, but nobody wants to raise that. Anyway, go to you.
Thank you, Dr. Arvinda, and thank you everyone for making my job easy. So my topic, I will be first start my topic with the old proverb, old is gold, and my salutations to Dr. Rajkumar. I've taken inspirations from Dr. Rajkumar, of course, because he has led a simple life and he has taught us to be simple in life. And also, as we talk about diabetes, we need to make the treatment of diabetes simple and not more complicated. So, what is premixed insulin? It is a combination of 2 insulins mixed together. One insulin that is short-acting, example regular insulin, or fast-acting like Lispro or Aspart, plus one insulin that is intermediate-acting like NPH. What are the factors we look before insulin initiation? Convenience, adherence, stigma, and efficacy. Premixed insulins, it has advantages. It is very easy to administer, provides both basal and bolus coverage with fewer number of injections. So what are the factors affecting choice of insulin for intensification? we think of dietary pattern. Very important is affordability. Yes, of course, I know my opponent will talk about the risk of hypoglycemia, lifestyle, weight gain, and very most important, patient preference. Insulin intensification should follow disease progression. We all know this slide. I am not here to discuss about how do we initiate or intensify the insulin, but my main aim is to show that both basal bolus and premix insulins are in guidance for the treatment of diabetes. And now what we hear is only basal bolus, basal bolus. Everyone has forgotten premixed insulin. There are a lot of advantages of premix insulins. This regimen is relatively easy to teach and simple for the patient. It offers fasting and better postprandial glucose control. It is more effective in lowering HbA1c than basal insulin alone. Improved compliance because of one insulin, one device. So, am I talking without any evidence? No. There are many evidences which initiate the about premix insulin. There is this study about 1-3 study, which the objective was attainment of glycemic goals in type 2 diabetes with once, twice, or thrice daily dosing with biphasic insulin as part 70-30. The study in patients with type 2 diabetes who failed with OHA or with basal insulin was conducted to assess whether addition and self-titration of basic biphasic insulin could achieve ADA, IDF, and other guidelines of HbA1c of less than 6.5 to 7. So the results, addition of once daily biphasic insulin could reduce 21% to achieve HbA1c of 6.5 and more than 41% to less than 7. With 2 daily doses of aspart, 52% achieved HbA1c of 6.5, and with 3 daily doses, more than 60% could achieve HbA1c of 6.5. This study shows that initiation of bypass 30 to type 2 diabetes poorly controlled on various OAD regimens was an effective treatment approved for achieving glycemic goals. So there was another study, a starch study. For the lack of time, I will go into the deeper. See, Indian food habits need different type of treatment. So whatever the ADA and the ASC guidelines, we cannot follow that. Indian food habits are unique and hence need a different approach. So main question is hypoglycemia. How do we tackle hypoglycemia in premix? There was a think strategy which it said that minimizing hypoglycemia with insulin therapy, the think strategy provides a comprehensive approach for diabetes care providers to minimize the risk of hypoglycemia related to insulin. So with this summary, diabetes is a progressive disease. Insulin intensification can be done with regimens like basal plus, basal bolus, premix insulins, and co-formulations. Proper dosing and timely titration is essential. Premixed insulin regimen is a time-tested regimen which is simple and effective. With proper hypoglycemia education, it can be safely advised to improve treatment compliance. Thank you very much.
That was a good one by Dr. Srihari. Captain Chitra looks excited and she's happy. She's taken a lead as of now. Now over to Dr. Shobha Naidu for basal bolus.
Good afternoon, everyone. And here, I think Srihari is here telling me that patient convenience, Indian subset, hypoglycemia, I think he already knows that he's on the losing end, so he's trying to touch my topic and try to get some bonus marks there. But I think I'm damn good with what I'm going to say now, and I think all of you will raise your hand at the end of my talk. With this, I would like to start and thank Krssdi, the whole team, for giving me this opportunity.
1 second, Dr. Shobha. Anybody for basal bolus? Okay, not bad. Okay.
So I'm from the Hoysala team, and Hoysala actually ruled the Indian subcontinent, the southern subcontinent, from 10th to 14th century, and the Odias came in only in the 16th to 17th century. So there actually been a futuristic role, and it should have been Hoysalas versus Odias. I don't know if the management has something to do with this, supporting them. Okay, and here Mr. Srihari is here talking about the premix. Though he's a futuristic leader, I don't know why he's gone back to his prehistoric age and still stuck with his premix insulin. So here there's a legacy effect. As we all know, aggressive glycemic control at the early stage is very important as per your UKPDS studies, and says the earlier the better, and we have all seen the risk reduction from 14 to 41%. The later you start it, you have more complications, and just the macrovascular complications you can hear. The legacy of basal insulin, the treat to target concept has demonstrated the role of basal insulin analogs in facilitating the insulin replacement, lower risk of hypoglycemia, and it has actually become the foundation of the therapy. The 4T studies have shown that over long-term use of premix insulin over 3 years has no role and has less effective in controlling the glycemic state. So that itself rules out the premix journey. And though, as you mentioned, the premix history has a better control in FBS and an HbA1c, I think the whole risk here is the hypoglycemia event. So Shriyar is only worried about his number games of FBS and HbA1c less than 7, but he does not understand the risk is putting his patient for an hypoglycemia, the amount of stress is causing for the patient, the amount of repeated admissions, the amount of recurring cost to that patient. I think that is equally in our thing, and I do not know what cost effectiveness he's talking about. So, and it also has better, lowers the weight gain, is the basal bolus. So premixes are not suitable. The reason is because of the inadequate prandial insulin, which causes postprandial hypoglycemia, and excess interprandial supply, which increase the risk of hypoglycemia. This is the story why they go into repeated hypoglycemias. And the main reason is because of their fixed ratios, which makes them less flexible, less adaptable to the individual specific needs than a basal bolus. I'll talk to you about the individual needs in a while. We have certain studies here, the laptop study, which compares the insulin glargine added to an OAD regimen versus pre-mixed insulin, which tells us about the cost effectiveness. It's just being penny wise but pound foolish, and I think that's what the study says, that is actually kind of cost effective in the long run over the annual cost for that patient, and it is equally glycemic control is there. The innate study, the comparative initiate study, which says that it is also kind of better glycemic control with the basal bolus, and with the basal insulin, it is easy to initiate a patient on insulin because they may actually land up with only 1 prick, whereas a premix is a must for 2 pricks. So once the patient is initiated, it can gradually be taken for a plus or a bolus of 2 or 3 injections later on. So again, we score over here. The ginger insulin is one which gives basal bolus over superior glycemic control over the intensified premixed insulin. Again, the risk of severe hypoglycemias, weight gain is the cause, and better glycemic control is seen in the basal bolus. What more do you want, dear friends? We have better glycemic control, no hypoglycemia, less cost, less weight gain, better patient acceptance, better initiation, and now we have the icing on the cake. Also, you have the glycemic variability because of the hypo and the hyperglycemias, which can actually be reduces with the basal bolus therapy. And one more, the cherry on the cake is one more here. Switching from premix to the glargine, there's an increased patient satisfaction. The treatment satisfaction from the patient side is enormous. I think that's what we're all asking for. One more feather to the cap is the patient satisfaction. How many of us here using insulin analogs, are we all ready to say they're good and very good for the insulin analogs? I think that itself answers the question. And here we have a the subcontinent, the Indian study, which says that the quality of life is improved, again, with the basal bolus. The mobility, the self-care, the usual activities, the pain, the discomfort, anxiety, and depression of repeated hypoglycemias. I think just now Dr. S.R. Arvind mentioned about that hypoglycemic episode, and you know how emotionally turmoil it is for a patient. With this conclusion, the basal bolus regimen offers patient flexible treatment that responds to different needs and lifestyles and reduces the glucose variability. And what I would like to say on this point is, if you go for a premix, our life revolves around those 2 insulin syringes, and we have to revolve around that, the diet, the exercise, the timings. But with the basal bolus, the insulin facilitates us our day-to-day routine. We just need to take the bolus. And if at all your main meal is either a breakfast, lunch, or dinner, all that you need to do is just add that plus dose. So where do we stand, dear friends? I think definitely basal bolus takes over at every level, and it has a 360-degree coverage. Thank you.
Now for the time for rebuttal. Time for rebuttals.
Thank you, Dr. Shobha. Thank you. As you said, of course, hypoglycemia is what you are talking about. As I said, there are a lot of studies and think strategy which shows that proper education of hypoglycemia, premixed insulin can be very well used. And making the treatment of diabetes simple is very important. Ma'am, do you think that with basal bolus we don't have to educate patients with hypoglycemia? And are our patients very friendly with using one pink pen in the morning, blue pen in the afternoon, and black pen in the night? With premixed insulin, it is more easier to educate the patient. Thank you very much.
Now the captain. Over to Dr. Shobha. Your turn to rebuttal.
I think Dr. Shriyari is still in the prehistoric age and being very colorful with the pens and talking things which does not actually matter to the content. I think what you should ideally understand at the end of it, how safe is your patient. Hypoglycemia, yes, very occasionally. I don't have to repeatedly make the patient stay awake in the night and fear of hypoglycemia every night. It does not occur that way. I think at every angle, whether it comes to the glycemic status, the cost, I think that repeatedly I'm talking about the patient satisfaction, the treatment satisfaction, the glycemic variability, everything scores over us. So I don't think so he actually has any say here. Thank you.
Okay, that's a big, the captain is coming up. She wants to tell some points. Okay.
Yes, definitely. I think if I catch Dr. Shobha far away from the venue of Krssdi and ask her for an audit of her clinical patients, we would know who's won this argument, right? When we look at diabetes distress, there are multiple components under diabetes distress. Do you know that regimen-associated distress is a big section of diabetes distress? The medications or the insulin regimen that we choose itself is a cause for stress for our patients. And then we talk about how we can reduce diabetes distress for our patients. Are we recommending basal bolus for all? Are we recommending premix for all? Not at all. There are a subset of patients who would definitely need to be on basal bolus, but premixed insulin is what you and I choose, right? We are sitting here in the middle of Bangalore on this lovely afternoon comparing studies about premixed insulin versus basal bolus, whereas your patients who come to meet you are out there living their lives, right? So people do things like taking care of diabetes in the middle of the larger thing of living their life. Just insulin dosing, checking, hypoglycemia is not their life. So when you decide what is best for them, you have to think about what their day is about and how your regimen is either going to get in their way or make it easier for them to live their lives while achieving the same targets. You and I have attended enough number of basal insulin talks, enough number of premix talks, and we all know that they all have enough data for this side or for that side. That's the truth. So here, if you have laptop study, that side you have 1, 2, 3 study. But I'll ask you to go back and audit yesterday in your clinic. How many premixed insulins did you write? Yesterday in your clinic, how many basal bolus insulins did you write? And then you know the answer. And think about this when you raise your hands. Thank you.
Swaraj, over to you. That's a big challenge from Chitra.
I think Dr. Chaitra is so eager that she was not letting our players speak. She wanted to speak before. So that itself tells the jitteriness. So I don't think so I'll have to talk. She talked about how many premix insulin Dr. Shobha has written. Hello, we are talking here science. Basal bolus is the best thing. You also know it, don't you? Yeah, you are the one. Second is regimen distress. Regimen distress. Yeah, you put a patient to a chemotherapy, there is distress. Who says there is no distress in chemotherapy? Hell lot of distress. Put the patient to bariatric surgery. Distress? No distress there? Then subset of patients. subset of patients is very important where we choose, what we choose. Similarly, for bariatric surgery also, she taught the fourth thing. When she knew nothing was working, she came up with emotion. Oh, how are they going to do? How are they going to live? They have to prick, they have to check. No, science says basal bolus is easy, acceptable and agreeable. And with good HbA1c reduction, good microvascular complication reduction. Thank you.
Now, now we have a real tough fight between the two teams. I think we'll leave the audience poll now. We'll go for the audience poll for the results. I think, as you rightly, both of you have pointed out, so both has got, premix as well, basal bolus has got plus and minus points and all. Both easy, comfortability, hypoglycemia, both, as there are two groups of studies favoring each other. Like, we'll leave to the audience poll now, like what they do in their clinical practice along with the science. Who is for premix insulin? No. There are some neutral agents. Who is for basal bolus?
Yes, you have the verdict there. I know that science is difficult and theoretics are something, but in reality, how many of you write more premix than basal bolus? So that's another question to ask. But that's not the debate here. Debate was on science, and I think we saw the answer for the same. Let's move on to the next topic. May call upon the next contestant here. CGM in pre-diabetes, yes or no? Now we have two speakers. Vikrant Shalini and Leela Mohan. So who's going to speak first? Shalini? Yes. Oh, for yes, right?
Yes.
Yeah. CGM in pre-diabetes is for the topic. Is it going to be a game changer?
So before he asks how many for yes or no, I'm going to ask how many rooting for France and how many rooting for Argentina? Dr. Arvind. Okay.
Yeah, I'm here for France. French.
The chairman, Dr. Suman. France, okay, there we have it. So, let's play some football. So I think, can I play football with this? No, I don't think so. Oh, he said not to have some derogatory remarks. So, well, we have set the stage. So, I think we have to have proper equipment, mindset, and the attire. I think I would like to change before I play football. So, same goes with my topic. You know, gone are the days when it was lifestyle modification, fruit khana hai, acha khana khana hai, exercise karna hai, 40 minutes, and that's it. And you write off the patient, especially in pre-diabetes. Pre-diabetes is taken very, very casually. You know, let's not get fooled by the pre. You know, it's a serious condition. It can lead to diabetes, stroke, heart disease. Almost 5 to 10% people convert into diabetes annually, and you know, it's associated with, I mean, everything is on. It's not like pre-diabetes is like a, you know, no disease. And we all know that high-risk patients, who are the high-risk patients who get pre-diabetes? Overweight, obese, individuals with family history, gestational. Now, prevalence, if we talk about, we all know the numbers, 79 million in India, diabetes. How many times do we talk about pre-diabetes? I think that's the focus, and that's why I love this topic, and I thought I am definitely going to talk about CGM. I think not many people think about it. We always, you know, try to prevent something. Why not focus on preventing? If we had prevented by lifestyle modification, we would not be having this conference. Everybody would be not diabetic because you have already controlled with lifestyle modification, no pre-diabetes, no diabetes. So, you know, 1 in 3 American adults pre-diabetic, 80% don't even know. Can you imagine what is happening in India? According to the ICMR study, in 15 states, the overall prevalence is 10%. It could be as low as 6% in Mizoram and 14% in Tripura. Even the adults are, even the adolescents are not spared. Look at the boys and the girls in the age of 10 to 19. Can you imagine If you don't do something in pre-diabetes now, what's our future? And according to the Krssdi, Indians have one of the highest incidence of diabetes and rapid conversion from normoglycemia to dysglycemia. If you look at over here in that cohort, they studied for 10 years, 299 people, out of 299 people, 176 progressed to diabetes, almost incidence rate of 78.9% per 1,000 years. So we all know what are the predictors of dysglycemia. Now comes the CGM. Now CGM is not new. It was introduced in 2000, almost clinical application. And it's always on. You're showering, you're working, you're exercising, you're watching Netflix, it's on. And you can see real-time data. And it has critical piece. It's current. You have 6-hour historical data. You can see where the trend is going. And nowadays, such state-of-the-art. You don't have to validate with the pinpricks. You are absolutely autonomous and alarm warnings. I mean, sometimes it can send an alarm to a parent of a type 1 diabetes that, hey, the sugar is low, and they can act. So basically, conventional counseling, not enough, and they show that a self-appropriate monitoring strategy is the need to do and habits are very, they're burnt into your brain. Very nice example of a toothpaste. He said they have a film on the teeth, you brush, it triggers a routine, and you get a reward, beautiful, sparkling smile. That's what the CGM does. It shows you your sugar is high, it triggers an action, you do your lifestyle changes because you have some hardcore data, and you get a reward. Now, personalized glycemic response is the in thing, and it's the most talked about topic. What I eat a chapati and rice, and with Dr. Suman eats a chapati rice, our sugars will not go similarly high. It is very different depending on his microbiome, my genetics, his genetics, and the kind of response we have. So which CGM is going to tell you what it is, so it is to be customized, and it's a game changer, and it actually empowers a person to accurately predict his glycemic response. And I think the most important point, the second point, physicians really need to change their own mindset. Behind all the apps and the non-medical people and in the Instagram, everything is running far away, and doctors are just sitting and doing the lifestyle modification. So let's not bet on who will win the cup tomorrow. Let's put our money on technology, and let's play with the right equipment. Dr. Pratyush.
Thank you. Thank you for touching the point. So after a prolonged CGM, we'll move on to the crisp no CGM by Dr. Leela. Dr. Leela Mohan. Slides, please.
Good afternoon, everyone. Thank you for giving me the opportunity to talk in front of all of you. It was a great pleasure to talk in front of all of you to afternoon. I thank the team Krssdi. Ma'am, Shalini ma'am had spoken very well about CGM, definitely. And thing is, there's no thing about pre-diabetes. What we are looking at is CGM in pre-diabetes. Definitely CGM is good in diabetes, not in pre-diabetes. So I'll tell you why it is not used in pre-diabetic. So the CGM devices in pre-diabetes, I really don't think it's necessary in pre-diabetic stage. So CGM is used to monitor blood sugar levels. We all know that, no doubt about it. But pre-diabetes is not the right time. I practically ask you a question, how many people use here a CGM in pre-diabetic stage in the audience? In pre-diabetic stage, not in diabetes, in the pre-diabetic stage. I don't think no one. I don't think anyone. Only one. Out of 100, only one. So we know all the CGM devices which are available. So about Freestyle Libre, Dexcom and Medtronic, and there are some more devices. And then we know the cost of it, and each device's cost, it's too much. Each device of with reader, it is around 4,000 to 5,000. When we see the Dexcom and the Medtronic and all those things are more than 14,000 to 15,000. So which will not be affordable by each and everyone in our country at least. The CGM limitations, mainly the physical limitations, the emotional cognitive burden, the accuracy concerns, and the clinical inertia and the costs. So the physical limitations with CGM are commonly identified as barriers to use. The clinical installation is a tedious procedure. When we compared with the SEMBG, the CGM is very difficult to apply. It has to be applied by a healthcare professional in a hospital setup, not by an individual at home, definitely. And then there are a lot of problems with the CGM devices if they are applying at the home. We know that when they apply it, there is a failure of the sensor, there is a dislodgement of the sensors, all certain things happens and give a wrong data which cannot be considered in treating diabetes. So patients avoid coming to the hospitals with the reasons of panic, and because of the CGM, the patient will be aware by himself, I'm using a device which I don't have it. The pre-diabetes is a stage that we have to prevent before only, and we should not let the patient for that diabetes. So CGM, when we apply the CGM to the patient, so the patient usually they'll be under a panic. So they feel that I have a disease already, I am set into a disease. The doctor asked me to put a CGM device. So they develop into panic and anxiety, which can cause stress and increases your sugar levels. So the self-diagnosis done by the patient and doubts to use the device, there will be a lot of doubts. And we know all the devices can be used only for normal 14 to 15 days. There are devices which are only for 7 to 10 days. So the data, whatever is available, will not be accurate after finishing of the device for 14 to 15 days. So the common sensor failure or accidental dislodgement due to reluctance of the patient. The cognitive burden using a device will constantly remind the patient about their diabetes. Continuous stream of glucose information can be overwhelming. Privacy would be a great concern. The patient will feel that once they put the device on the arm, the other people will think that I'm a diabetic already. So there are certain things which will run in patient's mind, and then they will try to stop the device using. So the frequent exposure to false or unnecessary alerts can lead to users becoming less likely to respond to those alarms. There are things called as alarm fatigue. The accuracy concerns. During the pressure applied on the sensors during sleep has proven to give out wrong results. That leads to the loss of trust on the device. So the CGM costs, as already discussed, there are different devices with the different costs. So as of date, there is no direct indication of CGM as a monitoring tool in pre-diabetes by any of the organization. So the NDPP only recommends AGP as a monitoring tool for pre-diabetes progression, and CGM is not affordable to the majority. 70% of our patients are from rural. In pre-diabetes, the acceptance rate for CGM is very poor, even in urban areas. As per ADA 2023, irrespective of CGM utility, definitely we have to use a glucose monitoring. False low readings are recorded in the first 72 hours. So there are certain cases, we can see the data here, what CGM has done here. A 45 male, which HbA1c was 6.1, CGM was applied. So he had followed the strict diet, but there was no improvement. We can see the HbA1c around 8.2. And there's a second scenario, a housewife, which we had not prescribed the CGM, but still the data and the HbA1c was not under control. So on a last minute, so what I wanted to tell is, on a funny note, I'll tell if we'll use a CGM in our clinical practice, definitely patients will not go to diabetes and your pockets will be empty and you'll be waiting for the patients to come in.
Thank you, Dr. Leela. I think
Thank
Dr.
you.
Shalini is waiting to kick the ball again. Dr. Shalini can rebut.
I don't know which shop Dr. Leela is buying the strips, as if he was giving free strips, for the one touch. It costs 20 rupees. You do CGM, I think hardly 100 rupees. And we are not talking about, 5, 6 painful pricks, right? So if you add up, that is going to be really painful, and I think the patient will change the doctor. He will go somewhere else. So, and one point which really, same point, difficult to apply. I think it's the most easiest way to apply, and hello, we are doctors. Please become technology savvy. We can't go to the old timer and giving pain to the patient. We have to learn. We have to go with the time. All non-diabetic people, everybody non-medical doctors are left in it, advertising on Instagram, social media. We will be left behind if we are not able to address these issues. We definitely not going to tell the patient, go ahead and do the pricks. And he said, panic. The patient is in panic. I don't think patient gets panic. I think the human behavior is prevention. We prepare for us, ice storm. We prepare for some cyclone. We prepare. So why not prepare and prevent diabetes by giving some robust tool to a patient, which I demonstrated the habit loop. If you give a cue, the cue for the CGM would be, look, I have high sugars. Hey, I ate the gulab jamun. And then the response of the patient would be, okay, I will not eat it. I will eat healthy snacks. I will eat the carrot and the gajar mooli, and I will exercise. And then the reward is right in front of him, right there. Raw data never lies. He gets motivated. It's just not the 3 month mein ek bar patient comes to you and, okay, you have to do more exercise and more diet, and I don't have anything else to tell you. So I don't think we are living in this era, and I think we should be go hand in hand, support the patient with the technology. And I think the FIFA people, Messi doesn't make a goal. There's a hi-fi technology goes into all the shots and the analysis and physiotherapy. Everything is technology based nowadays. Gone are the days. And I think what he said was last slide. People don't have money in rural areas. I think if you go look at the data, which I don't know, maybe you forgot to look at it. The highest GDP in Chandigarh, 3,883, basically the most socioeconomically advanced or the rich. Chandigarh is the highest rate of diabetes and pre-diabetes. So definitely they can afford, and I'm not telling to put a CGM on the entire Indian population. I'm telling to strategize the patient, pick up the patient who have pre-diabetes, who are at risk, which I mentioned, obesity, overweight, gestational diabetes, and give them a tool, a CGM, which they can absolutely look at their personalized glycemic response, which I showed a slide. Thank you so much.
Dr.
I
Leela.
hope I can see the audience raising hand for CGM. Okay, there we go.
Ma'am, Shalini ma'am, very well spoken. What is the topic here is CGM in pre-diabetes, ma'am. It is not diabetes. In diabetes, definitely CGM is always better. You don't accept it, I'll only accept it. Here topic is pre-diabetes. In pre-diabetes, how many times you want your patients to ask to check your sugar levels? How many times you ask your patient to check? Even during diabetes, we ask them, do it once in a day or weekly once, depend upon HbA1c levels. In pre-diabetes, if already HbA1c is less than 6, I am not here to talk about the scientific data, GDP, GDP, all those things. I am here to talk about the CGM in pre-diabetes. That's all. So how many of you here would like to put a CGM in pre-diabetes? I just wanted to ask only one question. CGM is definitely good. I am not saying no, but in pre-diabetes. And SMBG that costs, which is very less, and the glucometer stays for them, along with them for the whole lifelong, which costs a strip of 10 rupees or 20 rupees. And CGM is only just for 10 days or 15 days, depend upon the device. So every 10 days or 15 days, you want them to spend 5,000 rupees every month. And how many people in India, if I am there as a patient, even I don't want to spend 5,000 rupees in a day or for 10 or 14 days to just check my sugar levels. And where I'm not diabetic. That is what I wanted to say. But anyways, in our practice or in my practice, usually I never prescribe to use a CGM in pre-diabetes. So that's all.
Thank you. Captains, last word.
Okay. So I think 15 years ago in Krssdi, if we go back and look at the programs, I'm sure there was a debate which said CGM versus SMBG in diabetes. Right? There were arguments and people made strong arguments that What is the CGM so expensive? What if it falls off? My money will be wasted. And now everybody is agreeing, including our opposing team, that CGM is the way forward, right? All change is uncomfortable. All change is uncomfortable. So at first, our wish is to resist. Dr. Shalini is not recommending CGM for you to decide treatment or for you to modify treatment. She is considering CGM as a tool which can be used to make more specific and personalized lifestyle recommendations, right? You and I both agree that the lifestyle recommendations that we make are generic and at base mostly useless, right? Avoid all sweets, stop eating that, stop eating this, eat chapati, don't eat rice. Random statements which random people have made. All of us are different. We all know now that all of our glycemic excursions are completely individualized, affected by numerous factors. CGM is the tool which will help us understand our individual responses to this. I'm sure many of you in the audience have all tried a CGM yourself and learned many interesting facts about your own response to your different kind of food, right? That is the data which would probably make making lifestyle changes easier. You and I both agree making lifestyle changes are not easy. Instead of saying never eat sweets, can you figure out a way for your patient to accommodate an indulgent once in a while so that they can still continue to overall bring down their HbA1c, but still continue to still live their life? That's the point that we're trying to make. This is a very futuristic topic, but we are heading towards personalized medicine, where we are using big data about multiple aspects of our genome to predict which medication will work for you. That is pharmacogenetics, right? We're also looking at how we can figure out how different times of the day can affect your sugars better, right? That is using the chronicity of your metabolism to hack it to improve your HbA1c control. So I would be okay if the audience does not get this point at all, but your patients are on the bandwagon already. Right. Whether they tell you or not, they're already using the CGM. Whether they have diabetes or prediabetes, they are
Chitra,
using it.
we're running out of
to
time.
hack
I
it.
think you conclude.
So I'll hand over.
And I have 1 minute for Swaraj. Please conclude. We're running out of time.
Unfair. She made so many points.
No problem.
At
You
least,
can make your points.
At least
You can
100
make your
seconds.
points in 1 minute, yeah.
Okay, 15 years. So, Dr. Chitra is so startled by the first two talks that she talks 15 years before we were comparing SMBG versus CGM, and at the end she says this topic is futuristic. Okay, so changes are welcome. Everybody welcomes change. We learn, we unlearn, we relearn, we become wise. How do we become wise? By knowing that when to use, what to use, how much to use. So in pre-diabetes, what is the point? We showed two cases. One was put on CGM, another was not put on CGM. Real life practical cases, nothing improved. Yes, lifestyle. Lifestyle is the easiest and the most acceptable thing which is not done. By whom? By the patients. Why? God knows. Tried CGM, myself have tried CGM, but what? I knew that I'm eating XYZ thing, my sugars are going up, I need not have to eat. Yes, Baba, theek hai, we are not eating that. But what? We will indulge anyways once the CGM is off. So what will I do after that? Then, how many follow diet? Nobody. Then she's shifting poles from genes. Why do you have to talk genes when you're talking about CGM?
Thank you for the wonderful debate by ODRs and Noisalas. So at the end, we will look at how many will start using CGM in pre-diabetes. Lift your hands. How many will not use CGM?
Answer, I think it's futuristic. Once again, may I welcome all the team onto the dais, the captains, Chitra and Swaraj, for their wonderful rebuttal and defending the teams, and all the debaters onto the dais, please. Thank you, everybody, and thank you, wonderful audience, for being with us, and hope you enjoyed the debates. Please take the signs only.
Thank you so much.
Thank you.
I think this was really, heartwarming and probably just taking the sleep out of you. Thank you. Thank you so much. And we were really seeing the excitement over there, and none of the speakers were sitting. Everyone was jumping around, and it was real fun. And we really thank all the chairpersons also. Please stand for the photo, sir. It's not that who won. It's main thing. It's the sportiveness and the science behind this debate to make sure that you're all entertained. Thank you so much.
Wow. Power packed of performance by everyone. I'm not I'm still wondering what's going to happen, who's going to write CGM, not premixed insulins or basal bolus. Even I'm wondering now. So the next topic, I think a topic which is very less spoken about, diabetic erectile dysfunction. Can it be reversed? And would like to call upon the chairperson, Dr. Vinay, consultant physician, and Dr. Mohan Kumar, consultant physician for the, and the speaker would be Dr. S. Vasan.
Good evening, everybody. As a EC member, I welcome you once again to this Krssdi conference. Erectile dysfunction is a common problem in diabetics, and we'll hear from our speaker, Dr. Vasan. Can it be reversed?
Thank you very much, and thank you Karnataka RSSDI, and Suman, Dr. Manohar, and the whole team for this opportunity. I'm not going to bore you about erectile dysfunction. Next couple of slides, I will just take you through, just like there is a transformation in the management of diabetes where you discuss a lot of things and you have a lot of interesting debates. One of the challenges is been erectile dysfunction, and one of the challenges in erectile dysfunction is diabetes, because we know it significantly impacts erectile function because of various reasons. So just to give you an analogy, when the pill came in 1998, which was Viagra, it was like giving a man superhuman powers, just like you see in several movies. So there was a transformation of a man for a couple of hours. And consequently, everybody thought erectile dysfunction is cured. But the man was limp again after half an hour and he could not perform without the pill. So what happened was, because of the development of this pill, there was lack of understanding of the underlying disease, which is diabetes in your case. And we also know that the pill led to reduced effect over a period of time. And of course, there were fatal associated events because of the pill and so on and so forth. Historically, if you look at it, we were looking at where does the erection start. It starts at the central nervous system. So people looked at arousal mechanisms to correct the arousal mechanisms, which they found very difficult to correct. And there were various reasons for this. And then they looked at lumbosacral spine, where the ejaculatory reflex and the neuronal mechanisms are facilitated. And that was one area of correction. And then finally came to the corpus cavernosum. So these are the areas where you could modulate or manipulate erectile function in a given male. And we are all aware of the cyclic GMP pathway, the breakdown of the cyclic GMP to GMP, and that's how Viagra or any of your sildenafil or tadalafil tablet acts. And consequent to understanding of this corpus cavernosum mechanism, there were various agents which came in to picture your sildenafil, tadalafil, vardenafil, and you had the second generation which came. But all of them focused on only one thing: increasing intracavernosal PDE5, which is the breakdown, preventing the breakdown of PDE5. So essentially, not correcting any pathology. It means intrinsically whatever PDE5 you produce, that was facilitated. So this led to what is called as undifferentiated prescription. Anybody walks into an erectile dysfunction, it's like walking in with a fever. Okay, take a Dolo 650. So you take a Viagra. So, but at the end of the day, we do realize that there are a lot of metabolic changes and events which happen in the corpus cavernosum, which could also be fatal. And there was a recognition that the ED in a diabetic could be an early marker or a sentinel marker of a cardiac disease. And additionally, these were facilitated by use of testosterone in erectile dysfunction, where people felt that the response could be improved with testosterone. You also had some amount of nutraceuticals, which is your ginseng, L-arginine, maca, dihydroepiandrosterone, all symptomatic treatments which were given as a co-prescription along with your sildenafil or tadalafil to facilitate a better use or a better response of an erectile function. But generally, nobody looked at what was the basic pathophysiology, just like you have your autonomic neuropathy, you have your vascular complications in diabetes. Nobody looked at it. So what has changed, just like in diabetes, what has changed is, just now I heard the talk that glucose absorption or glucose levels after eating the same type of food in different individuals is different. Similarly, ED is not the same in all the individuals. You can't have one drug for every problem of every male, because we know that there are complex neuronal, vascular, and molecular interactions, and there are various anatomical structures. What is the exact pathophysiology, if you understand, and this is more prevalent in diabetic population, then only you can reverse ED. Now we are in an era of not talking about just giving a prescription. We are in an era of reversing erectile dysfunction. That is what it is. So now the era of research has gone into why diabetic men have ED and why they are more non-responsive to medication. We all know that diabetic men are not responsive. Not all of them do respond, basically because of the same pathology of your metabolic syndrome, autonomic neuropathy, and vascular prevalence, which is high. One of the barriers to developing an ED subspecialty in erectile dysfunction in a diabetic clinic was the lack of privacy. And secondly was the fact that erectile dysfunction, because it evolved as a psychogenic problem earlier, there was a complex history taking. It could be psychogenic, it could be neurogenic, it could be arteriogenic, it could be combined. So the history taking format was too complex to be incorporated in a regular diabetic practice. So now we know that 80% of the problem in diabetic men, especially with erectile dysfunction, is no longer psychogenic. It is not, it could be a combination of mainly vasculogenic or neurogenic or autonomic neuropathy. So we have devised what is called a 6-question format, which is very simple to use, because you basically want to finish this what can I say, this questionnaire in a very, very rapid format, and this gives you a broad overview whether the patient is suffering without embarrassing the patient, whether there is an erectile dysfunction or a premature ejaculation or both, because these are the combinations you would like to treat. Then what happens is that the patient, when he presents with erectile dysfunction, this is an algorithm which we have developed. He could have an associated erectile dysfunction or a premature ejaculation, or he has an associated comorbidity like your diabetes, hypertension, dyslipidemia. So we use a very short history format. And of course, in your diabetic patients, you always should look out for balanitis, because balanoposthitis could prevent sexual activity in majority of cases. And we are all aware you need to establish medical control. Then what happens? Are these men safe to take medication? Do you require a complex cardiological examination before you start any sort of PDE5 inhibitors? No. If he can climb 2 flights of stairs, which is 20 steps in 20 seconds, or without breathlessness, or he can walk 1 mile flat in 20 minutes without breathlessness, which is called as Princeton consensus criteria, then they are safe to take any PDE5 inhibitors as long as they are not on nitrates. So then you initiate a patient with PDE5 inhibitor, and which is usually a sildenafil. We always give sildenafil in these men, more preferable than tadalafil, where we give 50 milligram on demand, and 2 tablets he uses on demand. That means he uses whenever he wants. And generally these men have very low sexual desire, because women are also not cooperative or are not interested because of family issues and children and all that activity, so that there is a stimulation of the penis. And if there is no erection on 2 subsequent 2 tablets, they increase it to 100 milligram. And if at the 100 milligram 2 tablets, that means total 4 tablets, if they don't, then they have a significant problem. In trying to suggest to is not all diabetic men require extended evaluation. You can categorize your diabetic men on the basis of their response. If they are simple diabetic erectile dysfunction, they will respond to this. If they are not simple, then you require further investigation. So what is the further investigation? Of course, there are 2 caveats. If he is breathless on walking 1 mile in 20 minutes, then of course you are not going to start a medication. Now what happens in a diabetic? Why are men not responsive? Because we all know that the nitric oxide is predominantly present in the endothelium, and a good amount of nitric oxide is necessary to initiate a PDE5 response. And you have normal endothelium, you have endothelial dysfunction, you have an abnormal endothelium. So how do you differentiate these two? Because if you identify men who have endothelial dysfunction or an abnormal endothelium, correcting that would facilitate him to respond to an erectile medication, erectogenic medication. So research has gone into various biomarkers where we are looking at C-reactive protein, fibrinogen, your cytokine markers like IL-6, IL-8, and various things. These are blood biomarkers which we use. We also use monocyte count, which is a very simple count, which we use on the basis of monocyte count. Higher monocyte counts are associated with increased risk of cardiovascular events. And of course, there is research going on in asymmetric dimethyl arginine and symmetric dimethyl arginine. But there are certain tools which have evolved to assess endothelial dysfunction in all diabetic men. And these are non-invasive tools. They are very simple to incorporate in their practice. What essentially we do is measure the fingertip vascular reactivity or the brachial reactivity, where we look at the endothelium in the basis of the pulp oxygenation, which is similar to cavernosal artery, because it's a surrogate area where we check, because we can't check the penis. Then we measure the central arterial pressure, and we measure the carotid to femoral pulse wave velocity, because we want to understand only two things. One, what is the level of terminal arteriolar health, and what is the vascular stiffness. If you understand vascular stiffness and terminal arteriolar health, then you can classify these men into two categories: diabetic ED, non-responsive to medication with endothelial dysfunction; diabetic ED, non-responsive to medication with vascular stiffness, or it could be a combination of both. All these men, which is highlighted here, your numerous risk factor, they're all prone to this, and these are the green marked ones, which are very simple to use, which are tools which are available. These are all FDA approved tools to diagnose men who have endothelial dysfunction, because you're looking at reversing the diabetic endothelial dysfunction. And this is a classification to tell you how less invasive it is. And these are tests which are done in 10 to 15 minutes, just similar to your ECG in any of your thing. Then what do you do? Once you have this, then either there are strategies which are being evolved with anti-inflammatory drugs to repair the endothelium with your either statins or glucose-lowering agents or your anti-inflammatory drugs, or you have non-pharmacological treatments, which is your shockwave therapy and your platelet-rich growth plasma. Now, what is the concept of shockwave therapy? Shockwave therapy is essentially not shock waves, they are sound waves which are directed, which were supposed to cause neoangiogenesis of any tissue. Now we know that though there are multiple effects of these shock waves in terms of shear stress, nitric oxide synthesis upregulation, VEGF upregulation, and so on and so forth. But we now know that shock waves essentially facilitate a better elasticity of the blood vessels. They make sure that your resistivity index and pulsatility index comes down. Consequently, the distensibility of the vessel improves, and that's how the blood flow improves. It corrects the vessel wall deformity at the level of the penis, and that's the hypothesis, or that's the way shockwave works. And similarly, platelet-rich growth factors are supposed to be angiogenic, vasculogenic, and regenerative. So there are various types of platelet-rich growth factors which we use. You have pure platelet-rich plasma, you have leukocyte and platelet-rich plasma, you have pure platelet-rich fibrin, you have leukocyte and platelet-rich fibrin. So essentially, you individualize depending on the treatment of an individual, depending on the severity of endothelial dysfunction, and there are various methods of preparation, hard spin, soft spin, and so on. But what essentially are the growth factors you are looking at? You are looking at VEGF, you are looking at PDGP, you are looking at FGP, and you are looking at EGF. So these are the various growth factors which is concentrated and given into as a simple injection to the penis to repair the endothelium. So this is what happens. So when you categorize your patients who are diabetic, who are non-responsive to medication, and consequently none of them would require surgery and they could be managed in a very effective way. And of course, if this fails, there is also your stem cells, which people are, the treatment in the stem cell arena is still evolving, where you have your bone marrow derived stem cell, umbilical cord derived stem cells, and adipose derived stem cells. So these are the various things. So just to summarize, I'm going to give you an algorithm for ED management. One is to, I don't know whether you can see it, whether to classify these patients as a history of erectile dysfunction as well as associated premature ejaculation, classify them as mild ED or moderate to severe ED, basically on the basis of grading, just a grading 1, 2, 3, 4, where hardness score of 4 is the best, 3 is mild, 1 to 2 is moderate to severe. So if it is mild, you start them on a medical treatment, just like I told you, sildenafil 50 milligram 2 tablets, and if they don't respond, increase it to 100 milligram 2 tablets, and post that, you can always add at that state L-arginine, which is the only drug which is supposed to facilitate a better nitric oxide. And if they require psychosexual counseling, you do at that stage. If it is moderate to severe, on the basis of the classification of your scoring, if it is moderate to severe, you straight away start them on sildenafil. If they are not responsive, then you subject them to your endothelial assessment and pulse wave velocity assessment, and then you reclassify them as vasculogenic and non-vasculogenic, and then you start giving them, this is the other classification I just put up. I'm just rehearsing you again one more time just to show that, but I'm going to skip this slide. So once you know that, so once it's a vasculogenic ED, we go by the degree of endothelial dysfunction. In terms of the peripheral or the capillary perfusion, we use an instrument called Wendy's, which is a FDA approved instrument, which essentially is the terminal arteriolar vascular health, and the values range from 0 to 2.5. If the values are less than 1.6, those are individuals who require platelet-rich growth factor injection into the penis, and their diabetic ED would become reversed, and they would become facilitatory to an oral management with your sildenafil or tadalafil. Similarly, if they have arterial stiffness, we give them shockwave, which is 12 sessions. So we are clearly categorizing men into responsive, non-responsive group, and giving them directed therapy. That means we direct them to a specific modality, so there is no wastage of time and effort. It is not a gray area anymore. And there are people who have a combination of endothelial dysfunction and arterial stiffness. Then we combine both modalities. We give platelet-rich growth factor first. Always we repair the endothelium. Then we try to repair the vascular tone. So to summarize, the future of erectile dysfunction is not just about giving a tablet of Viagra. The future of erectile dysfunction, especially if you want to manage your diabetic patients, is to understand that diabetes, just like it is a multi-organ disease and has multi-organ involvement and has multiple areas where it can afflict an individual, define the erection type, whether it is neuronal, vascular, central, peripheral, visual, tactile, and then you can understand the molecular physiology. Luckily for you, in diabetes, it's mainly vascular, along with majority of your patients have a significant amount of endothelial dysfunction, and consequently, it's very easy to categorize these men. Once you categorize these men, it is very easy to channelize your treatment in a specific directed way. So it's no longer a gray area. Just like you can manage your retinopathy, you can manage your erectile dysfunction. Thank you very much, ladies and gentlemen.
Thank you, Vasan sir, for the elaborate presentation. And as we all know, no men, irrespective of age, want to suffer from erectile dysfunction. And being a diabetologist per se, so we know the erectile dysfunction is multipathogenic. That is more of neuronal as well as vascular. And with the rising incidence of diabetes in young, usually couples come into our clinic complaining of infertility, husband having uncontrolled diabetes, and they are trying for kids, but they were unable to, and female, I mean, the woman doesn't have any problems, but the men, after sending the woman outside, so he comes and tells us that, sir, I have some ED problem. So, and this is one good presentation where we are, I think, being a diabetologist, we are only writing sildenafil and asking the patients to follow for a follow-up. But this gives us a complete entire picture, so where we can also think that there is multimodular approach for a patient with an erectile dysfunction. And future is, I think, there is, and it also gives us a ray of hope for future with men with ED. So any questions? Still we have left time. So any questions would be welcome.
Yeah, see, the way to use tadalafil is generally it depends on the frequency of sexual act. There are two reasons why we use tadalafil. One, men with a frequency of sexual act which is more than 2 per week, then we use tadalafil because tadalafil is a long-acting drug and it stays in the half-life is much higher. Or in men who have significant ED where their response is less, then we use what is called a suboptimal tadalafil on a daily basis to improve nitric oxide, which is 5 milligram tadalafil. Additionally, on the day of sex, they take a sildenafil. So we use a combination. So only in two situations. One, if your frequency of sexual activity is more than 2 per week, you use a tadalafil, it is a better drug. And in cases where your response to, let's say, a sildenafil is less, then you use a tadalafil on a daily basis, add sildenafil at the time of sexual activity.
So I have one question for myself. Actually, many patients, usually diabetic patients per se, have hypertension also. So, I mean, this is untouched here in your presentation. So how common is drug-induced erectile dysfunctions, and how do you go ahead, actually?
Yeah,
because we use thiazide diuretics as an antihypertensive, we use beta blockers, we use statins, basically. So which is, I think, one of the cause for erectile dysfunction. So how do you go ahead, sir?
So then generally you are right, because the drug-induced erectile dysfunction can be anywhere between 10 to 20%. And not all men have deleterious effects because of the drug. Generally the patient reports saying that I started this drug, from then on I have. Then you are much better off, because stopping the drug itself or changing the drug at that stage would help. But if you don't have that history, or even if you, sometimes what happens, once you start the drug, even if when you change the drug, the erectile dysfunction doesn't go away. That is because of molecular targeting. So what we do is, in those kind of cases, you can directly start them on sildenafil and give them a couple of doses of sildenafil so that they overcome, and it gives you, and you can change the drug if you feel it is necessary and it is the causative mechanism, and then they should be fine. Most of them, we start them on an additional dose of sildenafil because at that point in time, anxiety adds to their problem, and we don't want them to get anxious, and that is the reason.
There are no questions. I think we'll wind up. So thank you, Dr. Vasan, sir, for a good presentation. Thank you very much.
Now, my whole idea of presenting this was to make sure, though I'm a urologist, I operate very little of erectile dysfunction. Mainly erectile dysfunction, there was this era where people thought that erectile dysfunction means prosthesis. Prosthesis is a destructive surgery. It doesn't give naturality. No man wants to lose an erection. And all of us are living longer, and we are more wealthier, and our financial capacities have increased. So everybody wants to have a good time in their life. And now is the era where we are looking at regenerating several of these parts so that we stay young forever. Thank you very much.
So one group photo with the chairperson. Thank you, doctor, for enlightening us with the topic, which is very, very, very less spoken about. All of you will agree that there is a plethora of products available for treating type 2 diabetes. So the next topic will help us in deciding which product to use for which patient. Making smart treatment choices for elderly type 2 diabetes mellitus. And the chairperson for the topic would be Dr. Lalita, who's a physician and a diabetologist, and Dr. Anasuya, who's also a senior specialist. The speaker would be Dr. Basvanagoda.
Welcome. Good evening. Welcome you all. It is indeed pleasure to welcome Dr. Baswannegowda sir, who is heading the topic of making smart treatment choices for elderly diabetic. Morning we heard about type 1 young diabetic treatment, and a small brief introduction about Baswannegowda sir. He is a principal and a professor of medicine, dean faculty in JSS Medical College, Mysore. And throughout his career, he is a gold medalist. He is the best outgoing student of JSS JJM Medical College, Davangere. And he has won 4 gold medal plus 2 cash prizes for his highest marks in medicine in the Mysore University. And during his PG days also, he has presented many theses, and it has been a good presentation. Is one of best is lipid profile in diabetic. And he was also worked as an assistant professor in various government hospitals, worked as a lecturer, and is professor and now is HOD and principal. And he has also worked in AIMS New Delhi, and he was posted for cardiology training also. And let's hear from him without much delay. Over to you, sir.
Good evening to everybody. At the outset, I thank the organizers for giving me this opportunity. I'm sorry to put them in disruption of the program. I was supposed to speak in the morning as a second speaker following opening batsman, but for inevitable assignments in the institution, I could not come in the morning. And thank them for making this readjustment, but I am at a disadvantage now because the program is delayed by nearly 1 hour, and you all have witnessed such a wonderful scientific program, well designed. I congratulate the whole team for a successful program. And after the war between the teams of Warriors and Hoysalas, then listening to Vasan for erectile dysfunction, I had to speak on a subject which may not be of very great interest, but I'll try to see whether I can drive home some of the points based on the title of the topic. My topic is making a smart treatment choices for elderly type 2 diabetics. What do we have to learn? This is a disclaimer from MSD, who have sponsored this program with unrestricted academic support to the KRSSDI. My overview of the talk would be this. I will be elaborating on the burden of elderly diabetic population in India. Why is it important? How they are differently treated? Challenges in the management of diabetes in elderly population. What do we have? The available pharmacological options. Do we have a choice, and how do we make a choice? And what is the role of sitagliptin? In the very beginning, in the morning when we heard post-lunch, Dr. Arvind was talking, he gave a very shocking revelation that ADA 2023 guideline is taking away the gliptins from the guideline. I was really shocked. Then I was little solace with the answer given by Shekhar, who said, I don't believe ADA. So, because my recommendations will be that, and I was also talking to some of my colleagues. Arvind also said, apart from reducing A1C, it doesn't do anything. It does many things. If a drug does not produce hypoglycemia, if the drug does not produce weight gain, but it does work as an anti-diabetic drug, what do you want? So let me delve into this. Quickly take you through what is the burden of elderly population in the world. And look at our own country. As Shekhar was telling, the life expectancy before independence in India, our life expectancy was just 40 and below 40. A lot of people were dying of infectious disease and epidemics. In 1961, it was mere 42 years. In 2018, it was 69 years. Now it is roughly about 72 years. We are expected to shoot 76 years and above by 2050. Friends, we are having accumulating great numbers of elderly population in this country. And the evidence is that we are number 3 among the elderly diabetics in the world. We all know the greatest number of diabetic population in the world is China in general. And we are number 2 because of sheer number of population. And USA is number 3 in the order of merit of diabetic population. But when you look at only diabetic elderly population burden, we are at number 3. USA has taken over from us because their people live little more longer than us, and so they have a burden of elderly diabetics more than India. Just about, they have 11.5 million elderly diabetics. We have roughly about 11 million diabetics elderly in this country. Overall, if you take 65 and above age group, in the world, 50% of them, all diabetics, will be in the age group of above 65. That means it's a big number. If you're talking about 270 million, you have 135 million who are elderly. So we have, dear friends, we have to understand, how do we understand them differently? Do we treat them equal to an younger diabetic? That is the crux of my presentation. And we all know the lot of urbanization and movement of the people to urban areas and lack of lifestyle problems. I'll just put two important components, make us understand why do we need to make elderly diabetic get differently understood and treated than a routine diabetes practice. If you look at the pathophysiology and the link between aging, obesity, and type 2 diabetes, my job will be made easy. Aging will add on to sarcopenia, skeletal muscle dysfunction, frailty, central adiposity, malnutrition, physical inactivity, neuromuscular dysfunction, beta cell dysfunction, then hormonal dysregulation and deficiency. All these complexities will come up as a gift as we go on aging. And obesity becomes inevitably creeping up as we pass beyond 40. The insulin resistance will go with obesity, central adiposity, ectopic adiposity, chronic inflammation will stay on and work on, making a further progressive decline in the beta cell function and glycemia and so many other factors. So when we have this insulin secretion going on depleting as the beta cell function goes on depleting as we age, and also insulin resistance goes on increasing or persisting at least, we have a progressive burden of worsened diabetes among the elderly people. Having understood this, we need to know that aging and obesity lead to a development of progressive worsening of type 2 diabetes, increased adiposity, elevated insulin resistance, and ultimately culminating into more and more complex diabetes than what we see in younger people, and then more and more complications. Dear friends, when you look at all elderly above 65, 40% of those diabetics will have 4 and more comorbidities together. And nearly 60% of them will have one more comorbid disease. Beyond this, we need to understand there are so many interplaying factors which make them different than when you look at the young people. What are they? One is cognitive decline. It creeps up as we go on older and older. Polypharmacy, because of so many diseases are together. Disability adds up because of the sarcopenia and disability. Depression becomes inevitable gift as we go on aging. So many contributing factors will be there. Urinary incontinence, hearing difficulty, visual impairment, falls and fractures, and cardiovascular disorders. Friends, all these, along with 1 or 4 comorbid conditions, makes them a totally different individual as we go on getting aged. Very, very important point we need to understand. When the diabetes creeps in later part of life, how do we make a diagnosis? It's a very, very clear, evidence-based statement made. If you make only fasting blood sugar as a screening procedure, you will be missing a lot of diabetics among the elderly population because most of them will be normal. 2-hour plasma glucose with or without OGTT are the more reliable than fasting glucose for diagnosing diabetes in elderly if it starts little later in life. What is important is their clinical presentation is very different. Many of them will not have osmotic symptoms. They may not have polyuria, polyphasia because there will be higher renal threshold, number one. Number two, they will be asymptomatic. 1 out of 2 will be asymptomatic when it is especially elderly. And the symptoms may be totally non-specific. They may not come to you with polyuria, polydipsia, but they will come to you with not doing well, general weakness, fatigued, lethargic, and can be mistaken for a attributed for the age-related problem. It could be a diabetes presenting like that. And then it could be straight away presenting as a complication. So these are the differences among the elderly diabetics when compared to young people who are going to have classical symptoms. Diagnosis, as I told you, don't believe on fasting sugar for a screening procedure. Please do at least 1-2 hour postprandial blood glucose to pick up them, if not OGTT. A1C is specific but less sensitive for diagnostic purpose, which was very, very clearly stated by Dr. Shekhar. It depends on what method it is done. So just don't take the guideline by ADA that 6.5 and above A1C is diagnostic. I have seen patients where fasting postprandial is perfectly normal. He walks in with 6.7 A1C. Can we diagnose him as diabetic? Be careful in using that, especially in elderly. An assessment, the moment you diagnose diabetes in elderly, it is not just the numbers that matters. It is not that the cardiac health that matters. You have to look at these three important components, which should be a baseline assessment factor. Vascular disease is inevitably there. Physical assessment is very, very important. How functional it is physically. Neuropathic functions has to be assessed, and it could be one of the presenting symptom, neuropathy. And mental or cognitive functions are very, very important, which we hardly spend time in diagnosing. Dear friends, vascular, physical, and mental complications are very, very inevitable component in elderly diabetic. They are contributed by mental dysfunction, physical disability, vascular component, like all these, micro and macro, ultimately causing disability of visual loss and immobility, frailty, falls, and mental dysfunction. Friends, so what are the challenges in management of diabetes in an elderly population? They are all complexed by coexisting geriatric syndromes. We all know about what are the geriatric syndromes. I will reveal that. Incidence and progression of diabetes and its complications is very enormous in elderly. And then facility and setting and taking the preparation. These are the major challenges which are going to make ourselves to look at the elderly diabetic in a different way than a young diabetic. One is inevitable component of delirium and progressive cognitive decline. What does that happen? The people will become, when they are delirious or decline in cognitive function, they don't take meal in time. The refusal of glucose monitoring, they refuse. Why should I get checked? Why should I frequently meet a doctor? Why should I adjust my treatment? They refuse medications and injections. This will happen because of the ingrowing delirium and cognitive dysfunction. And what is the remedy? Simplify medication regimen. Then regular diet. We have to give attention to that. Educate the family members to look into that matter. This de-intensification of the treatment, very, very important. We have to learn how to de-prescribe than escalating the prescription. The second is frailty and decreased mobility. Very, very important component. Many of them will be deconditioning, they develop pressure ulcers, requiring assistance with feeding and toileting, and they could be falls. So what do? We have to optimize the activity, assess and treat the pressure ulcers. Physical and occupational therapy is very, very important, which is not required for a younger diabetic. Depression is an inevitable component that leads on either to weight gain or a weight loss. In depression, both can happen. And refusal of activities and glucose monitoring happens from the patient side. So we need to understand and give psychological counseling and assess and treat depression. Skin infections, food problems, non-healing ulcers, they're all going to consequently lead to hyperglycemia, impaired food intake, and impaired mobility. We need to escalate the treatment there. Friends, one simple question. Generally, we all look at tight glycemic control to have a better outcome of diabetes management in terms of micro and macrovascular complications. It is right for younger diabetics. But is it same? Does it hold good for elderly? The answer is big no. You look at the Wikipedias, it clearly demonstrated the better outcomes of preferably microvascular, also to some extent macrovascular complications when you reduce the A1C levels to near normal targets. But what happened when you looked at the Accord trial, it clearly made a statement, trying to achieve a tight glycemic control in elderly is a foolish thing to do because it does not improve the quality of life. Only we will be happy The patient will be happy, our number has come down. But he is having a impaired quality of life with repeated hypoglycemias. And higher risk of hypoglycemia and falls and frailty. That means we have to look at them in a different manner than a general approach to treating a general diabetic. I'll tell you, this is a very, very important slide. As we age every year from age of 60 onwards, dear friends, whether you want it or not, unless you are physically very active, 1.5 to 3% muscle mass loss occurs every year. That means if you are 60, by the time you reach 70, you will have lost 15 to 30% of the muscle mass. Sarcopenia creeps in whether you want or not. From 60 to 80, you will have lost minimum 30% of the muscle mass. That is very, very inevitable, and it gets doubled up in diabetic. So aging itself will produce a progressive muscle loss after 60 years to the tune of 1.5 to 3% muscle mass loss every year. So sarcopenia is a very, very important outcome due to aging. And aging also puts, as you know, the natural history of diabetes, progressive decline in beta cell function is an inevitable problem. So that has to be kept in mind. So ultimately, type 2 diabetics in elderly aged people will be different than what it is at 50 or 45 or 40. So these are the very, very important components. And there are at least sarcopenia contributes to functional impairment and increased risk of the mortality in elderly type 2 diabetics. Elderly patients of type 2 diabetes are 2 times more prone for sarcopenia than a non-diabetic counterparts. So this is very, very important. So treatment goal is to look at the level of pre-sarcopenia than once you start treating when they are sarcopenic. So we have to understand what is sarcopenia, how do we prevent that happening so that we prevent this frailty, prevent the risk of fall, prevent the complexities of the geriatric population. Now let us look at the medications and their impact on sarcopenia. Bigonides, there is no clear impact whether they are beneficial or not in terms of sarcopenia. Sulfonylureas, definitely there is a poor evidence to support. Glucoside inhibitors, no data. Thiazolidines, used with caution because as the elderly populations are vulnerable to have IHD, heart failure provision, they can have fluid retention, and they can be a problem than usefulness. The only drugs which have got a solid evidence to be weight neutral and less hypoglycemic in a sarcopenic is DP4 inhibitors. Then GLP-1 analogs and SGLT inhibitors, they are good for if you are aiming at an obese, healthy elderly diabetic who wants to lose weight. Otherwise, they are not a good choice for a sarcopenic underweight diabetic. And insulin, of course, it has its own role. Dear friends, as I mentioned, more than 50% of the diabetics are having obesity. And Indians, as we heard the debate, it is more of visceral adiposity than general obesity. So we call it as what is called sarcopenic obesity. It is not just a overall general increase in body weight. It is muscle mass is lost, and then fat mass is increasing. So there is a sarcopenia, which leads on to lack of physical activity. They interplay each other. There's a low grade of inflammation continued with uncontrolled diabetes, insulin resistance. They interplay makes a diabetic who is elderly to be differently behaving than an young fellow. There is a very, very important component that we need to understand. In elderly, the terminology of de-intensification of diabetes care is very, very important. Now, we should not keep on looking at only the numbers. I should not just say everybody should have A1C of less than 7%. We need to know all these people, we should be very, very careful in tightening the targets. So who are the people who need to have a de-escalation of treatment? One, they are not going to live for longer. They have cancer, they have severe dementia, they have a lot of too old a person, short life expectancy, low cognitive function, very demented, low functional status, patient preference. He doesn't want, don't put me on too many medication, give me to keep me symptom free. He wants that. Severe or high number of comorbidities. Too many comorbidities are there. Polypharmacy creeps in, and you are adding 4 drugs, then the patient becomes very, very worried. Long diabetes duration, vascular complications, hypoglycemic risk is very, very high, low level of reassurance, resources and support. If they are there, please relax, leave him alone. Don't worry too much about tightening the glycemic control. De-escalate, de-prescribe the antidiabetics, reduce the blood glucose monitoring at home, de-prescribe the other medications, and reduce the number of medications, and reduce the diabetes-specific assessments. Friends, de-prescribing antidiabetics in elderly type 2 diabetic is very, very important component and concept that needs to be understood. Prescribing antidiabetic medication involves stopping. De-prescribing means stopping or dose reduction or changeover. Now, stopping or reducing the dose, begin with antidiabetic which are most likely to contribute to hypoglycemia. Switch over from sulfonylurea and insulin to an anti-hyperglycemic agent than hypoglycemic agent like DP4 inhibitors or SGLT2 inhibitors. And switching to another drug with a lower risk of hypoglycemia. So these are the very, very important things like de-prescribing and changeover are to be learned as an art for individual adaptation to a given patient. Now, recommendation to reduce the risk is de-prescribing antidiabetic agent that are known to produce hypoglycemia. De-prescribing antidiabetic agent in patients experiencing a risk of adverse effects and individualizing glycemic targets. I will tell you how do we individualize, how do you categorize the elderly people. This is a lengthy algorithm. I will simplify it for you. If any of you are type 2 diabetic above 65 years, has a risk of hypoglycemia due to advancing age or tight glycemic control, measures that you have taken, or multiple comorbidities or drug interactions are there, hypo history is there repeatedly, or hypoglycemic unawareness stories are there, impaired renal functions are there, and they are on insulin or sulfonylurea, please, if that history is there and he is recurrently having hypoglycemia, please set those individuals into 3 categories. I'll tell you what are those 3 categories. If it is not, if he is healthy, tolerating the targets, please continue your anti-hyperglycemic treatment, whatever you are doing very well. At any time of this thing, they get into this, please de-escalate the treatment. So recommended de-prescribing is reduce the dose, switch to another agent, reduce the dose of the other drugs if required. So monitor daily, 1 to 2 weeks, and then readjust the dose. Careful assessment of the clinical, functional, and psychological factors are important. And these are very, very important slide. This will summarize my statement about what we should do in elderly people. If an elderly diabetic is healthy, do not have too many comorbidities, and functionally intact and cognitive functions are all right, please do continue your treatment, aiming the A1C to less than 7.5, fasting to less than 130, postprandial to less than 150. Okay? And they are going to live so longer. Goal is to prevent future macro and microvascular complications. It is something like what you are treating any regular diabetic. Look at the second category of elderly diabetic. You have a patient who is moderately unhealthy with few comorbidities together, multiple comorbidities, 2 or more IADLs. That is, IADL is instrumental daily activity handling, like using a telephone, managing medications, handling finance, and performing household work. They are very, very important component in a day-to-day life. If they are not capable to do it properly, please relax. Don't target to make it 7.5 or 7. You should be happy if you can maintain under 8 A1C, under 150 fasting sugar, under 180 postprandial sugar. Because they are going to have intermediate life expectancy. They have got a high treatment burden because of multiple comorbidities, and they are at a risk of hypoglycemia and fall is there. That's why you should be happy with A1C of 8, fasting of up to 150, postprandial of up to 180. The last category, which I told you earlier, they are not going to live longer. The benefits of your glycemic control is very uncertain, and high risk of hypoglycemia and falls. There you should be happy even if the A1C is up to 8.5, and fasting is up to 180, and postprandial is up to 200. Friends, this is the simple categorization that we have to do, and we have to learn to relax our targets depending on what category he falls into among these three categories. Regarding the insulin, very, very important concept that has emerged in elderly diabetic. If somebody is patient on both basal and bolus treatment, we heard the arguments. It could be one is clinician is comfortable with pre-mixed, 2/3 in the morning, 1/3 in the night if you have got a higher dose requirement. Even pre-mixed can be started as a single dose initiation. It's not that basal insulin only way to start. Basal bolus is required only when sugars are very highly fluctuating and CGM demonstrate a lot of excursions. Then you need to switch over to that. But one concept about basal insulin in elderly, the evidence says what we usually do when we initiate insulin, we initiate basal insulin at night. It has been documented now, the hypoglycemic unawareness and nocturnal hypoglycemia intensities, though you use so-called peakless insulin, they peak somewhere in the middle of the night and there are chances of worsening hypoglycemia. So the recommendation currently is change the timing of basal insulin from bedtime to morning. That is one of the concepts that has come up. Titrate the dose of basal insulin, and the goal is to maintain fasting at 90 to 150. If it is 50% of the values are higher above that, you just increase by 2 units and decrease by 2 units if it is persistently less than 80. This is one component. Then mealtime insulin also, if it is less than 10 units per meal bolus, you can de-escalate depending on the monitored values, or you can stop the mealtime insulin altogether if it is required to be less than 10 units. So in a nutshell, we should learn the habit of switching over from basal insulin from night to morning and de-escalating and stopping the bolus insulin. Management of CV risk in perimenopausal and postmenopausal women in type 2 diabetes. Again, there are so many factors which are operating. We have to look at the lifestyle modification, glycemic control. You should be a little right here unless they have got other comorbidities, manage the blood pressure, lipids very well, and use antiplatelets when they are at a postmenopausal woman at a higher risk of vascular disease. Challenges and strategies for a impatient diabetes management. Again, patient-centric individualized approach for a glycemic reduction is very, very important, which is true for every diabetic, not only for elderly. Insulin therapy, regardless of patient age, because he is under your care, you don't worry about hyperglycemia episode. Take care of the crisis, bring him out, and then de-escalate the treatment when you discharge him and send home. DPP-4 inhibitors plus low-dose basal insulin is found to be very, very suitable and tolerable for elderly diabetic with a less hypoglycemia, with a less chance of weight gain. Now, what does ADA say? What does American Geriatric Association say? What does American Association of Clinical Endocrinologists say? What does American College of Physicians say about HbA1c goal for most healthy elderly diabetic with the intact cognitive function is 7 to 7.5, 7 to 7.5. But AACE is the only organization which says you be strict and be below 6.5. But you will be at danger of putting them into hypoglycemia. But ACP also says it is all right if it is between 7 to 8. But look at here, you have to be relaxing. But if you go with AACE, they still persist that it should be 6.5. Last 2-3 slides. Management of targets and goals of therapy based on the functional levels. In elderly, we have to look at the functional levels. Is he independent? Be like what you're doing to any other diabetic. If he is partially dependent, take care of adequate nutrition, high protein intake to prevent sarcopenia. Reasonable resistance exercise by at least 2 times a week is to prevent progression of sarcopenia. So we have to have flexible glycemic control anywhere between A1C of 7 to 8, depending on the level of the supervision and risk of hypoglycemia. Maintain function, prevent any excess risk of diabetes, disabilities, lengthen the time interval of dependency. If they are totally dependent, take care of their nutrition, sufficient protein intake to prevent sarcopenia, resistance exercise as much as you can tolerate. Don't impose too much of physical activity for a fellow who cannot do it. And safe and symptomatic glycemic control. Here, you do just treat him for symptomatic therapy. Don't aim at A1C of 7 or even 8. It's all right even if it is between 8 to 9. And ensure treatment safety, control symptoms, maintain function, prevent excessive loss of lower limb performance, and maintain the quality of life. Ultimately, what is important is make him live with good quality of life as long as he's going to live for a few more months or year. Lastly, ADA 2021 management of recommendation for elderly adults with type 2 diabetes and increased risk of hypoglycemia, and medications with a low risk of hypoglycemia are preferred. Over-treatment of diabetes is common in elderly adults, and we should be careful and avoid it. De-intensify, polypharmacy should be avoided. Cost of care has to be kept in mind. I think I'll skip these slides. Among all the drugs, in terms of the comparison of current options in glycemic control in general, it is DPP-4 which has got a low chance of hypoglycemia, less glycemic variability, moderate cost, treatment complexity is low, effective with the preserved beta cell function, and it can be tolerated because it is not having significant hypoglycemia, not having significant weight gain, but it does help. Quickly running through, metformin can use GI side intolerance, B12 deficiency, we should be careful. Avoid using in patients with severe CHF to avoid lactic acidosis. SGLT inhibitors, sarcopenic, we should be careful. Otherwise, they are very good drugs for comorbid condition like IHD and potential CHF. Sulfonylureas, be careful because they can have weight gain and hypoglycemia, can cause hypoglycemia, which must be avoided because of the potential arrhythmias. And lastly, DP4 inhibitors are the important drugs which can be useful because of low hypoglycemia, can be used, dose reduction needed for few DP4 with a CKD, and use patient with CVD, there is no problem. And to conclude, DP4 inhibitors are effective treatment option either alone or in combination, but in general, categorize them into 3 categories. Learn the targets, readjustable, de-escalate the treatment whenever it is possible, and take care of the other component, keep assessing their functional ability. And there are studies to show that sitagliptin was wonderfully helpful in terms of the achievement of A1C to the targets, of relaxed targets with no significant hypoglycemia and weight gain. Friends, I thank all of you for patient listening and opportunity given to me.
Thank you, sir, for that wonderful presentation and making us learn the difference between the treatment of young adults and older adults. Thank you for that lucid presentation. I think we have time for one question, if anybody would like to ask.
Yes, sir. Can you give mic to him?
Hello. But, as per the ACE guidelines, American College of Endocrinology, they said 6.5%. Even for adults also it is 6.5%. Is there any specific reason?
No, any guideline made by any organization or guideline makers, committee, they make their the interpretations based on their data that they analyze. So all these guidelines are out of meta-analysis of the studies or data available from the data that is available. Maybe they have looked into those particular studies which have shown beneficial effect of tight glycemic control versus this. Just like UKPD's data says, tight glycemic control is good. With whatever means you achieve it, it will reduce the microvascular as well as some extent macrovascular Maybe AACE has looked at those kind of data. Whereas if you look at the ACCARD data, you will be scared to make it tight glycemic control. Possibly they have the data which they have possibly analyzed will have given them to make that kind of interpretation.
And initially, SGLT2 inhibitors, when it came, we were very reluctant to use in elderly patients. Of course, now with some studies, EMPA, more than 65 years they've used.
Yeah.
What's your clinical experience in?
There are two concepts. They are very good drugs, especially irrespective of the age. If there is a compelling indication, like if they have got a heart failure, they are inevitably good drugs. Only problem with elderly is potential risk of urinary infections, prostatism and related sepsis or stone-related sepsis or urodynamic-related sepsis. But for that, they still are good. Only thing is if there are sarcopenic patients, already there is a significant weight loss and not eating well, not taking much protein. Further weight loss could be little compounding and make them little become more frail. But it is a question mark issue. But if there are ischemic heart disease or early nephropathy related issues, these drugs will become cardiorenal protective molecules. It can be used with little caution of monitoring these sepsis.
I have some of my patients 65 and above. They are doing well. If they are
Yeah.
fit and
I do use. I don't say that to contraindicate just because they cross 65. But we have to look at the individual, and individualized selection of a drug depends on the comorbidities. So there can be combination of DP4 and SGLT inhibitors could be still wonderful in elderly people who do not have a contraindication for either of them.
Thank you.
If there are
Mike,
no
please.
questions.
The advantage of using combination is polypharmacy can be avoided, number one, number of drugs to be taken at a time. Number two, combination like the co-synergistic drug like the DP4 inhibitors and this, we all know that when you combine, give SGLT2 inhibitors alone, the chance of urinary sepsis is more. When you add DP4 inhibitors, it comes down a bit. So that advantages will be there. One is avoiding the polypharmacy or multiple drugs to be taken at a time. Number two, it could be advantageous. The disadvantage is that if you want to adjust one particular medication, you have a problem of again splitting it. Otherwise, cost also, the combination may work out little economical also and convenient for the patient.
And the dosage of two drugs, what is the maximum dosage combination?
You have to get into the dose requirement depending on the blood sugar levels and tolerability issue of that. And what is the target for the particular patient. For example, he is in category 1, you can give optimum moderate dose to start with, escalate the dose. If he is in category 2, like moderately unhealthy, 3-4 comorbidities, cognitive dysfunction is there, you should give the lighter dose. The lowest possible combination of both the combination drugs, whatever you are giving.
And maximum dose achieved, HbA1c, during that time.
Yeah.
With the combination, how much is the...
No, it is individual variation is there depending on the response to the therapy. Same dose, every individual will not respond to the similar fashion, as you know. Pharmacological response depends on your genetic behavior or the cellular response.
No, HbA1c, how much it can be reduced with combination therapy?
HbA1c can be reduced to the tune of 1.5%. So if somebody is 9, you want to achieve 7.5, it could be good to have a combination therapy. Thank you.
I think now we can close the session. Thank you, sir.
We'll just have a group photo. Thank you, sir. It was really enlightening and it was a robust talk. Yeah, moving on. I think we had Dr. Mohan Bhattacharya's talk in the morning only. So we'll move on to the next talk by Dr. Anil Virmani. That is, can type 2 diabetes be prevented? To chair the session, I'll just invite Dr. Krssdi, who's a consultant diabetologist at Diascope, and Dr. Shweta S. Over to the chairpersons.
Good evening, everyone. So we have a very interesting topic today. Can we prevent diabetes, type 2 diabetes? So as you all know, that 95% of the diabetes is of type 2 and remaining is 5% is the type 1. Now there is a good news and bad news, basically. Good news is that if we prevent the diabetes type 2, then it's a good news for the patients that they did not do the monitoring lifelong. And bad news will be definitely footfall of the diabetologists will reduce. So to cover the wonderful topic today, we have with us Dr. Anil Kumar Virmani, who's done his general medicine, and he's also have fellowships. He's also has a qualification FRSSDI. He's a consultant physician and cardiodiabetologist Diabetologist Jamshedpur, President, Clinical Cardio-Diabetes Society of India, Chairman, Indian Association of Clinical Medicine, Jharkhand, Chapter, Faculty, New Yorkshire Foundation Teaching Program, UK, Faculty, School of Diabetes of PHFI. Over to you, sir.
Thank you. Good evening to all of you, honorable chairpersons and dear friends. Let me start with a very bold statement. Diabetes is not reversible, no matter what the Babas may say. But it can go into remission. But why wait for diabetes to develop? Why we cannot prevent or delay diabetes? And that is my topic today. Now, when we talk about prevention, it's very important to realize something called primordial prevention, which we often tend to ignore. And that is right from the beginning, that is existing from the beginning. It refers to efforts in early life, pre-pregnancy, pregnancy, and infancy to reduce the risk of diabetes at a later stage. We must remember the most prominent window for epigenetic programming of diabetes is the periconceptional period and covers pregnancy, lactation, and infancy. And improving maternal health during and after pregnancy has the potential to curtail the escalating epidemic of diabetes in future generations. And that is the slogan given by Professor Sashaya, the father of GDM in India, focus on the fetus for future. And then, of course, all of you know about what is primary prevention, secondary prevention, and tertiary prevention. Now, there are certain key issues. We know diabetes has 3 states: a normal state, a pre-disease state, or a critical transition state, and a disease state. Now, do all patients of prediabetes behave the same way? Can we identify the prediabetes state? Can we stratify them according to some risk factors and whether they will develop complications? What drives the change from prediabetes to diabetes? And can we prevent this change by intervention, either pharmacological, and if yes, then to whom to give the pharmacological treatment? What is the role of biomarkers like adenopectin and other pro-inflammatory biomarkers like fetuin A and visfatin? What is the role of liver, pancreatic, and renal sinus fat? But what is more important to remember is we may not have answers to all the questions here, but yes, all patients should undergo intensive lifestyle intervention. Now, we all know prediabetes is a high-risk metabolic state for diabetes, but it does not reflect the subphenotypes of pathophysiology of type 2 diabetes, nor it is predictive of future trajectories. The A1C criteria of 5.7 to 6.4% was derived way back in 2005-2006 from NANES study. And the risk, now we know that the risk starts increasing from a fasting level of 82 to 87 and gradually progresses in a curvilinear fashion. Moreover, if you look at the gold standard postprandial figure, we know the fasting glucose lacks specificity and results in many false positive diagnoses, whereas A1C lacks sensitivity and results in many false negative diagnoses. And we must also remember that the glycemia of diabetes or prediabetes is not related directly with CVD. The twofold higher unadjusted risk of cardiovascular disease is driven mainly by abnormal levels of conventional CVD risk factors. And it is very important that A1C relation and CVD risk factors are not very prominent. So what we should do is that we must take care of the conventional risk factors. Now, the 2023 ADA standards of care have included that if you are putting a patient on statin, the risk of diabetes is there. So be very careful and monitor and enforce preventive strategies. That is very important. Now, why screen for diabetes? Epidemiologically, we know that it is highly prevalent and we can easily screen, and there is evidence that screening is beneficial. We have a high healthcare capacity system, and there is low cost of early detection and low cost of clinical detection. So it is simple and cost effective. Now, whom to screen? You must have a plan, But the most important thing is to remember opportunistic screening for undiagnosed patients, especially who are presenting to the healthcare setting for any unrelated illness, be it cough, cold, dental, gynae, whatever it is. And wherever feasible, we do go for community screening. There are two steps to do. We identify high-risk patients and then measure their blood sugar. And then as far as GDM is concerned, it is universal screening. There is no question of whom to screen and whom not to screen. And if the test is positive, then you go for further testing. We must involve the paramedical personnel such as nurses or other trained workers so that we have a very good workforce. Now, pre-diabetes, the diabetes prevention study, you all know the risk reduction was 31% by metformin, but 58% by lifestyle. Now, 86% of this group went into what is known as the diabetes prevention program outcome study, where metformin was given 850 milligram twice daily. The 15-year follow-up result was that the metformin-treated group showed significantly less development of diabetes in those who had a higher fasting plasma glucose. In those, the A1C was on the higher side, 6 to 6.4, and history of GDM. So the other societies wanted to know that if you are delaying diabetes or preventing diabetes, can we also prevent complications? Unfortunately, this failed, and there were two major meta-analyses which have shown that neither metformin nor lifestyle intervention reduced the primary outcome of preventing complications. Yes, they reduce the onset to diabetes, but not complications. So should we stop preventing diabetes? But why this results came? Possibly our standard of care has improved, and we are now extensively using lipid and hypertensive medication and etc. And the metformin and the other lifestyle interventions do not matter much as far as cardiovascular disease is concerned if you have the glycemia, lipids, and blood pressure under good control. So the importance is, and this was another study which said the same thing, importance being that get the conventional risk factors under control. That is the message I want to give you. Now, this was the Indian prevention program in Asian Indians who are highly leaner, more insulin resistant. And in this, metformin lifestyle plus metformin lifestyle alone had similar results. It didn't matter. It was around 40% risk reduction. Now, we know that lifestyle medication intervention is effective even after 20 years. Pharmacological intervention is effective, but there are adverse effects in some drugs. But if you look at the last year, pioglitazone, 81% risk reduction in the ACT-NOW study, which was very dramatic. And why? These patients reduced the risk of diabetes, although there was significant weight gain and edema, and the number needed to treat was only 18. Now, it also reduced various cardiometabolic parameters, and in the IRIS study, we know 52% reduction in progression from IG to type 2 diabetes. And now, for the first time, 2023 ADA have recommended use of pioglitazone in reducing risk of stroke or MI in people with this history in pre-diabetes and insulin resistance. First time, second drug to be approved after metformin. Now, why metformin was the first drug? Potentially provides an 8% absolute reduction in the risk of development of diabetes, and there is a total cumulative exposure is less, and it is very simple to give, it is cost effective, and it improves the quality of life, it reduces pro-inflammatory biomarkers and increases adiponectin, and given to the right patients, this is very, very cost effective. And we know this is the first drug to be used, approved by DCGI in our country. Now we are using, a lot of you are using, and I am also forced to use cinnamon and all that supplements, but it will be irrational if we do not use metformin for prevention, and we keep on. We must remember whom to give metformin. Less than 60 years, BMI of more than 35, greater degrees of fasting hyperglycemia, and women with history of GDM. And this is known as benefit-based tailored treatment. That is very important, who will improve and who will not. If you look at the guidelines, ADA says to give it to BMI more than 35, ESC and ESD says don't give it, NICE says use your own discretion. but now it is clear-cut whom to give. Now, so these are the strategies. Depending on the A1C levels from 5.7 to 6.4, you use all, and at the higher level, you use pharmacotherapy and bariatric or metabolic surgery. Now, again, in this recommendation that have been updated, they have said those who are at a higher risk, our approaches should be more intensive. That is very important. So the basic strategies for diabetes prevention are mass awareness and education programs, screening of high-risk patients, risk stratification, and lifestyle intervention, both non-pharmacological and pharmacological. And this, we remember the ADA 2022, they said you use a validated risk calculator. I'll talk about it a bit later. And they mentioned the obesity. And they said screening should begin at the age of 35 years. I don't agree with that. Look at the huge conditions they have given. Asian Indians are more prone, and all of us should be basically screened, and the age group should be cut down to 20 years because we are seeing now patients at the age of 20 years with type 2 diabetes, and then you can do it at 3 years intervals. If the report is normal, you can do it with whatever method you want. But remember, identify and treat cardiovascular disease risk factors. That is very important. Now, in children and after onset of puberty, you have to look at whether the BMI is more than 85th percentile overweight or more than 95th percentile. In those who are HIV, you screen the patients before starting antiretroviral, at the time of switching antiretroviral, and 36 months after starting or switching. Now, why screen at a younger age in Indians? I said we should start screening at the age of 20. If you look at the complications that these young people develop, the young onset diabetics, the risk of microvascular complication increases steadily over time. And this is more common in our ethnic population. Now, this is the risk calculator given by the ADA. It looks very complicated. I don't use it. Ours is Indian Diabetes Risk Score developed by Dr. Mohan et al. Just 3 questions: what is the age, family history, physical activity, and just one measurement, waist circumference, and you can calculate the total scores. Anything above 30, go and screen the patient. And for the first time, they introduced how we can delay diabetes. They said monitor, that was in 2022, monitor annually. Use a diabetes prevention program strategy, which I've just talked about. Talk about diet, exercise, whatever it is. And this diabetes prevention program should be offered to all patients by certified technology-assisted diabetes programs, and these are the persons that you involve. Now, metformin, as I said, these are the indications. I've already talked about it, but only one thing is to be remembered. If a person has used metformin for more than 5 years, do measure his vitamin B12 because he might become deficient. And most important, treatment of modifiable risk factors for cardiovascular disease. The goals are weight loss or prevention of weight gain, minimizing progression of hyperglycemia, and attention to the cardiovascular risk and associated comorbidities. No to smoking, including electronic cigarettes. Vitamin D, this randomized trial has shown that it has no effect in the onset of diabetes, that it does not lower the diabetes risk. Now, this is a very interesting novel concept that has recently come up. The Wagner et al. Have classified into 6 different clusters of prediabetes, just like there are clusters in diabetes, validated in the Whitehall-2 study. Now, if you look at, and this was based basically on OGTT, MRI, fat distribution, liver fat content, etc. Now, 1, 2, and 4 are basically healthy. 4 is obese but metabolically healthy. 3, 5, and 6 are high-risk cases. 3 is insulin secretion is high. In 5, there's a high liver fat, and both have a lot of cardiovascular and neuropathy complications. Cluster 6 is a bit different. It has high visceral fat and high renal sinus fat, but the progression to diabetes is low. So what does this indicate? There are 2 types of dual sort of risk of complications. Like one patients who develop diabetes and have complications, the others who do not progress to diabetes but still have complications. That is the metabolic heterogeneity, and some potential therapeutic applications are there. I'll just take 2 minutes more, with your permission.
Please go ahead.
Okay. So what are therapeutic implications? We know 1, 2, and 4, just simple lifestyle modification. but 3 and 5, we must enforce very intensive lifestyle modification. Cluster 6 does not progress to diabetes, so maybe metformin may not be needed, but at least lifestyle intervention is important because it progresses to various complications. So the drugs, metformin has been approved in cluster 3 and 5. Role in cluster 6 is doubtful. As I said, they don't progress to diabetes. Off-label, but now paliquetosone has again been recommended in 2023 because of the severe reduction that has been proved in clusters 3, 5, and 6. And we are now getting emerging evidence with saroglitazole. Off-label SGLT2 in 3, 5, and 6 because they can reduce the fat and prevent cardiorenal complications. But remember, when you use any off-label drug, there should be judicious selection of patient, no contraindication, shared decision-making, education of patient, and pharmacovigilance. To wrap up, awareness and education right from the schools, right from nursery level. There is no sense in educating a crowd like this and asking them to go for lifestyle intervention. We should start from the school level. Screen for prediabetes, assess individual risk factors. Not all patients of prediabetes behave similarly. We must remember this fact. Intensive lifestyle modification is the major pillar. Clustering of diabetes, which I just talked about, is a very novel and emerging. We know the role of metformin in younger, more obese, more hyperglycemic, history of GTM, and now cluster 3 and 5. Looking beyond guidelines, the use of PIO and SGLT2 can be of immense benefit in 3, 5, and 6. Now, I have talked about type 2, just one slide on type 1. Can we delay type 1? Earlier we thought no. Now, this is the biggest breakthrough in 2023 when teplizumab was introduced and said it can delay type 1 diabetes by 2 years. But my dear friends, it is a 14-day course of IV infusion costing a whopping $200,000. Is it worth delaying type 1 diabetes for 2 years for $200,000? I don't think so. So the best investment we will ever make is make in yourself. Exercise daily, sleep well, reduce salt intake, and maintain a healthy eating habit. Thank you.
Thank you, sir. Thank you for a wonderful presentation, sir. And I think this is a very important topic as of now, prevention of type 2 diabetes mellitus. And screening a patient at the pre-diabetic stage has become a success, if at all we screen a patient at pre-diabetic stage. And also counseling them not to go to the diabetic stage is another very important factor. I think every diabetologist should start being creative in how to tell them regarding, if at all we think diabetes is inevitable, then prevention becomes a myth. So if we counsel the patients regarding diabetes can be prevented, including the complications, if we start treating them at pre-diabetes stage through a comprehensive healthcare, as you rightly said, I think primordial prevention of having interventions at the school stage is also very important. Thank you for a wonderful presentation. Sir,
that is in future generations. See, primordial is in future generations. Rest I've talked about right from schools is in the present generation.
Present, yes, sir. Thank you. And if there are any questions, we can go ahead with the question.
No.
Sir, I have one question.
Yeah.
I have seen some of the patients who underwent hysterectomy, lady patients. So what happens is they will be euglycemic before the operation, and after 3-4 months, they develop pre-diabetes. You have any take on that, sir? You would like to comment on that?
They develop?
Pre-diabetes. I mean, they get into a pre-diabetes.
Post-hysterectomy.
Post-hysterectomy.
No, it may be because of the sedentariness or lack of exercise, not following lifestyle interventions. They feel that now that there's nothing else to do. So there may be various factors, but as such, post-hysterectomy is not a cause to cause pre-diabetes. There's no reason why it should cause, unless the other factors are there.
Thank you, sir.
Well, if there are no questions, I just invite the chairpersons and the speaker for the photo moment.
Nice talk, boss. Thank you. Thank you. Thank you.
Yes, sir.
Thank you.
Well, we have kept the best for the last, and the last batsman, sir, Arpandev sir, is ready. He was going to talk something about hypoglycemia.
Listening.
Just to chair the session, we have with
mute
us
this, no?
Dr. Ravi Kirti, sir. We got Kirti Shetty, who is a consultant physician at Narayana Health. We got Dr. KG Suresh, sir, consultant at Manipal. All three will be there to chair the very important session on hypoglycemia in non-diabetics. Over to the chairpersons to introduce the speaker.
Good evening, everyone. I think the last session and the most important, from the morning, I think since morning we are talking about, I think we are hearing about only hyperglycemia. I think the hypoglycemia is equally important. It has got a acute as well as a chronic complications. So today we have with us Dr. Harpande Bhattacharya to talk about the hypoglycemia. So he doesn't need introduction. So he's a well-known endocrinologist, one of the senior-most endocrinologists at Manipal Hospital. So over to Dr. Harpande Bhattacharya for further deliberation.
Thank you very much. It's very nice to be here in KRSSDI. I wonder how you listen the whole of the day. So I need to take something different so that you don't feel bored. Thanks, Dr. Shuman, Dr. Manohar for calling. And Manohar was very particular that it has to be something different. That topic. He's coming? No. Just 1 minute, we're taking the technology, sorting it out. Huh? Is there this? Anyway, I need probably not more than 15 minutes, so I'll make sure that I don't cross your time. What is that one? Wi-Fi thing? But this is a HDMI switch is not working. Is hypoglycemia this one? We are putting in your computer? Okay, fine. That's fine. It is coming fine, nicely. Yeah, fine. Good. Thank you very much. Technologically very advanced. My charger also. Thank you. Sorry for this little technical glitch. So a little bit of disclaimer that I don't have any share in the pharmaceutical company, and this is not a sponsored talk, so I can't talk. And I can see one of the clinicians' clinic. I have seen that outside the room is written for medical representative that do not discuss anything about sitagliptin and dapagliflozin. So I'm going to do the same thing. We are not talking anything about sitagliptin and dapagliflozin. And the nice of giving a topic like this so that I can talk my own and the way I wanted to talk rather than somebody dictating me what should be the slides. There is no conflict of interest other than I'm a married person. It's really, look at this one. See, managing hypoglycemia, this is Manohar's discovery. In someone who doesn't have diabetes, come on, we are in KRSSDI. So we are talking about somebody who doesn't have diabetes. So I, as a married person, always had to compromise more than 20 years now. So I thought I'll compromise a little bit and you'll not mind that. I'll present something which is managing hypoglycemia in a patient with diabetes, but not due to diabetes. Essentially, I'll tell you a case. It is difficult to a big crowd to interact, but whenever I stop you, please put your comment on what you are thinking. And in this, as I go through, I'll obviously discuss what are the points that for hypoglycemia detection we do. Exact treatment I will not do much because I think treatment is pretty easy, only the diagnosing is the challenge. So this is the problem of these ladies we'll try to solve out. She is 50, has type 1 diabetes for 30 years, a good control, compliance, satisfactory education, and on 2 or 3 injection a day with a total unit of insulin around 50 unit. Little bit of nephropathy was there, GFR was 60, and proteinuria was 1 gram. Mild background retinopathy, a little bit of sensory motor neuropathy, and probably around 5 years back she had some episode of TIA type for which on ecospidin and statin. This is the problem which we had that. For the last 2 years, she's giving recurrent life-threatening hypoglycemia. This life-threatening means completely life has gone for a toss. Anytime it can happen. Blood sugar as low as 23 documented, and several times has visited the casualty department with complete in full coma. So whatever happens, Whipple's triad will remain the main focus of our diagnosis in our lifetime, definitely subsequent generation as well, which will be low blood sugar, documentation, there should be symptom, and the improvement should be there with the symptoms of the correction. And we have different symptoms of hypoglycemia. So autonomic symptom, sweating, trembling, palpitation, anxiety, shivering. Neuroglycopenic symptom like poor concentration, lightheadedness, confusion, weakness, drowsiness, dizziness. And neuroglycemic related to coordination and articular unsteadiness. That's one of the differential diagnosis event of the alcohol intake. Blurred vision, double vision, slurred speech, and poor coordination. All of these we know, and we see patient with hypoglycemia very frequently, whoever we are managing people with the diabetes. A traditional classification remains a fasting and postprandial. This is a typical classification of our classroom teaching. I think there's a bit of a problem with this classification. If you ask me, I will be dividing hypoglycemia as hypoglycemia in people with diabetes and people without diabetes, because it becomes a bit different ball game. And then people without diabetes, you can talk about fasting and postprandial hypoglycemia. Very clear now, the alert value of hypoglycemia is 70, no more 56. That's the level 1. Serious hypoglycemia, 54, and non-severe versus severe hypoglycemia, patient has symptoms but can treat themselves. Cognitive function, if impaired, is only mild. That is non-severe. Severe means they have impaired cognitive function and they cannot take care of themselves. These things are very, very standardized. All our clinical trial, we follow this. Consequence, as you all know, just for the completion of the talk, before we sort out the problem with that lady, in the brain, coma, seizure, cognitive dysfunction, mood change, psychological effect, cardiovascular system, myocardial ischemia, arrhythmia, very, very important, and physical injuries because of the fall. That is a big problem. If you are driving or in the road, accidents, fracture because of fall, dislocation, and accidents. But ultimately, it is very, very well known that increases the mortality, not only the morbidity, and that is the reason we should be very, very careful about hypoglycemia. Two other things for completion's sake. One is a dawn phenomenon. Dawn phenomenon is that slowly increasing blood sugar in the early morning because of growth hormone secretion. Another is Somogy effect, which is hyperglycemia as a reaction to hypoglycemia because of the adrenergic response. So in the graphical term, it will look like this. The sugar will come down in the Somogy and then it will go up, but dawn phenomenon slowly rising, and main differentiating point remains in the checking a blood sugar in the early mornings around 2 or 3 o'clock. Okay, with this, let's come to this lady. You remember, type 1 diabetes for 30 years, good control, a little bit of complication as expected for 30 years of diabetes, but recurrent, life-threatening hypoglycemia. Two situations, probably Manohar wanted me to talk, which will not be applicable to the lady, and we get always very excited. One of them is insulinoma. It's a very rare condition, but we do see new cases of insulinoma probably last 21 years. I'm in Manipal, probably around 5 I have seen till now. So it's uncommon, but a very interesting condition. It's an autonomous insulin secretion, either a autonomous neoplasm, benign usually, which we'll call insulinoma, but is a hyperplasia, will cause an acidoblastosis. After the symptom, we needed very clearly, we need a test of prolonged supervised fast. Prolonged means 48 to 72 hours. Supervised means it has to be in the hospital. And fasting means you are not going to give any calories. Only will allow three things: water, salt, lime. Lime is just to prevent the nausea. When you find hypoglycemia, take a blood sample for insulin C-peptide, that's confirmation of the diagnosis, then you localize, then surgery, unless proved otherwise. And the second diagnosis, which again will not be applicable, but for the completion of hypoglycemia, is a Hirata syndrome. It's a Japanese scientist described because of insulin antibody. And a disproportionate release of the insulin at odd time make them very hypoglycemia. One of the diagnostic factors is the insulin level will be very, very high. Say 500,000 like that. So you know this is Hirata syndrome, this is not insulinoma. And usual cutoff is 3-figure. Any insulin level, if it is more than 100, is likely is Hirata syndrome. And this is a typical test, a simple test. Your biochemist can help, you and me probably can't do, we are clinician, is a peak precipitation test, polyethylene glycol. So you put the serum, take the insulin level, run the serum to polyethylene glycol, and then check, you see the 50% drop, you know this is the diagnosis of Hirata syndrome. We need to find out a cause. Steroid is the treatment of choice. But these are the two diagnoses we will keep aside, which will not applicable to our patient, because this lady has type 1 diabetes. So whenever we see a diabetes, we need to go through about cause, find the management, what exactly happened, and so on, so you know. So common cause will be a mismatch with the diet, and probably commonest cause. But we need to rule out about hypothyroidism, hypocortisolism, significant nephropathy, very fault GFR, and autonomic neuropathy, so-called DAN-MAN. So these ladies, hypoglycemia has no relation with the meal. You can't make out a fasting or postprandial or insulin level. There is no change in the diet. It could happen any time of the day. Symptoms subsequently not very good. That you know that recurrent hypoglycemia adrenergic symptom goes up. And HbA1c, previously around 8%, now it has gone to even up to 13%. So it is really a distressing situation. So we are trying to investigate. A little bit of anemia was there, not very significant. Normal liver function, no feature of infection. Thyroid function was normal. A short synectin test done to rule out hypocortisolism, which showed a normal cortisol result. So whatever the common causes we see, hypoglycemia in somebody like this, in people with diabetes is not applicable. So what treatment we have done? We have reduced the dose of insulin. We have tried different regimen. It used to happen that whenever this lady comes to the OPD and everybody wants to show up, give it to somebody else, whether registered C, other consultancy, just don't see me, because nobody can sort out the problem. We're thinking whether this lady got psyche or not. Hypoglycemia remained the same. HbA1c keep on worsening. From around 8% to 12% it has come on. We have gone through the diabetes education again, whether anything is happening or not. We know in type 1 diabetes, eating disorder is very common. Whether we are facing this because some of the eating disorder and the detailed psychological analysis was done, it didn't show any abnormality. Then, without finding any cause, then remember that one of my senior teacher in the college used to tell that gold mine is the case note. Whenever you can't sort of start from the beginning, see everything like that. Now, I tried to search everything. I was working as registered that time. So start everything, sir, what else you can find out, because nothing is getting sorted out. Now, two factors we found it, which looked interesting. She lost 5 kg of weight in the last 3 years. So anybody with hypoglycemia, because of increased snacking, is expected to gain weight. And ESR is 85. What do you think the next step should be? Which direction are you going? I was very excited to seeing the report. These two information. Any quick comment? Cox, tuberculosis. Yeah, but that's fine. Obviously, we need to think of that, people with the diabetes, but chest X was clear. There was no other infective feature that we found it. Multiple myeloma. Yes, are very high. Very nice. I got excited. Yes, I got something for, I will be publishing a paper on this one, because that time, you know, when we were junior, we were very paranoid in publishing. So hypoglycemia, weight loss, high ESR in a patient with type 1 diabetes, malignancy associated hypoglycemia is very, very excited. So we started doing a malignancy screening. So this is what is done. On chest X-ray, it's normal. Ultrasound abdomen and the pelvis is normal. Calcium profile is normal. Serum and urine electrophoresis is normal. Fecal occult bulk is normal. Colonoscopy is normal. Barium meal follow through, all are normal. Now, where is the malignancy then? Ultrasound abdomen is normal. There is no GI disturbance. So you want to make CT scan of the pancreas to see. PET scan. This is a bit old case. At that time, PET scan was not there. Now to Manipal, before the ultrasound of the abdomen, PET scan will be done. Okay, so malabsorption test was done, showed that serum protein, ferritin, folate, and B12 was normal. Fat absorption test was normal. Think of our training period. Where was PET scan that time? And D-xylose absorption test was subnormal. Where we are leading to? Chest normal. So in a patient with a type 1 diabetes, I'm saying life-threatening hypoglycemia, weight loss, high ESR, subnormal D-xylose test, and that was the diagnosis. We did get a publication actually, because it is a very unusual case of presenting like that. Anti-endomysial, anti-glardin antibody was positive, and upper GI endoscopy, jejunal biopsy done, we showed completely flat villus atrophy. Celiac disease. So we have done the gluten-free diet and everything done, everything became wonderful. Gained 4 kg in 6 months, hypoglycemia virtually disappeared, insulin dose increased, HbA1c improved, and back to the usual self. So this is my take-home message. Hypoglycemia is most unwarranted medical condition in our clinical practice. Nobody likes it. Patients don't like, family don't like, we don't like. It's terrible experience. Etiological diagnosis is a must for the treatment, and you need for a bit of a stepwise treatment, stepwise approach, particularly taking from the history. And hypoglycemia treatment is definitely rewarding, including the sorting out of the problem, why the patient happened. Obviously, treatment itself is not that difficult unless we are facing a recurrent hypoglycemia. Thank you very much. And this is what is that supposed to be. Apparently, FIFA knew it, who is going to win. Look at that, final is France versus Argentina. That's tomorrow we are going to see. Thank you very much.
Thank you, Dr. Appandev. So, hypoglycemia in a non-diabetic is a challenging scenario we all facing these days. So, thank you, Dr. Appandev, for enlightening us about the same. If anybody has...
Yeah, definitely. And then why suddenly celiac disease at the age of 50 diagnosed presented? We can't answer that question. Maybe some precipitating factor or something was there which we still don't know.
Any more questions?
Have you ever seen any case with adenocortical insufficiency or cortisol insufficiency landing up with severe hypoglycemia causing seizures and other complications?
Usually, I've seen, but usually they will not have a severe hypoglycemia, but there were milder form of hypoglycemia, definitely symptomatic hypoglycemia. And most of the time they are associated with primary hypothyroidism as well as a polyendocrine autoimmune syndrome. So both of them together make the blood sugar a bit lower side, usually 60, 70 in that range, but not a really severe hypoglycemia.
Because there was a case of 18-year-old boy who was having frequent hypoglycemia and causing seizures, and he was evaluated in some place in Tamil Nadu. They could not come down to any diagnosis, so they had to put him on Belila. So now he's traveling back to Bangalore for further evaluation. So I would like to address.
Yeah, it will be nice to work up, definitely. Yeah. But some of them recurrent hypoglycemia is really challenging, very difficult.
He's non-diabetic. The C-peptide levels are normal.
Yeah, but thing is that you need to get a bit proper assessment. It should be a proper supervised, prolonged supervised fasting. is not from a thyroid lab or blood sugar C-peptide, because that doesn't tell much. So basically, these type of people has to be admitted in the hospital, and we need to know what we are doing very clearly, including the ward nurses. So usually what we do, we admit them and we give the dinner, and that the clock starts from there, say around 8 p.m. or 9 p.m. And they will be on fasting and supervision. Every 4 hours, we check weight, blood pressure, heart rate, and urine ketone and a glucometer sugar. Urine ketone is needed because if they are not cheating, the ketone will be positive. Okay? Yeah. You are admitting somebody in a single ward, how you are knowing they are doing?
He was evaluated in one of the diabetes hospital only. Even one of the endocrinologists also has seen, but they have not come down to any conclusion. So he's flying back to
That's
Bangalore.
okay. I'm just trying to tell the protocol we follow. So we need to check the urine ketone. Now, if the urine ketone is negative, after say 24 hours or 48 hours, and no hypoglycemia, two possibilities there. One possibility is that they're cheating, eating, that's why urine ketone is not positive. Secondly, they are really hyperinsulinemic. And if they are hyperinsulinemic, ketone will be negative, but the blood sugar will be low. And that is the main differentiating point it happens. And lot of time, we admit them and do this a prolonged supervised fast. After that, they don't come back because they realize the doctor understood the diagnosis, I'm making it. So a lot of psychological cases will be there like that. They will be telling hypoglycemia, I feel good in eating glucose, whole family get attention.
No, they have monitored his sugar. It is to drop down till 30 when they had found him unconscious and all that condition. So,
well, malignancy, although it is 18-year talking, IGF-2 induced hypoglycemia, this type of thing happened. But by the time they develop hypoglycemia, the malignancy is actually over. It is no more the occult malignancy.
So in case he comes down, is it okay if
it will be it will be nice to work up, yes.
Thank you, sir.
Cause of diabetes remission.
Insulinoma as a cause of hypoglycemia in a diabetic.
Well, in Harrison's textbook, older version, there was one case report apparently was done. So I think it will be very, very difficult. Have you seen anybody like this? Anybody has seen like this? It will be very difficult diagnosis, obviously. It will be probably much more theoretical. But anyway, it can happen. There's no doubt about that.
Thank
Initially, your tablets will go off, insulin will go off, then also low blood sugar, then you will make the insulin-glucose ratio, and the same formula will go. But I believe it will be very, very rare condition.
And pre-diabetes, we see a lot of hypoglycemia.
Yes, but that is a different reason. Pre-diabetes hypoglycemia because your glucose curve and insulin curve is desynchronized. Normally, when you eat, blood sugar go up, and at the same time, insulin will go up to get the control. And here, the insulin curve get desynchronized and it get a bit delayed. So at one point of time, you have more extra insulin, and that makes a bit postprandial hypoglycemia. And that is very, very common. I actually have that. And every day, I'm very sure that I take a fruit at around 11:30 every day. Otherwise, I don't last till 1:30. It's common, very common.
Thank you, sir. Thank you for wonderful deliberation.
Thank you. Sir, I think a group photo of the chairperson with the speaker. Please. Just wanted a small announcement to make. We'll be having a general body meeting. We'll be having a general body meeting at around 7 p.m. in the hall B. We had a last talk. Dr. Vikrant was not able to come, but since it was a sponsor talk, we thought our chairman's committee wants to conduct this talk. I just wanted to invite the chairpersons for this last talk. It will be for 10 minutes. Dr. Rajiv Lokhande and Dr. Abhijit Bojraj. If you are there. Just to fill the gap, we have our secretary, Dr. Vijay, who will be taking over.
Hello. At the outset, we would like to thank the organizers of KRS
SSDI for having given us this opportunity to chair this session, important session. Unfortunately, it has been terminated early. Inflammation in diabetes. Diabetes is a systemic disease. It is caused by insulin dysfunction and manifests as vascular disease of the vascular endothelium. The vehicle of damage in diabetes is glucose due to persistent hyperglycemia. The mediators of the damage are advanced glycation end products and reactive oxygen species. The primary pathophysiology is endothelial dysfunction, nitric oxide reduction, and which eventually leads to vascular endothelial inflammation. And this inflammation leads to a systemic disease, what we call it as diabetes. The talk today would have been about the markers to recognize these inflammatory markers. To tell us more about this part of diabetes, I hand it over to you, sir.
Yeah. Thank you, sir. Like Sir Dr. Rajesh sir was telling, basically diabetes is a systemic disease, but there are quite a lot of evidences that has been linked to inflammatory markers that could be triggering or even worsening the progression of diabetes. Since our speaker was going to be speaking on the inflammation and diabetes, unfortunate situation could not make it. I'll just run through his slides and we can make a quick wind up. So I'll not hold you for a long time. So is diabetes an inflammatory disease? So the biomarkers are the center. So what are biomarkers used for? You know, biomarkers are used for maybe early detection of disease, assessment, any kind of acute or chronic conditions, risk stratification, and selection of the therapy, and even observation of the disease progression. And looking at the sensitivity pattern and prediction and robust treatment patterns can be used using all these biomarkers that we all know we go through. It can be any kind of inflammatory or infectants also. So what are the historical perspective about inflammatory markers? Observational studies provided first evidence that there is a possible association with inflammation and diabetes. Even a century ago, the administration of high dose of sodium salicylate led to decreased glycosuria in people with suspected or definite diagnosis of diabetes. That was the first time when everyone thought there could be some inflammatory association. And larger studies were done, and the role of inflammation in diabetes revealed that hypoglycemic action was related to inhibition of serine kinase I-kappa-B kinase beta. So IKK beta, which correlates with the post-receptor action of insulin. That means some inflammatory marker is definitely acting on some pathophysiology of insulin. A landmark study then to correlate inflammation with diabetes was conducted in animal models, and it was found TNF-alpha in obesity, and particularly was mainly responsible for insulin resistance and even diabetes. Epidemiological associations of inflammation with obesity and type 2 diabetes were made when circulating concentrations of many markers like fibrinogen, CRP, IL-6, plasminogen activator, inhibitor 1, sialic acid, and white cells. All these markers, these are the markers that has been seen to have been associated with, to be elevated in conditions who are having diabetes. So the next decade, numerous studies of human and animal models provided supporting evidence, and accumulative evidence suggests that chronic activation of pro-inflammatory pathways also in the target cells of insulin action contributed to obesity, in turn insulin resistance and related metabolic disorders, including type 2 diabetes. The identification of potential pathways connecting inflammation to diabetes has produced a greater interest, and then a lot of improving risk stratification was also studied using inflammatory markers as potential indexes. So if we look at inflammation, mainly we worried that inflammation can or have a lot of role in cardiovascular or cardiometabolic disorders. So chronic inflammation and the molecular mechanisms in these cardiometabolic disorders, the markers mainly TNF-alpha, IL-1B, PF, TGF-beta, PKC, and arachidonic acid, all this basically led to the activation of the endosomal NADPH oxidase, and generation of ROS and activation of the NFKB, all leading to inflammation. And inflammation, they had shown leading to metabolic syndrome and also atherosclerosis progression. Well, also there was an association with diabetes. So not much of this pathophysiology. So it says low-grade systemic inflammation actually connects to aging and even MS and also cardiovascular disease. So there are a lot of inflammatory signals that has been seen, watched or observed in diabetes. In type 1 diabetes, the thymus on the T lymphocytes causing inflammation on pancreas. Therefore, autoimmune beta cell dysfunction was seen. In type 2 diabetes also, the inflammatory markers like the IL-1B, TNF-alpha and IL-6 was causing some kind of disruption with the pancreas, causing the beta cell apoptosis, beta cell dedifferentiation, and also decrease in beta cell mass. So that was signaling that there was a lot of inflammatory association that has been observed in the type 2 diabetes pathophysiology as well. So what is it in type 2 diabetes? Inflammation basically contributes to insulin resistance, beta cell dysfunction, and onset of type 2 diabetes. So high metabolic load as an excess calorie intake, there is a pathway leading to insulin resistance and also burden on the pancreatic beta cells causing insulin insufficiency, either both leading to type 2 diabetes. We all know inflammation is one of the main reasons that is causing microvascular complications in diabetes, hyperglycemia and hyperlipidemia, both causing oxidative stress, as Dr. Rajiv mentioned just now. Signaling cascades, and then the local activation of the pro-inflammatory cytokines causing inflammation and leading to all the microvascular complications, renal, retinal, and neural complications. So the inflammatory pathway from hyperglycemia, well, it was earlier also known because of environmental and genetic factors causing chronic low-grade inflammation, all this leading to hyperglycemia. The pathway is so robust, it's signaling a cascade of inflammatory markers, stimulation of NF, gamma B, and adipokinase, adiponectin, leptin, and also the chymokines, all this leading to stimulation of the pro-inflammatory and anti-inflammatory conditions causing to diabetic peripheral neuropathy. This is very established pathway we have seen in the peripheral neuropathy. And a lot of evidence also has been associated and proves that there is even international evidence was there and published in many journals over the decade. The biomarkers that mainly work for type 2 diabetes are the diabetic subjects. It says diabetic subjects have shown 2 to 4-fold increase in cardiovascular disease than those without diabetes. Diabetes can be prevented if detected earlier. We know this. Progression of diabetes not only causes hyperglycemia, but also micro and macrovascular. But the mechanisms which involves in all this detection and progression of diabetes, there are multiple mechanisms, including inflammation. So different mechanisms causing also associated with progression to cardiovascular complications as well. These mechanisms alter different signaling molecules in blood and other body fluids. These altered molecules offer potential biomarkers for the identification and early detection of disease progression. Identification of early biomarkers for non-communicable chronic diseases like diabetes is very important, and appropriate therapeutic strategy can be utilized because of this. Prediabetes and insulin resistance are characterized by a marked inflammatory state. Biochemical markers of acute phase reactants and inflammatory cytokines are elevated on the onset of type 2 diabetes and may even further increase with disease progression. These markers, the CRP, WBC counts, fibrinogen, all these three have been investigated as potential predictors for development of type 2 diabetes. These are the three markers which we will be regularly monitoring and regularly seeing in our patients. And also, they are one of the predictors for development of type 2 diabetes, such as even atherosclerotic risk also in community studies. So the potential markers for chronic low-grade inflammation, WBC counts, the serum cytokine markers, the IL-6, TN-alpha and IL-10, acute phase reactions, HSCRP, serum amyloid A protein and fibrinogen, immune cell markers, the increase in CD8 plus T cells and decrease in CD4 T cells and even CD19 B cells. So the highlight of this session is that the commonest markers we can pick up for chronic low-grade inflammation could be the WBC, HSCRP, and the fibrinogen, which we can generally pick up in most of our patients. So it's very basic and very simple. So prospective evidence has been linking to inflammatory markers to diabetes development. There are quite a few studies where there are linked the increase in CRP and increase in WBC leading to association of diabetes. Quite a few studies has been there. Also the TNF-alpha, IL-6 and decreased adiponectin. This was a systemic review and meta-analysis that has shown of these markers. Increased CRP risk marker in diabetes, the same thing I was going through. I'll just rush through these slides due to time concern. Well, immunoglobulin-free light chains and the free light chains as inflammatory biomarkers of diabetes also has been postulated in some studies. That's mainly triggered by some viral infection. Also the obesity and hyperglycemic status also. Changes in these free link chains also lead to inflammation causing diabetes. There are numerous medicines that we are prescribing in our patients which are mainly working on these pathways. Well, the inflammatory markers and their relations to metabolic syndrome and the type 2 diabetes, here see the cytokines basically are IL-6, IL-1B, IFNY and TNF-alpha, all this leading to beta cell failure. On the other hand, adipokines and other like the osteocalcin, all leading to insulin resistance. Metabolic syndrome is happening and other side type 2 diabetes is happening. So inflammatory markers relation is definitely established in this way with the analysis they have made. The characteristics of biomarkers of pre-diabetes, diabetes, and associated complications with these markers. So basically, there are the studies analysis has shown and their mechanism of action with the basic markers that has been mentioned all the time now, the CRP, IL-6 and the WBC, all these have shown associated to type 2 diabetes and increasing insulin resistance, while WBC was showing to have been predictive of worsening the insulin action and secondary function of type 2 diabetes and also associated with coronary artery disease. Well, these could not be our routine tests, but still these are one of the markers we should remember. Coming to hydroxychloroquine, this one molecule we would like to mention, which is we are mostly prescribing in most of the inflammatory conditions, and what is the role of this molecule in managing of diabetes. The mechanism is basically, one, it inhibits insulin degradation. It reduces inflammation, improves insulin sensitivity, and also helps in beta cell preservation. So this is what is the main mechanism of hydroxychloroquine. And these slides basically explain the different mechanisms. Well, as blood hydroxychloroquine concentration increases, insulin degradation decreases and also blood insulin level increase. That's what this chart means. Also HCQ reduces systemic inflammation and clinical pharmacodynamic studies has been established. So HCQ improves insulin sensitivity by 20% and beta cell function by 45% is what finally they conclude with this study. And preserving of beta cell function, there is a picture that has been shown, the different in before treatment and after treatment, even the beta cells, quite a good improvement that has been established. Latest international presentations also recommend usage of HCQs, and because they are having a largest clinical data on HCQ also with even real world studies. The conclusion was HCQ could be an effective and well-tolerated therapeutic option for even treatment of diabetes, type 2 diabetes. So real-life use of HCQs in diabetes uncontrolled on 2 or more OHAs with or without insulin. One study has been studied and also presented at the ADA. Conclusion was HCQs could be well-tolerated and effective treatment option for patients with type 2 diabetes, those who are uncontrolled even on OHAs 2 or more. Yes. In summary, inflammation may play a crucial role in the pathophysiology of diabetes. Patients with elevated hsCRP are at a higher risk of developing diabetes and even cardiovascular disease. Hydroxychloroquine reduces HbA1c in the range of 0.9 to 1.3% in uncontrolled diabetes. CV benefits has been seen with this oxy trial, HCQ, even in MI patients. However, careful selection of these patients has to be made. Renal safety has been established, and the risk of retinopathy after 5 years was only about 1%, and after 10 years, only 2%. So beyond non-pharmacological interventions, a limited number of anti-inflammatory agents have shown promising results for lowering ASCVD risk as well. Targeting this inflammation specifically can play a major role in treatment of management of diabetes. HCQs, due to anti-inflammatory and immunomodulatory benefits, have promising role in preventing and managing type 2 diabetes. Thank you.
Thank you, sir. And this is definitely an important point that we all need to be looking at how we are managing diabetes, and it definitely will make a difference when we're looking at global pandemic of diabetes. So any questions? Any end thoughts?
Diabetes is indeed an inflammatory disease. It is caused by persistent hyperglycemia. The glucose which enters into the cell, more than what the cell can use in glycolytic process, enters into a pathway called as aldose reductase pathway. What it does is, it reduces glucose to sorbitol, and this sorbitol remains in the cell, cannot move out of the cell, and it causes glycation of the proteins and produces advanced glycation end products, which will again lead to production of reactive oxygen species, what you mentioned as oxidative stress. So the mediators of diabetic complications are advanced glycation end products through receptors for advanced glycation end products, what are called as RAGE, and oxidative stress. And the final common pathway of diabetic damage is endothelial dysfunction, reduction of nitric oxide, and endothelial inflammation. Because it affects the endothelium of the blood vessels, it becomes a systemic disease. High CRP levels suggests that the disease has advanced a lot. And hydroxychloroquine is one drug which has shown to benefit patients with diabetes to reduce this inflammation.
Can we use it in GDM patients? Because with APLA positive and all that patients, even the rheumatologist asks them to continue. It's quite safe. So can we use it in GDM patients?
Yeah, one explanation even the rheumatologist or immunologist can explain is that even in pregnancy there is a high risk of inflammatory pathways. So at that, it has been found to be safe. HCQs has found to be safe, and they still continue using it, provided the patient is already having a chronic inflammatory state or condition.
But
For diabetes and GDM only, without any chronic condition, we're still not clear about such situations.
Just for the group photo. Well, just to fill in the gap, it's very tough. That too with a short notice. I really thank Dr. Vijay for filling in the gap of a speaker who was not able to make it up. Thank you, Dr. Vijay. So we have come to the end of the session. So I really thank all the delegates who have really waited so patiently. And also wish to mention that for all the members of Krssdi, we'll be having an annual general body meeting at 7 p.m. at the ground floor, White Petal. I'm sorry, it will be here, it seems. So we'll be having an AGM in this same hall by 7 p.m. So all the members can stay back for the AGM.